0.75 mg per kg oral steroids in tapering doses. And for the TLGLL part, we gave oral cyclophosphamide 500 mg weekly was started, and she was discharged. She came back now 10 days back for the follow-up at 3 months. Her constitutional symptoms of fever and weight loss all has been resolved. She had a weight gain of around 3 kgs, and the blood picture, the total count was 4,500. For the first time, there was a reduction in the absolute lymphocytosis, and the differential began to start resolving. And the peripheral smear showed no atypical cells this time, but unfortunately the neuropathy has not improved clinically since the food drop has already set in and since the wasting has already set in. So learning points from this case, persistent cytopenia with absolute lymphocytosis in a case of rheumatoid arthritis warrants evaluation for large granular lymphocytic leukemia. Leukemic and normal large granular lymphocytes are morphologically indistinguishable, justifying phenotypic analysis when LGL is suspected. So even in normal patients, there can be large granular lymphocytes, but if it is persistent or if it is more in number, showing a more getting towards LGLL, we should do a flow cytometry and rule out LGLL. Third learning point is a neuropathy in rheumatoid arthritis is not always rheumatoid vasculitis. We should look for other causes like TLGL also, provided if there is any hematological involvement. My questions to panelists are, how much do we need to evaluate in a patient of rheumatoid arthritis with leukopenia? And is LGL leukemia a consequence or a driver of rheumatoid arthritis? Can Felty syndrome present with this clinical picture, or is it a disease of same spectrum of that of large granular lymphocytic leukemia?
Thank you, Navin, for a wonderful presentation. I think I will ask my panelists, Dr. Meghana and Sandeep, if there is any comment on these questions.
So, any case of RA presenting with leukemia, the first approach will be going from clinical. What is the duration of RA? How has the RA been behaving? What drugs the patient is taking? So, very commonly what we see in clinics is drug-related cytopenias. Another thing is sometimes these patients of RA go on to develop associated CTD like MCTD or lupus overlap. They may have lupus, so that neutropenias, cytopenias, leukemias are another etiology, and long-standing RA, again malignancies, Felty syndrome, amyloidosis. These are the considerations you should keep when you have RA with. And CTD overlap also should be looked for, and are there any other features? Is there associated thrombocytopenia? Other cell lines, how they are?
Any comments from the audience? Yes, Yojana?
Did you review the first bone marrow slides, because response CSF was really poor.
Yes,
After 3 CSF injections, the 2,700 should have become 10,000-15,000.
Yes, ma'am.
It became only 4,300. So did you think of reviewing the first bone marrow slide after getting this?
Yes, ma'am. After getting this diagnosis, we reviewed that, which also showed a large granular lymphocyte. Yeah. And we came to know that if there was any improper staining, we could miss a large granular lymphocyte. Yeah.
Another thing is, you mentioned about peripheral neuropathy did not improve.
Yes, ma'am.
One question, do you expect it to improve on, it looks like mononeuritis multiplex,
Yes, ma'am.
actually. And if yes, how much time?
Ma'am, we didn't expect it to improve because the wasting has already set in. And
So the duration of this peripheral neuropathy was how much?
ma'am, 6 months.
It will improve. It may take 9 to 18 months, it will improve. Just persist with it, it will improve.
Sure.
And how often peripheral neuropathy or mononeuritis multiplex is reported in RA vasculitis?
Ma'am, RA vasculitis causing neuropathy.
Is it really reported in literature? Because I get gangrene or scleritis. Peripheral neuropathy
it is reported.
It must be extremely rare, right?
It is rare, it is reported, and nowadays it is more rare. And when we were training, it was not uncommon.
You have better treatment.
I think we'll go to another few other.
Yeah, did you test for RO52?
RO52.
So next, Sapan, and then Dr. Ved.
I wanted to ask what the mechanism of LGL is. I don't recall, because if it is continuing rheumatoid activity with B cell CCP RF leading to LGL, then wouldn't giving rituximab make sense in these patients? I'm not sure I'm asking.
Can I comment on that? I had Sir Nilesh here.
Yes, yes.
I had the same extension to what Sir said. So, LGL in rheumatoid arthritis is actually being driven by chronic autoantigen exposure. So, there are very good retrospective case series that rituximab has worked well. So, I had 4-5 questions since you have read very well. First, when do you decide this is an LGLL? Is there a particular cell count or clonality percentage? Second thing, because it was looking like rheumatoid vasculitis being driven, you have already given cyclophosphamide, which is showing improvement, which I agree. Is there a plan to give rituximab? Because that seems to be a drug which will stop the autoantigen or autoantibody proliferation, because surprisingly, even in LGL, the B cell probably overacting is driving the T cells. So that is a theory which has been coming out in some retrospective case series. And what is your long-term plan? And I totally agree with Yojana ma'am. Sometimes it will take 6 to 12 months also. So I just wanted to know what you guys are now planning to do actually.
Sir, first regarding the diagnosis, so the first line treatment is either cyclophosphamide, methotrexate or cyclosporine. They have tried only 3 agents.
It came on the first cover page of Blood, that magazine. So neuropathy is described even that time, and we had a similar case, exactly similar case, and biopsy shows a lot of infiltration in the nerve. So that probably we could not do about the biopsy.
So I think we have a lack of. Time. I'll try to summarize. It's a chronic, untreated rheumatoid vasculitic manifestation. Again, it can have multiple factors. So rheumatoid is not always rheumatoid alone. It can tag on with many other diseases as well. Thank you, Dr. Naveen. I think we have to move on. Thank you very much. The next case is going to be presented by Dr. Rizwana Naushad.
Morning everyone. My case for today is necrotizing sclerouveitis with skin ulcers and neuropathy when extraarticular disease dominates. So we have a 45-year-old woman who is an agricultural laborer with no prior non-comorbidities, who presented with a total duration of illness of 5 years. Her disease started in 2020 when she developed insidious onset pain and swelling in small joints of hands, followed by knee, elbows and shoulders, for which she used to take intermittent over-the-counter painkillers, and there is no prior DMARD exposure. In July of 2025, she developed a left leg blister, which later ulcerated to form non-healing deep painful ulcers. In September 2025, she developed redness, watering and pain in the right eye, which aggravated by eye movements and was associated with blurring of vision, for which she presented to Jipmer Ophthalmology. On examination, her general physical examination was normal except mild pallor. Vitals were stable, all peripheral pulses were palpable. Ocular examination revealed a visual acuity of 6/18 in the right eye, scleral thinning and conjunctival defect with exposed uveal tissue, as we can see on the right side figures. Irregular pupil, anterior chamber cells and keratic precipitates, and posterior synechiae formation. So a diagnosis of necrotizing sclerouveitis with impending perforation was made. Further, on cutaneous examination, she had 2 ulcers, 4/3 centimeter and 2/2 centimeter sized punched out ulcers with regular margins, floor covered with slough, pale granulation tissue and minimal purulent discharge with surrounding induration and tenderness over the left lower leg. However, there were no skin nodules or digital infarcts. Musculoskeletal examination was normal. There were no active joints, no deformities also. Systemic examination wise, respiratory examination revealed bilateral infrascapular and end inspiratory crackles. CVS per abdominal and neurological examination was normal. So, considering a non-deforming polyarthritis of 5 years with necrotizing sclerouveitis and tender non-healing deep leg ulcers in a 45-year-old woman with 5 years history, the differentials considered were rheumatoid vasculitis, ANCA-associated vasculitis, cryoglobulinemic vasculitis, and polyarteritis nodosa. On evaluation, her baseline parameters revealed an HbO of 10.5, WBC of 12,690 with 70% neutrophils, platelets of 5.2 lakhs, ESR of 89 millimeters per hour, urea creat of 40 and 1.1 respectively, AST-ALT of 3640, total protein albumin were normal, urine PCR was 0.3, VDRL was non-reactive, and her immunological investigations revealed an HSCRP of 15.3, lower limit being 3.1. ANA IIF revealed 3 plus centromere pattern. MPO-PR3 ANCA ELISA was negative. RF was 232, which is high titer positive. Anti-CCP was more than 250, again high titer positive. Anti-phospholipids, cryoglobulins, complements were negative. Further evaluation revealed a pure tone audiometry, which revealed mild sensorineural hearing loss, and nerve conduction study showing bilateral peroneal axonal motor neuropathy. A local eye swab revealed E. coli. However, her blood cultures were sterile and echo was normal. Further evaluation revealed X-ray which showed there were no erosions. However, juxtaarticular osteopenia was seen. HRCT thorax was done, which showed basal predominant traction bronchiectasis and subpleural sparing, which was suggestive of a fibrotic NSIP of around 5 to 10%. A biopsy was taken from the ulcer edge, which showed dense perivascular inflammation with fibrinoid necrosis, which were suggestive of vasculitic changes, but diagnosis was limited since it was more of a superficial biopsy. So, summary is we have a 45-year-old woman with history starting from 2020 with small and large joint symmetric non-deforming polyarthritis, followed by non-healing left leg ulcers, followed by right eye necrotizing sclerouveitis, peroneal motor axonal neuropathy, ILD, and mild SNHL, without any prior DMARD exposure. So a diagnosis of rheumatoid vasculitis was made. And our management was, we gave her culture-directed antibiotics initially for E. coli, which grew from the local eye swab, followed by pulse methyl prednisolone was given, after which she was started on oral prednisolone 1 mg per kg. We induced her with IV cyclophosphamide, 750 milligram per meter square. And our further plan is to continue monthly cyclophosphamide 6 doses. Maintenance will be further decided. Scleral patch graft is being planned by the ophthalmology team. And yearly HRCT thorax and 6 monthly PFTs. So if you are seeing the spectrum of rheumatoid vasculitis, most common involvement is cutaneous involvement in almost 90% of cases, which can present as nail fold infarcts, purpura, non-healing ulcers, digital ischemia, or pyoderma, followed by peripheral nervous system, seen in around 40% of cases, which can either be sensory polyneuropathy, motor or mixed, or mononeuritis multiplex, followed by eye, which is seen in around 16% of cases, which can be scleritis, episcleritis, peripheral ulcerative keratitis, or retinal vasculitis. All other major organ involvement is rare, among which heart being the common one. So there are no definite RCTs available yet for rheumatoid vasculitis. So this is a proposed guideline for diagnosis and management. So once a provisional diagnosis of rheumatoid vasculitis is made, we have to assess for the extent and severity of the disease and also look for the other extra-articular manifestations. So if it's a mild to moderate rheumatoid vasculitis, we can go with induction with oral glucocorticoids and oral DMARDs. But for severe cases, we have to go with IV or oral high-dose glucocorticoids with cyclophosphamide, and maintenance being methotrexate, AZA, or Lefno. If any refractory involvement is there, better to go with rituximab, or we can switch to TNF inhibitors. So learning points are ANCA-associated vasculitis and infections can mimic necrotizing disease and should be excluded early. Necrotizing sclerouveitis is rare, but is a high morbid illness. Rheumatoid vasculitis can occur without deformities or erosions. So we have to rely on clinicopathology rather than radiographic damage. ANA positivity should not be overinterpreted without any clinical overlap features. Superficial ulcer edge biopsies may show vasculitic changes but are often non-diagnostic. So my questions are, what are the common other differentials which we should consider for necrotizing sclerouveitis? And what red flags should be considered in infection rather than an autoimmune disease in sclerouveitis? And in a similar case of eye or limb-threatening RA vasculitis, when to choose cyclophosphamide versus rituximab for induction?
Thank you, Dr. Rizwan, for this presentation. I think I'll ask Dr. Meghna, our panelist, to give her comment, and then I'll open it to the audience. Dr. Meghna?
I had few questions for you. So why do you think this patient had such a florid presentation? What factors predisposed her to develop such a florid vasculitis?
She already has high titer RF
Other than that,
and
anything?
CCP positivity. Other than that, based on the literature, the usual risk factors that are being described are male gender, longer duration illness, smoking history.
That is not there in
That
this
is not
case.
there for
no?
her.
In this case,
For her only-
was it a very florid arthritis which she had, which was inadequately treated or uncontrolled?
She gives history of arthritis, but on examination she didn't have any active joints, neither deformities.
So, do you think seronegative ANCA vasculitis could be also a possibility?
Since she had high titer RF and ACPA positivity, we considered ANCA also as one of our DDs. So we worked for it also, like PR3 and MPO ANCA was done, which was negative. ELISA was done, which was negative.
Sarcoidosis?
Sarcoidosis we didn't consider.
So, apart from whatever you discussed, obviously ANCA-associated vasculitis, RA can cause necrotizing sclerouveitis, sarcoidosis can cause, and also rarely SPA can cause, that's very rare, but it can cause, and infections, tuberculosis commonly
Since it
can
was a
cause
longer duration
necrotizing
disease,
yes. And then not pertaining to this case, but isolated ocular inflammatory disease can be a presentation.
Thank you, Dr. Meghna. Any comments? Any Dr. Sapan?
I don't think I would put ANCA as 5 years of arthritis, and even paranomic rheumatism, CCP strongly positive, RF strongly positive, you go on to have extra-articular manifestations. There is some kind of vulnerability of these patients to. The comment is it could be pyoderma gangrenosome, that is another differential in such cases, but you have done a biopsy. My question is there evidence of small molecules, especially early on if you give? Once you have an ulcer, we know that ILD ulcer and all, you'll give rituximab or cyclophosphamide. But if you use small molecules, early on with methotrexate refractory patients, for example, there is some data of small molecules tofasib in non-healing ulcers, and they do heal. But ILD, again, I'm not sure, and such kind of sclerouveitis also, I'm not sure. So, is the data on small molecules?
Dr. Ved?
I'm still confused with the diagnosis. 5 years history causing such extensive, and your ANA 3+ positive, and ulcers, and such extensive. I still feel this crowd should debate about the primary diagnosis. What about, forget about the treatment. What is the diagnosis with the 5 years history of arthritis and everything? I don't know. I think the diagnosis needs revision. Yeah, so I don't know. That's from the beginning I was thinking about some different diagnosis. I don't think it's a simple rheumatoid arthritis which can cause such an extensive lesion, and ANA positivity 3+. It cannot be ignored. And ILD, severe ILD.
Dr. Nilesh, and then.
Just adding to what sir said, I think the contemplation here is whether the diagnosis can be rheumatoid vasculitis. We have at least 3 patients now who never had arthritis, just presented with small fiber neuropathy, some large fiber neuropathy, very large skin ulcers, seen by at least 4 or 5 rheumatologists. NTCCP is more than 1,000, 2,000, 3,000. There is absolutely no documentation of arthritis anywhere. 2 of them were given at least 5 doses of cyclophosphamide. NCAs are negative. Even DADA workup was done, which was negative. Extensively evaluated for other causes. Even PET scans were done, because I also thought in my initial 5 years of practice, it cannot be RA vasculitis, because RA means you need to have deformities, you need to have high titer antibodies, and you have to have long disease duration. And out of the three, one responded to cyclophosphamide and two have responded to only rituximab. So for even 5-6 months of cyclophosphamide did not control the disease. And these are all people who are having high titer anti-CCP plus high titer anti-RF. So I think when we are seeing a lot of certain disease, the rarer presentations do come out. And I think what Sapan sir was asking, whether small molecules have any role in rheumatoid vasculitis. I think that question has remained unanswered.
Yes, I don't think we have an answer because there is no studies. Dr. Vignesh?
Yeah, if we see such a presentation in a child or an adolescent, type 1 interferonopathy we would definitely consider, because of the fact that you have deforming arthritis, RF positivity, you have interstitial lung disease, and you have ulcers with vasculitis proven. So this is the common spectrum which we see in Copa syndrome or sting-associated vasculopathy. I would definitely go for.
Think about it upfront. But having said that, I think rheumatoid, depending upon what other genetic, epigenetic changes happen, they can present with ILD upfront. Sometimes they can present with uveitis, scleritis. So it is not uncommon to have, though the traditional teaching is it has to be a chronic, untreated RA for them to develop a extra-articular manifestations. It's not always true. Over to you, sir.
Good morning, everyone. I'm a senior resident from KIMS, Bhubaneswar. Considering the possibility of NA by IFA and also rheumatoid factor anti-CCP positivity, but with 5 years of duration, non-deforming arthritis, can it be Sjogren also if possible?
The other way around, ACL70 is more likely to have ILDs. We have to, that's a differential diagnosis. That's the beauty of this case. The possibilities, whether it is rheumatoid or rheumatoid with some other autoimmune disease overlapping, or rheumatoid with some monogenic factor contributing to the presentation. So this is the areas I think we should look for. And in future, with the whole exome sequence being more and more available, yeah, as Dr. Arul Murugarajan was suggesting, doing a nail fold capillaroscopy might give us a suggestion whether there is an additional component of scleroderma or not. Dr. Sandhya, you wanted to comment? No, okay. Yes, Apan, we have 5 more minutes.
Understand is the concept of IPAF is true for every tissue. You know, we had lung dominant CVD bases, we saw ILDs and they were strongly CCP positive. They did not have arthritis. And then we subsequently called it IPAF. It was initially called lung dominant CVD. We see a lot of CNS cases, young females, strong ANA positivity, they got these demyelinating lesions or even infarcts. And the neurologist call us, we say, nahi, humko kuch nahi karna hai, false positive ANA kind of thing, you know. Of course, you rule out infection. So as Nilesh said, strongly positive CCP, nothing. Only neuropathy, some infarct somewhere, something. So I think the concept of tissue specific, you know, tissue dominant CTD, or you might just have antibody positive with the tissue involvement. We must think of these things and start collecting that data, because you never know what is actually just an organ specific autoantibody.
Yeah, as our professors used to say, no, our diseases don't read the textbook. Any other comments? Any other, Sachin?
Centromere is not only the antibody for limited systemic sclerosis, it can also happen in primary Sjogren syndrome. Can it still be rheumatoid with Sjogren's overlap? I just wanted to ask doctor whether did we look for Zika symptoms and did we do minor salivary gland biopsy for the patient?
Minor salivary was not done, sir. Schirmer's was done, which was normal, but minor salivary was not done.
I still feel it is Sjogren. I'm very convinced because you do the parotid ultrasound. Okay. Because I also, and many other things, it's a multi-system problem. And 4 years I don't think it's more.
Okay.
Should we do an ANA profile or antibodies against extractable nuclear antigen? I think that should have completed your evaluation. You have done all other things. That would have completed. If that has come totally negative, then probably we would probably take that point away. But if there is double SSA, SSB, Rho52 strongly positive, then the argument that whether it is a rheumatoid with Sjogren-like presentation could contribute to this illness. So if there are no comments, I think we will move on. Thank you, Dr. Rizwana. Now I invite Dr. Rakshi Tyagi to present her case.
Good morning, everyone. I'm Dr. Prakshi Tyagi, first-year DRNB resident from Max Super Specialty Hospital, Saket, New Delhi. The topic of my presentation is decoding vasculitis and rheumatoid arthritis. So I'm presenting a 75-year-old female resident of Delhi, known case of type 2 diabetes mellitus and hypertension for last 20 years, seropositive rheumatoid arthritis, RF and anti-CCP positive for 15 years on DMARDs. She presented to follow-up visit to OPD with following complaints: progressive tingling, numbness and weakness in right leg for 2 months associated with right foot drop, multiple painful non-healing ulcers over both shins and ankles for 2 months. She had complaints in multiple small and large joints for last 15 years and diagnosed as seropositive rheumatoid arthritis. Initially managed on methotrexate, iguratimod, and sulfasalazine. Because of poor response and high disease activity, she was shifted to anti-TNF injection etanercept, but significant improvement was not seen, so it was only for a few months. Later, she was started on tablet baricitinib after discussion with the family, following which good improvement was seen. She presented with weakness in her right foot for last 2 months as she noticed difficulty in lifting foot off the floor and dragging of foot with 2 episodes of tripping while walking. She complained of numbness and tingling over the dorsum of right foot and lateral part of the leg with history of patchy numbness over left foot intermittently. There was no history suggestive of any proximal muscle weakness or upper limb weakness, no history of acute back pain, radicular pain, bowel bladder involvement or facial anesthesia, no history of diplopia, dysphagia, dysphagia or any muscle or facial weakness, no history of headache, seizures or vomiting. Patient developed multiple painful ulcers over both the legs. Initially appeared as small, tender, erythematous nodules over the right shin, which gradually enlarged and then ulcerated, followed by similar lesions on both shins and around the ankles. The ulcers progressively became larger, deeper, and slow healing with serosanguinous discharge and severe burning pain. Some ulcers developed black eschers and surrounding skin showing lividoid discoloration. There was no response to antibiotics. There was no history of trauma, prior similar ulcers, no history of claudication pain, DVT, or varicose veins. No history of fever, decreased appetite, weight loss, or night sweats. No history suggestive of any abdominal pain, postprandial pain, cough, hemoptysis, dyspnea, or wheezing. No history of hematuria, frothy urine, flattened pain, or decreased urine output. We went ahead with examining the patient. On general examination, she had stable vitals. Musculoskeletal examination, she had a tender joint count and swollen joint count of 6, with deformities like swan neck deformity, ulnar deviation at MCP, and MCP subluxation. Systemic examination, her CNS examination, higher motor functions were normal. Cranial nerves normal, motor 1/5 power in right ankle dorsiflexion, eversion, and toe dorsiflexion. Absent ankle reflex. Sensory impaired fine touch, vibration, and position sense. Rest of the systemic examination was normal. On local examination, there was large punched out ulcers present on the shins of both legs and ankle, largest measuring around 10 to 3 centimeter with necrotic base and lividoid changes in the surrounding skin. So we had a patient with rheumatoid arthritis with articular symptoms with high disease activity, new onset mononeuritis involving right lower limb, and vasculitic skin lesion. With these, we had the following differentials in our mind: rheumatoid vasculitis, cryoglobulinemic vasculitis, antiphospholipid syndrome, polyarthritis nodosa, infection or drug-associated vasculitis, or secondary ANCA vasculitis. So we went ahead with investigating the patients. On routine investigations, she had normal blood parameters. She had raised acute phase reactant, ESR was 90 mm per hour, and CRP was 308 milligram per liter. On autoimmune worker, her rheumatoid factor and NT-CCP was strongly positive. Rest of the investigation, C3, C4, ANCA profile, ANA by IEF, CTD profile, cryoglobin screening, and APLA profile were negative. Her viral markers were negative. On nerve conduction study, she had axonal sensory motor neuropathy in the right lower limb. UFG arterial and venous Doppler of bilateral lower limbs were normal. So we made a diagnosis of rheumatoid arthritis with rheumatoid vasculitis, with articular symptoms with high disease activity, with new onset mononeuritis involving the right lower limb, and vasculitic skin lesion. Based on this diagnosis, patient was started on treatment with intravenous methylprednisolone, followed by oral steroids and monthly cyclophosphamide pulses. Patient had received 2 doses of cyclophosphamide, but there was not much improvement in her skin ulcers, and her acute phase reactants were still on a higher side. Now, when she was due for her 3rd visit, she developed sudden onset slurred speech, right-sided weakness, and facial deviation. Her MRI brain revealed acute ischemic infarcts in bilateral centrum semiovale and chronic microangiopathic changes. At this point, we were considering the possibility of CNS vasculitis and wanted to do a CSF study, but patients' attenders didn't give consent. We started considering the need for change in treatment. Should we continue on cyclophosphamide or should we consider shifting to rituximab? Then a pivotal turn came in our case. Her son, who was staying in Bangalore, came to see her deceased mother. The son revealed he was being treated for a vasculitic disorder, which he also had some skin lesions and peripheral neuropathy and was receiving monthly cyclophosphamide injections in Bangalore. This was a turning point. So we had refractory arthritis, peripheral mononeuropathy in the form of mononeuritis multiplex, possibility of CNS vasculitis, vasculitic skin lesions, and family history of vasculitis. So we started considering the possibility of a monogenic vasculitis because of the family in the history in the mother and the son. At this point of time, we sent the clinical exome sequencing of the patient, and in that report, the AD2 gene showed heterozygous mutation. So that's what helped us to clinch the diagnosis of DADA2 in this patient, though it is not very common to present at a late age. In this patient, we had a presentation of rheumatoid arthritis, and all the features were fitting into the diagnosis of rheumatoid vasculitis, but it was the presence of the son having the same symptoms and having the same kind of manifestation, which prompted us to consider the diagnosis of a genetic disease. So the key learning points from the case are lack of response to steroids and cytotoxics, presence of ischemic events and positive family history should raise suspicion for a monogenic vasculitis. DADA2 can present in late adulthood and mimic autoimmune vasculitis, especially in patients with pre-existing RA. Anti-TNF therapy is the treatment of choice and prevents vascular and neurological complications. So my questions to the panelists are, when should DADA2 be suspected in adults with vasculitic features? Should ADA2 enzyme testing or genetic screening be integrated earlier in refractory vasculitis evaluation? Can DADA2 coexist with autoimmune diseases such as rheumatoid arthritis, or does it mimic them phenotypically? Thank you.
Thank you, Dr. Prakshi. Over to you, Dr. Sandeep, for your expert comments, and then it's open to the...
Great presentation. Very small comment. Try to put the data on the slides that only give you the gist of the entire slide, and you should not read out. Try to make the telegraphic language for each of those sentences that you make. So it's important to be crisp on the slides. You should vocalize whatever you want to say. And two is your question on when should we suspect DADA2. So the earlier the onset of disease. So this was a 45-year-old lady.
75.
So that's very peculiar in that why would she carry this gene all her life and yet not have the DADA2 related thing? So probably she had rheumatoid to begin with, which would be a common manifestation. And the heterozygous nature of the ADA2 deficiency allowed the manifestations of vasculitis to sort of percolate and present at a later age. So the rheumatoid related inflammation and the late presentation of ADA2. So if she was homozygous for this, she would have an early onset. Maybe the disease, since this was heterozygous and likely pathogenic, that's what you got. So that's very important also to see what you get in your gene survey of the whole exome sequencing. If it's definitely pathogenic, likely pathogenic, of uncertain origin, so all those matter. So although this patient does have features of DADA2, and the fact that the son probably inherited another, you have not mentioned what the son had. Was he homozygous?
Heterozygous.
So he was also heterozygous. That's very peculiar. So maybe there were other genes involved which caused the heterozygosity to present as DADA2, yet he came to the rescue of the mother's diagnosis. Usually the other way around. So your other question was, what to the panelist? Can you go to the questions, please? So overlap, can it be an overlap with DADA2? More and more, now we know that the molecular level studies allow us to understand what we have taken for granted as rheumatoid vasculitis, and rheumatoid vasculitis becomes malignancy and so on and so forth. So it's underlying genetics somewhere, some epigenetic phenomenon. So why not? This could be overlap. And most of our presentations have been about features that don't come together as a solid gel, don't come into one envelope and become a single diagnosis. You have to have your mind open to these features. So this could be done if this was presenting very early on. Don't go to a 70-year-old rheumatoid vasculitis and do a DADA2. Here you had the son's history to give you an idea. Therefore, you went ahead and found a likely pathogenic scale. So can DADA2 coexist with autoimmune disease as rheumatoid, or does it mimic them phenotypically? So overall, the answer should be that only when you have very early onset of disease, you have more of vasculitic features rather than articular symptoms. And as far as the spectrum of illnesses go, try to see for patterns. Like the previous case, there was interstitial lung disease very early on, and there was vasculitis and arthritis. So the COPA syndrome, there's a family history, interferonopathies, and so they go in boxes and try to see if it fits into a pattern, and then maybe see what particular, so this could apply to a VEXA syndrome or DADA2 or COPA or whatever else, and then do whole exome sequencing, not straight away rush to any of these. I think that should be all for this case. Thank you very much.
Thank you, Dr. Sandeep. And how was the response to treatment? Did you try anti-TNF? What happened to her ulcers?
So she was planned on anti-TNF. We were planning to start anti-TNF, but during this illness, when she had stroke, that time she succumbed to death in the ICU.
Okay, that's unfortunate. So you got the diagnosis. I think the importance is to be a little more insistent with the history. I think when moment we see an arthritis, we don't bother what the other family members have it. So we generally ask whether any of your family members have arthritis. If they say no, then we no family history. So what else your family members have might be a question. Even if it is a diabetes, hypertension, noting it down might be important in we take a history. We all miss out. Not that you only missed out, we all miss out. We just ask whether anybody has a similar illness. Nobody said no, then we're done with it. So that is an importance of maybe a little more persevering with the questions. And the giveaway point in your case may be the presence of a livido, which is a little unusual in a rheumatoid vasculitis. It's usually a punched out vasculitic ulcer or a gangrene or a mononeuritis or a scleritis. That is a usual rheumatoid vasculitis presentation.
One other feature that I forgot to point out is, more importantly, before doing a DADA2 or whatever else, beginning in the 50s and 60s, most patients with rheumatoid or lupus or connective tissue diseases should have evaluation for their lipid profiles, their heart. And so the likelihood of this being a peripheral vascular disease, a stroke of non-inflammatory nature, is at least 50 times more than this being a DADA2 or a systemic vasculitis. So that's one aspect of therapy. So for example, when you said that 2 cyclophosphamide infusions, the ulcer hadn't healed, the possibility of a peripheral vascular disease, having poor ischemic and venous congestion related ulcer formation, is more than DADA2. Here you have an ADA2 to help you from the son's history. But otherwise, your focus should have been on peripheral vascular disease.
That's while investigating, we had done the Doppler scan for arterial and venous Doppler. We had done.
And maybe a CT angio if there's even a higher.
Arterial and venous Doppler we had done, and that were normal.
Questions? Any burning comments?
A very interesting case. This is not a classic ADA2 deficiency because you have the ADA2 defect in the heterozygous state. So this could be a dominant negative ADA2 defect, and this typically presents in adults. So to finalize your case, I think you need a ADA2 enzyme activity to show the activity is low, and this correlates with the physical symptoms to publish your case. I think it is very important to publish this case. Dominant negative ADA2 reports are very, very scarce from India.
Have been reported.
And I think the son, you could do a test now, at least the IDA activity, isn't it? The mother is not available.
Yeah.
Any other comments? Nilesh?
I am not really sure. We can still call this DADA2. If this was a case given to me and an exome sequencing done at 75, we don't have an ADA activity. Vignesh said that this can be a dominant negative. We don't know which. Did you mention the mutation we had? There are
I
some
have mentioned
mutations.
the mutation, but the study which have been done, that mutation is not there in that particular study which have been studied.
Yeah, so there are few mutations which
Yeah.
can present with dominant,
Dominant
negative,
negative,
heterozygous and very severe presentation.
Yes.
Generally at 75, if you are heterozygous, the DADA2 heterozygosity without having too much low ADA2 activity should have very mild features. So I'm just contemplating, if this patient had survived, will you still have given rituximab? It's just a wild thought, maybe because we have had patients who have not responded to 4 to 5 doses of cyclophosphamide also. And obviously looking at the cardiovascular risk factors like lipoprotein A, apolipo, and obviously this patient is at a very high cardiovascular morbidity. It's a very complex case, nothing to criticize, but probably we have to be careful in this context because there is a very strong context of rheumatoid vasculitis and not so strong context of DADA2, though the son may be having a more dominant negative DADA2, but I'm not sure whether we can call this an overlap or whether this is just an association.
She had received briefly course of anti-TNF for her arthritis. So that Kaushik, and there's one more, somebody.
You know, the interesting part, everybody is focused on the ADA vasculitis and said that it is, it isn't, etc., which is all fine, which is perfectly okay. It's a great discussion. The problem is if you had to, on the other side, say it's a rheumatoid vasculitis, you have a patient who was an etanercept and then baricitinib. So which patient of yours with on etanercept and baricitinib was not controlled and you allowed it to go to vasculitis? Unlikely, isn't it? So when we are talking about even a rheumatoid vasculitis who's already on biologics or on JAK-STAT inhibitors, good ones at that, why did this ulceration happen? And then if you're thinking of ADA, then why were we giving cyclophosphamide anyway? So it's this, I think we are shooting at just what is obvious on the board, but there's something much more here. Because a rheumatoid, why did the vasculitis develop? You'd controlled it very well. You were doing well on baricitinib. That's what your comment was.
Yeah, that one thing is baricitinib, whether that has brought on ADA expression, because we all know JAK inhibitors makes somebody to clot more. Whether that would have contributed to has dormant ADA to heterogeneous state to become more obvious. That's one way of thinking it, I guess. The one young gentleman, then after that Sapan and yeah.
Dr. Arvind from MMC, sir. My question is to the panelists. We have a patient with DADA2 vasculitis, a child with recurrent strokes and who failed to respond to adalimumab but responded to infliximab. So is there any such evidence that differential response to TNF inhibitors, and also that should therapeutic success be assessed by suppression of inflammation or prevention of new vascular events in DADA2 vasculitis? Thank you.
I think Vignesh could answer this question, I guess, being a pediatric rheumatologist. Right. I don't think it's a data-free zone. Always there are people who respond to one drug. We don't know that adalimumab is well preserved, potent. So there are so many issues come up. I don't think we have a clear-cut answer. And somebody else wanted to.
This patient was 75 years old. She was started on cyclo, had vasculitis. Was she on starting?
She was not.
Would have been, no?
I think one thing that we are all forgetting, we know, I think I must compliment you on, although it's a costly test and we traditionally taught not to send these in 70-year-olds. The pre-test probability was there because of the livedoid ulcer. We have to remember that. And when you have a pre-test probability of something, you thought of something and sent an AD and it turned out to be, I know it's heterozygous. I think there is something there, as Kaushik says. It's more, I would be, curious to know what patients who are non-atherosclerotic sort of these kind of strokes, even in diabetes or others, who actually have these ADA mutations as a part of what is happening to these people. I don't know if TNF helps there or not. In this patient, since she died, you would have probably done anything to try and save her. But I think there is something more to, the pre-test probability was high because of the livedoid ulcer. And livedoid ulcer, someone also once.
Again, at 70 years, even if you see a libido, then you would say that, okay, sometimes RA can do like this. We would probably not give weightage without the history of family history. So that's what I would see. So thank you very much for igniting a beautiful discussion. Thank you very much. I think we'll move on to the last case. Dr. Gunashri is going to present her case. Hopefully one more bouncer.
Good morning, everyone. I am Dr. Gunashri, second year DRNB resident from KIMS Hospitals. So, title of my presentation is Double Trouble when the vessel shadows lies in the joints. Coming to case presentation, a 54-year-old female presented in March 2025 elsewhere with complaints of low to moderate grade fever, which is of intermittent in nature. Her highest highest temperature was 102 Fahrenheit, without associated chills and rigors or malaise or generalized weakness, which was of 1 month duration. No history of weight loss or loss of appetite, or no history of any localizing symptoms. So, on evaluation by the physician, she has anemia with mild leukocytosis with a normal LFT, and ferritin was mildly elevated. And infective workup, procal was negative, and blood cultures were negative, and malarial parasite was negative. Urine culture showed candida. On further evaluation, TB quantifier and gold and MANTU were negative, and 2D echo was normal without any vegetations, and bone marrow aspiration suggestive of reactive marrow, and viral serology was negative. So they have done CT test to rule out the cause of fever. So it was showed small fibrotic band in posterior segment of right upper lobe. So in view of pyrexia of unknown origin of 1 month duration, PET-CT was done in April 2025, which showed subcentimetric lymph node in the left hilar region and the cervical region, level 2 lymph node. So cervical lymph node biopsy was done. It was suggestive of reactive lymph node without evidence of granuloma or necrosis. So as part of infective workup, Brucella IgM was done. It was found to be positive. So she was treated as having brucellosis and started on rifampicin and doxycycline along with steroids on 1st May. Around 15th May, she developed thrombocytopenia of count 1.2 lakhs to 1.75 around. Rifampicin was discontinued in view of thrombocytopenia, and doxycycline and steroid was continued. In June 2025, repeat Brucella IgM and IgG cultures bilateral shoulders and hips and knees for 2 months duration, which is associated with EMS of 15 minutes and pain improved with activity. And she has low grade fever without any localizing symptoms. So on examination, her vitals were stable. All peripheral pulsations felt without any blood pressure difference in both upper and lower limbs, and general examination was unremarkable. On musculoskeletal examination, tender and swollen joint present in right first MTP, and tenderness in bilateral hip joints with a painful restricted range of motion, and also tenderness in bilateral shoulders and knees. And bilateral fiber was positive, and there was mild restriction of forward flexion and lateral flexion, which was due to pain, and bilateral SI joint tenderness present. Rest of systemic examination was unremarkable. So on evaluation, she has anemia of HB value 9.4 with normal LFT and RFT, and elevated inflammatory markers CSR and CRP, and autoimmune workup was done in view of this low grade fever and marked elevated inflammatory markers. ANA dsDNA was negative, and serum AC levels were normal, and HLA-B27 was negative, and Brucella IgM IgG cultures were done, which were negative. So on imaging, MRI SPA protocol was done. This is the STIR sequence, STIR coronal sequence showing no active, no evidence of subarticular marrow edema. Whereas lava axial sequences showed bilateral iliac-sided erosions. You can see in the top left image, there were iliac-sided erosions in the inferior 1/3 of the bilateral sacroiliac joints. This is the ZTE sequence, axial section showing iliac-sided subarticular sclerosis in the right SI joints, along with the erosion in the right SI, iliac side on the right SI joint. So this is the T1 coronal image showing the subarticular, iliac-sided subarticular sclerosis and also erosion. So T1 sagittal section of dorsolumbar spine, it did not show any fatty corner lesions or synesmophytes. CT sagittal section showed only exaggerated kyphosis and diffuse osteopenia. So this is the C sequence of pelvis showing active enthesitis involving bilateral iliopsoas and gluteal regions. So she has chronic structural sacroiliitis along with the active enthesitis in the multiple pelvic girdle muscle insertion sites. So an ultrasound of right ankle suggestive of active synovitis of right first MTP and tenosynovitis of extensor hallucis longus. And ultrasound of left shoulder showed active enthesitis in supraspinatus tendon. In view of low-grade fever and marked elevated inflammatory markers, we have done PET-CT. So it was suggestive of active FDG uptake in the enthesial regions involving tibialis posterior insertion, plantar fascia, and bilateral greater trochanteric region. So it also showed diffuse FDG uptake in the walls of aortic arch, descending thoracic and abdominal aorta, and even in the bilateral iliac, femoral and popliteal arteries. In this image, there is uptake in the left subclavian artery, but in other sections, there is uptake in other vessels also. So as arterial phase is missed during the PET-CT, we have done CT aortogram to know the structural anatomy of the vessels. So it was showing circumferential wall thickening in the abdominal aorta and superior mesenteric artery. So CT pelvis in the bone window showed iliac-sided subarticular sclerosis involving mid and inferior one-third of right SI joints and even in the inferior one-third of left SI joint. And there was erosion, you can see in the inferior one-third of right SI joints on the iliac side. So CT aortograms, it was shown further similar wall thickening involving brachiocephalic and bilateral carotid and subclavian and iliac arteries. And there was a wall thickening involving the renal arteries left more than right, and focal severe stenosis noted at the origin of the SMA and IMA. Suggestive of large vessel vasculitis. We have done further evaluation to know the cause of the large vessel vasculitis. HLA B51 and B50 were negative, and IgG4 levels were normal. VDRL was non-reactive. So in this case, points in favor of vasculitis are low-grade fever, inflammatory arthritis, markedly elevated inflammatory markers, and PET-CT, CT aortogram suggestive of large vessel vasculitis. Whereas points in favor of spondyloarthritis in this case are inflammatory back pain and inflammatory arthritis with elevated inflammatory markers, and imaging suggestive of chronic sacroiliitis and enthesitis. So we kept the diagnosis as large vessel vasculitis with spondyloarthritis involving axial and peripheral involvement along with enthesitis. So in view of high disease activity, ASTAS of 3.6, we started her on adalimumab 40 mg subcutaneously once in 2 weeks, along with methotrexate 15 mg weekly once, along with prednisolone 15 mg. So there was complete resolution of fever and arthritis within 6 weeks with marked improvement in the inflammatory markers. Inflammatory markers have come down ESR from 83 to 18 and CRP 52 to 4 mg per liter. So learning points in this case is classical vascular features may be absent early. Imaging modalities such as PET-CT and CT angiography are vital in detecting subclinical arterial inflammation. And there may be shared inflammatory pathways. TNF-alpha and IL-17 may underline this overlap and support the use of anti-TNF therapies. Regular pulse and blood pressure assessment should be part of every inflammatory arthritis evaluation to avoid the missing occult vasculitis. So key questions to the panelists, sir, what could be the differentials for large vessel vasculitis can be considered in this case, and can this be considered true overlap of Takayasu and SPA, and how confident are we in the diagnosis of axial SPA in this case, and what phenotype of SPA is best considered here, and what are the guiding principles of treatment in large vessel vasculitis with SPA overlap?
Thank you, Dr. Gunashri, for a beautiful presentation. And for expert comments, Dr. Sandeep.
So keep this, yes, keep this. So one is the first learning point of this case is if you have a PUO, do a PET-CT as soon as you run out of ideas. So you did a PET CT much later in the evaluation of the patient when there were difficulties in finding out whether the patient had SPA and was developing fever. So it's PET CT maybe 3 or 4 months down the line after you've already treated the patient for brucellosis. And then, is
Sir,
that right?
brucellosis, it was treated outside by physicians, sir. PET CT was done outside, sir. It was showing only lymph nodes only, sir, at that time.
At that point?
At that point. They have missed the vasculitis part, sir, actually, in
They
the
had
reporting.
missed. Oh, I see. So that's how it is.
Ma'am, actually there was a uptake, ma'am, in the previous CD. Like we have reviewed the CD of the outside PET CT, ma'am. There was uptake in the subclavian and the aorta also, ma'am. But they have missed the reporting, ma'am.
Okay. The second thing is, what was...
So, I'll go to question number 3 first. How confident are we of the diagnosis of axial SPA in this case? So this patient is 54, has never had significant back pain earlier on in the 30s and 40s. She's B27 negative. The MRI is not showing osteitis or inflammation. What we have are erosions in the superior most and the inferior most aspects of the SI joints, which are also picked up on a CT scan, but there are no definite arthritis. There is enthesitis, which could be age-related. So all that makes the diagnosis of axial SPA very doubtful. The high CRP and RF, the ESR were probably related to the quote-unquote vasculitis and Takayasu arthritis. So I'm not very sure about axial SPA here because it's the wrong age, wrong sex, much later in the disease, absence of real core features. So that takes care of question number 3. I'm not going to call this SPA. I'm going to say maybe this is Takayasu arthritis. Because the possibility of a large vessel vasculitis based on what you have on the PET CT, but absence of peripheral, there were no absent peripheral pulses, there was no claudication, she's not in her 20s and 30s, she's in her 50s, makes also this large vessel vasculitis a little suspect. Maybe it's very mild Takayasu's, she's Asian origin, she's in her 50s, I'm not sure how much. So the differentials are impossible to explain because there is brachiocephalic and other involvement. So that would not be isolated aortitis. This would not be IgG4 related aortic inflammation. So large vessel Takayasu's is likely. She responded to the therapy with adalimumab. So that's also going for the diagnosis of Takayasu's. But what I would want to really summarize here is the overlap with SPA is not that important, although there are patients who've presented with this kind of scenario. So a lot of times you'll have a very subclinical minimal SPA. Had this patient been B27 positive, you'd certainly consider the possibility. But all features being negative, erosions on the superior most, inferior most aspect, no family history, that makes it a little suspect. So very awkward Takayasu's presentation. But the important point, I think, should be do a PET CT after you have done the regular tests and not found a reason for the PUO. I think that should take care of all the key questions. Is that okay?
Yes, I think. And
Questions?
Meghana, do you have any comments to add?
Yeah, as Dr. Sandeep rightly said that definitely we won't consider axial SPA. If you have to stretch it, you may call it maybe peripheral SPA. Definitely look for any psoriasis, any hidden sites of psoriasis, because predominant arthritis and enthesitis. Also, the Takayasu case series and cohorts, 20 to 30% of arthritis, some enthesitis has been reported as a part of Takayasu arthritis itself. Another thing is extracranial large vessel GCA has to be considered. Elderly female, post 50, high ESR CRP, constitutional, no claudication, no the pulse asymmetry, no bruise. So that has to be considered. I think the only feature against extracranial GCA is the distal, the renal and the superior mesenteric artery involvement and stenotic lesions also. So those are against. Otherwise, yeah, that is also a very good differential. And axial SPA, whatever case series you see, they are termed as overlap of Takayasu with SPA. You have to go back into the methodology. How are they defining the spondyloarthritis? And calling it sacroiliitis is a little odd here, because there are only erosions predominantly in the inferior aspect that in a 54-year-old lady, they can be because of stress also. So yes, the diagnosis of axial SP on MRI has moved from not on bone marrow edema alone is like not only, even if you don't have bone marrow edema, you can still diagnose axial SPA, but in the context of the structural lesions, the where are they placed, how in the middle aspect, in the cartilaginous aspect, and whether the inflammation has moved on to develop fat metaplasia, what is the extent of those erosions, is there backfill? So all those features are not there in this case.
One comment, Dr. Maganai. This patient actually presented to rheumatology unit with inflammatory back pain and enthesitis. So the coincidence is a background large vessel vasculitis which missed out. And recently there is an article saying that in large vessel vasculitis, in that cohort, they have identified 9% of spondyloarthritis underlying.
That's what I'm saying, sir. How did they diagnose?
So here, the presentation itself is inflammatory back pain and enthesitis. It's a coincidence because the PET CT, the review of the PET CT revealed that the presentation is not that, and the patient improved with anti-TNF here.
We should also be careful while calling it inflammatory back pain, because EMS of 15-20 minutes improving with activity is plus minus IBP, I would say. A definite IBP will be a significant EMS of more than 30 minutes, whether there is midnight awakening, whether there is difficulty in moving in the bed, whether there is nocturnal awakening, whether there is aggravation
sorry,
with
I have to
rest.
interrupt here because I am the treating physician here. Probably it is an error. We never ever call EMS of 20 minutes as inflammatory back pain. Okay?
No personal thing.
No, it's not personal. It's not personal because
it's at a point. That's the point.
That is very well taken. Probably it is wrongly, typed or something. And whenever you give an anti-TNF, we take so much care. Why do we give it? So
peripheral arthritis is significant, definitely.
Yeah, no. Off late we are seeing. I tell you, my first SPA with tachyarthritis in 2002. One patient came with inflammatory back pain. Earlier it was a sciatica. So during rounds, just I examined the peripheral pulses. I noticed difference in the left and right side. So in our investigative workup, she has sacroiliitis, but we did workup for vasculitis. She has a tachyarthris in the background, but presentation is not tachyarthris. That was in 2002. So these combinations
Probably, it is very well known that they can have a spa-like presentation.
Yeah, probably.
Very quick comments because we have only 5 minutes.
I just want to
Yojana, one half second.
How much treatment was given for brucellar spondyloarthritis? Because doxy and steroids were given, right?
Yes, ma'am.
No combination drugs. You have to give.
No, ma'am. Initially, rifampicin, along with rifampicin, they have given three drugs, ma'am.
3 drug combination.
After she developed thrombocytopenia, they discontinued rifampicin, ma'am. They continued only doxy.
Of 3 drugs, was it for 3 months? More
3
than 3
months,
months?
ma'am.
And steroids were continued?
No, ma'am. In 3 months, steroids were tapered, ma'am. After tapering only, she developed this arthralgia and this.
Why steroids were added to these 3 anti-brucellar drugs?
Ma'am, actually, we did not add steroids.
It was from outside.
From outside by physician.
It was from outside. So actually, because bilateral sacroiliitis can occur in brucellar spondylitis, aortoarthritis, cardiovascular involvement can also occur in, because the age for Takayasu, she is much beyond the age for Takayasu and little early for, say, GCA. Peripheral pulse absent. Other features of Takayasu are not there. So why not brucellar spondylitis with brucellar aortitis, where the treatment is going to be actually long duration and injectable steroids. When cardiovascular system is involved, you have injectable antibiotics. You have to give monoceps and gentamicin or streptomycin. The duration is longer. I mean,
so that's a
did you rule out IBD inflammatory bowel disease? Because we have an overlap of IBD, Takayasu, psoriasis overlap. So it may be associated with IBD. When you suspect spondyloarthropathy and vasculitis, mostly first type of SPA is ruled out as inflammatory bowel disease. Did you come
She did
for
not
that?
have any bowel disturbances.
Need
no
not
bowel
be that. It may be a
symptoms. Only
subclinical, even subclinical IBD. Will be.
Yeah.
You can think of that.
Thank you, Arul. So quite a few nice points came up. One is brucella itself can be the cause for spondyloarthritis presentation, and brucella rarely can cause arthritis. That's what I learned from Yojana today. And Arul has brought out possibility of an occult IBD. And one young gentleman, we'll give a chance to the young gentleman.
Sir, if it is brucella, would you expect IgG positive later on?
like seroconversion.
No, we don't know about the test validity. There are possibility, but we can keep it. But in this patient, everything as IgG is normal. It has remained normal after some time.
IgM was positive, sir.
IgM was positive. Subsequent test, even IgG is negative, which is little unusual.
Yes, sir.
Even the IgM is very low titer. It is very low.
Yeah, please.
Considering the overlap of symptoms of spondylospectrum and vasculitis, Behçet's, which is like limited to vascular Behçet's, is one possible differential, because in the early 1970s, the Behçet's were defined as spondylospectrum. And later on, now patient has some arthralgia, spondylospectrum, sacroiliitis is also documented. And later on, you can see this vasculitis there. So vascular Behçet's can be a possible diagnosis in this case that can explain both spectrum. And also the age of onset is not fitting into GCA, neither in this Takayasu, so everything is fitting. So
the presentation of vasculitis in this patient where Takayasu-like presentation in Behçet is pretty unusual. Basic and CAS vasculitis, the presentation is slightly different.
Considering the inflammatory back pain, spondylospectrum,
it's a good thought, because Behçet was originally labeled as spondyloarthritis. Yes, last comment from Ved, and we'll finish this.
I just want to say the same thing which youngster was telling. Probably it's not Takayasu, it's not SP also. Probably it is, as was discussed, differential diagnosis like brucellosis and something. Probably we are trying to fit it as a Takayasu, but probably it looks like some other differential diagnosis.
Oh, we had the same discussion here in this hall only. Dr. Amita was there. She actually disagreed. We thought it was the brucella positive triggered everything, the vasculitis and the inflammatory back pain, enthesitis. Is it all the same? So she said it's unlikely. So I think we'll all have our difference of opinions.
Yeah. I think we have a learning point. This case initiated a lot of debate. Thank you, Gunashri. And I think I invite our rapporteur, Dr. Mahabaleshwar to give us the summary points of this session.
Okay, sir. So good morning, everyone. So we had 4 cases presented today. The first case by Dr. Naveen. He presented a case of a disease duration of 15 years, a case of inflammatory arthritis, RF and anti-CSP positive, and this patient had defaulted the treatment, and he developed a neutropenia, which was treated with GCSF, lost for follow-up, developed peripheral neuropathy, and then he was found out to have absolute lymphocytosis, and then they did the flow cytometry study, and the peripheral smear also clinched the diagnosis of LGL leukemia. We had a learning point, like the role of nerve biopsy in this patient would also help us, and also the peripheral neuropathy can be a manifestation of rheumatoid arthritis, or it can be a paraneoplastic manifestation. The second case was presented by Dr. Rizwana, a disease duration of 5 years, non-erosive polyarthritis with non-healing ulcers, and she had developed necrotizing sclerouveitis with early ILD. So this case initiated a discussion about other possible differentials, because RA with uveitis without any deformities, with less duration of 5 years, we have to think of other differentials, since this patient had also ANS centromere positivity. Think of Sjogren's or any overlaps, and also Sir Vignesh sir gave input about Tourlot, COPA, to think about COPA or sting vasculopathies. If the similar clinical presentation would have been seen in a child, vasculitis, ILD manifestation with a rash, think of sting vasculopathies. And other differentials would be seronegative ANCA vasculitis and sarcoidosis in this case. The third case was a case of it was a case of resistant arthritis, DMARD failure with no improvement with etanercept, and she developed peripheral neuropathy and CVA like CVA, and family history of DADA2 vasculitis. The gene sequencing showed like the patient was positive for DADA2 vasculitis, and it was a heterogeneous mutation. So dominant negative ADA2 discussion in this we also happened, and also the learning points were lack of response to steroids and cytotoxic agents, think of differentials, importance of history taking, and this patient had livedo like lesion, so that is rare in rheumatoid arthritis, and also the role of lipid profile testing and common things like suspecting atherosclerosis, and the role of antiplatelets was discussed, and also the role of ADA enzyme testing as a marker of improvement in these patients was discussed. The last case by Dr. Gunashri, she discussed a case of pyrexia of unknown origin, and this patient had inflammatory back pain, and PET CT and CT aortogram revealed features of large vessel vasculitis. So in this patient, we have to think of other differentials like spondyloarthritis with large vessel vasculitis. Think of IBD, psoriasis as a differential. Even brucella can present with spondyloarthritis and large vessel vasculitis involvement. And also extracranial large vessel vasculitis should be kept as a differential. And Behçet's disease can be one differential in this case. So thank you all.
Thank you, Dr. Mahabaleshwar. I think we'll close this session. Thank you very much for active participation. I also thank my panelists.
Thank you, Dr. Dharmanand, for completing the session on time, well before on time actually. Now I invite the faculty for the next session on scleroderma, Sjogren's, and related CTDs. I invite Chairperson Dr. Vikas Agarwal. Please come onto the dais, sir. Panelists Dr. Vijay Prasanna, Dr. Bhuvnesh, and rapporteur Dr. Sanjaya P. Over to you, Dr. Vikas.
Very good morning to all of you. Yeah, Dr. Sandhya, please join us. So I think we received 17 abstracts for this particular session, and 4 have been selected for the oral presentation. And I can tell you that I have never seen all these such cases ever in my career till date. So these are very interesting and very challenging, difficult cases. So many things to learn. We also learned, I think we panelists were discussing amongst ourselves. So we learned a lot. And this is the elite panel of reviewers. Thanks to them, they have selected these 4 cases. So without wasting any time further, let me call the first presenter. And the first presenter is Dr. Ashwant Kumar. He will be presenting a very interesting case. Let's hear him out.
Good morning, everyone. I'm Dr. Ashwant, doing my PG residency at Madras Medical College, Chennai. So today my topic of discussion is about a patient. So that is, our topic is the hemolytic tapestry. So interweaving membrane fragility, autoimmune thrombosis, and sclerodermatous skin. So we'll be seeing about this patient who presented with multiple inflammatory conditions. So this patient is a 55-year-old female, a homemaker, coming from Tiruvannamalai, Tamil Nadu. So presented with chief complaints of yellowish discoloration of eyes for 1 year, difficulty in swallowing for 3 months, breathlessness for 1 month. History of presenting illness, Jaundice was intermittent, present for a 1 year duration. It was self-limiting. She had difficulty in swallowing for 3 months, which was non-progressive. Breathlessness, which was subacute onset for 1 month. This was non-progressive. She noted skin thickening limited to her wrists for 1 year. Progressive fatigue for 6 months. Negative history. So no hair fall, skin lesions, photosensitivity, no Zika symptoms, no arthritis, deformities, no Raynaud's, digital ulcers, gangrene, no recurrent or prolonged fever, no loss of weight, no loss of appetite, no cough, no chest pain, no palpitations, no syncope, no facial puffiness, leg swelling, abdominal swelling, no altered sensorium, seizures, no muscle weakness, neurological symptoms, no history of hematemesis or melena. A past history, she had a history of left lower limb DVT that was 2 years back, and currently she is on azenocomarol. No known comorbidities and no previous surgery history. Personal history, married, she is a non-vegetarian, normal sleep appetite, no smoking, alcohol, drug abuse or promiscuous behavior. Treatment history, actually she is on azenocomarol 2 milligrams per day and on multivitamins, calcium supplements and metformin for diabetes. Family history, she was born of third degree consanguineous marriage, and her marriage is also a third degree consanguineous marriage. She had actually 2 sons and a daughter. One son died of jaundice. Another son had a history of intermittent jaundice and anemia. Daughter also had intermittent jaundice and anemia, and she had undergone splenectomy. This is a pedigree chart which shows menstrual history. She attained menarche at 14 years of age, attained menopause at 45 years. As said earlier, 2 sons and a daughter. One son died at 10 years of age. That is due to jaundice and no history of abortions. Clinical findings. So vitals were stable. Conscious, oriented, afebrile. Pallor was there. Ictus was present. No cyanosis, clubbing, no pedal edema, no lymphadenopathy. She had microstomia and sclerodactyly. So the sclerodactyly was limited to her wrists. Systemic examination, CVS S1, S2 heard, loud P2 was there, no other added sounds, no murmur. Inspection of respiratory system, bilateral air entry was present, no added sounds. Para-abdominal examination, abdomen was soft and there was presence of hepatosplenomegaly. CNS examination, no focal neurological deficit. MSK examination, no active arthritis. So investigation wise, CBC. So hemoglobin was low, that is 10.5. Total counts normal. Platelet count was normal. Her MCV was within the normal range, 84. MCHC was elevated, that is 38. Coming to her LFT, so there was indirect hyperbilirubinemia, that is indirect bilirubin of 3.4. OTPT were normal, alkaline phosphatase normal, GGT was normal. So total proteins are also on the normal side. Urine examination, no proteinuria, pustules or casts. RFT, urea, creatinine were normal and serum electrolytes were also normal. Reticulocyte count was elevated, that is 6.5. LDH was elevated 443. Uric acid normal 4.6. Blood sugars at the on exam, that is it was normal 110. DCT was negative. ESR was 20. CRP was negative. Peripheral smear, which was done twice, revealed microcytic to normocytic anemia, anisopyclocytosis and polychromasia. Viral markers were negative. CT chest, no features of ILD. CT abdomen revealed presence of hepatosplenomegaly. Liver 15 centimeters, spleen 16 centimeters. Echo, good ejection fraction, no regional motion abnormalities, mild pulmonary hypertension, no clot or pericardial effusion. Immunology, ANAIF revealed anti-centromere positivity, 1:160 titers. ANA profile, CENPB positive. ANCA ELISA was negative. RF ACPA were negative. Prothrombotic workup, ACL beta 2 GP1. Serial titers were done, that is 3 months apart, which were elevated. The other prothrombotic, the SLAC was negative. Protein CES, factor V Leiden were negative. Serum homocysteine levels were normal. APTT was also normal. Nail fold capilloscopy demonstrated systemic sclerosis pattern. Whole exome sequencing was done. Whole exome sequencing revealed heterozygous pathogenic SLC4A1 stop gain variant. So which was suggestive of hereditary spherocytosis type 4 autosomal dominant. So treatment and follow. So she was treated with oral prednisolone, mycophenolate mofetil, azenocomarol, tadalafil and supportive measures. So on review after 3 months, she became symptomatically better. Her fatigue and tiredness improved. Hemoglobin was 11.4, total bilirubin was 2.4, indirect bilirubin reduced to 1.5. On review after 6 months, hemoglobin decreased to hemoglobin improved to 11.5, total bilirubin 2, indirect bilirubin also improved, that is it decreased to 1.2. To summarize, so this was a 55-year-old female, non-diabetes on oral hypoglycemic agents. So she had a whole history of lower limb DVT with serial titers of ACL, beta 2, GP1 positivity, other elevated levels. Also she had microstomia, sclerodactyly, pallor, jaundice, loud P2, hepatosplenomegaly. NFC revealed active SSC pattern, and ANA suggestive of systemic sclerosis. Genetic workup of the patient revealed that was suggestive of hereditary spherocytosis with strong family history. So before, this patient presented with a multitude of conditions. The reason for selecting this patient or the novelty of this case presentation lies in the fact that, so there were 3 conditions. A hematological condition, that is inherited hemolytic disorder, so hereditary spherocytosis. This hereditary spherocytosis was diagnosed based on the clinical family history and genetic workup. And the second is limited cutaneous systemic sclerosis, evidence based on the history, clinical examination, and presence and immunology based also, presence of CENP pattern, anti-centromere pattern, and NFC pattern revealing systemic sclerosis. So 2 diseases, hereditary spherocytosis, limited cutaneous systemic sclerosis, and finally APS positivity. So by evidence of history and clinical examination and presence of high titers of ACL beta 2 serial levels. The learning points. So actually chronic hemolysis in hereditary spherocytosis, this may trigger autoantibody formation, including antiphospholipid antibodies through immune cross activation and membrane antigens. So basically chronic hemolysis will lead to breakdown of various, that is will lead to breakdown into non-heme ion and also microparticles. What they do is they expose phosphatidylserine on their surface. So what happens is the beta 2 glycoproteins, mainly beta 2 glycoproteins, go and sit on these phosphatidylserines, and later the antibodies go and attack those beta 2 GP1 proteins. So this next is coexistent systemic sclerosis amplifies the autoimmune and endothelial injury pathways, heightening the thrombotic risk, phospholipid positivity. So the questions to the panelists. First one is, how might the endothelial dysfunction and microangiopathy in systemic sclerosis interact with chronic hemolysis to potentiate thrombosis?
Shant, we will take over from here. I think the questions are here. So just for the brevity of the time, so I'll, before opening the case for discussion with the audience, let me ask the panelists the first question, what he is asking. How might endothelial dysfunction and this microangiopathy in systemic sclerosis interact with chronic hemolytic condition?
So as we all know, the one of the key pathogenic mechanism in systemic sclerosis is endothelial dysfunction. And whenever you have this endothelial dysfunction, there will be an activation of, this endothelial dysfunction leads to production of many molecules like adhesion molecules, platelet aggregation, and resulting in procoagulant state. Along with this, there is also an imbalance between vasodilators and vasoconstrictors, and predominantly because of the pathogenesis, you will have a vasoconstriction of these small vessels, which again lead to increased susceptibility to coagulation. So in chronic hemolysis, as we have seen in this patient, so as he has said that this heme also causes a pro-inflammatory state, decrease in nitric oxide, and also endothelial injury with a subsequent hypercoagulable state. These two mechanisms can add on like in additive fashion to increase the susceptibility to thrombosis in this patient.
Right. And the next question is that could this hemolytic stress or erythrocyte-derived DAMPs can contribute to the pathophysiology of systemic sclerosis?
Yeah, definitely. Because this heme and also the membrane-lysed products, they act as dams which lead to trigger of toll receptors and thereby triggering the inflammation and finally the endothelial damage and the cascade what we have explained now. So one of the other mechanisms in the pathogenesis is fibrosis. Whenever you have this endothelial dysfunction, there is also a trigger for fibrosis by increasing the pro-fibrotic factors like TGF-beta. So this also leads to the fibrotic nature. That is one of the three components of pathogenesis in scleroderma.
Yeah. And could this patient be having pulmonary hypertension because of systemic sclerosis per se, or could it be contributed by a chronic hemolytic condition like hereditary spherocytosis?
This is definitely very difficult to answer because the symptomatically bedside we cannot differentiate what is the cause of pulmonary hypertension in this patient. It could be because of the underlying autoimmune disease, that is systemic sclerosis, especially you're saying a limited cutaneous systemic sclerosis. And chronic hemolytic anemias do cause pulmonary hypertension. This is very difficult to differentiate bedside. In addition, this patient do have persistent positive antiphospholipid antibodies with one episode of DVT, which can also be a risk factor for pulmonary thromboembolism. So with the family history of hemolytic anemia, two daughters and one son and two daughters, and this patient having APLA phenotype and also scleroderma along with hemolysis, really it is very difficult for us to ascertain which is the cause of pulmonary hypertension in these patients, and symptomatically also it is very difficult to differentiate.
Yeah,
Here
but I think limited systemic sclerosis phenotype is more likely to be associated with pulmonary hypertension rather than being contributed by chronic hemolytic condition per se. Now coming to the last question posed to the panelists, okay, but before that I will ask you actually, Ashant, why did you give mycophenolate to this patient?
Sir, ideally in this scenario, that is without any systemic involvement, immunosuppression is not advised, sir. But a patient with overlap of this condition, even overlap with hemolytic conditions, so
But this was not autoimmune hemolytic anemia. So you don't require actually, the reason why I'm saying so, maybe the...
so the other reason being it was actually initiated outside, sir. So we just continued it.
Yeah, no, it was for the sake of the discussion, we just wanted to know. So let me ask the same question to our elite panelist, how she is going to respond to that.
So, as sir has pointed, this is not an autoimmune hemolytic anemia, which is very much evident from the clinical history and the genetic workup you have done. There is no point in treating this patient, especially in terms of anemia, with immunosuppression. And the second is very limited cutaneous systemic sclerosis with no other major organ involvement, and I don't want to treat this patient with immunosuppression. So if at all you want to think of immunosuppression in this patient, probably you should have a certain phenotypic manifestations requiring immunosuppression, which is not evident in this patient.
Yeah, very rightly so. And just to add to the, especially because there are many fellows here, see, hereditary spherocytosis leads to splenomegaly, and any hemolytic condition which causes rapid rise in splenic size is likely to lead to autosplenectomy syndrome, and thereby these patients are much more predisposed to infections anyway. So adding an immunosuppression without much benefit being seen should be tempered with. So now I'm opening the case for discussion with the audience. No, let me start from the back rows actually. If there are any fellows, you are likely to ask any question first. So anybody from fellows?
One clarification.
Yeah,
Sir.
please.
The
Sir.
genetics testing was done later, so only after that we were able to diagnose or suspect spherocytosis.
Yeah.
Otherwise, it was considered as autoimmune hemolytic.
So for that, I will just like to mention one more thing. Your hematologist should have given you that answer that patient is having hereditary spherocytosis.
No, peripheral smear was normal, sir.
No, but they should have, because had it been hereditary spherocytosis, spherocytes would have been seen in the peripheral blood smear, and the microspherocytes would have differentiated from autoimmune hemolytic anemia.
There are reports that peripheral smear may be normal, even spherocytosis.
Yeah.
In addition, we have a strong family history also.
Yeah, so there are.
That we ask only after the genetic testing.
So anybody from the fellows? Yes. Yes, please.
Why did it respond to steroids?
Yeah, so we don't know whether it responded to steroids or not. Any Ashant, what is your take? He's asking whether it has responded to steroids, your anemia.
Sir, this was actually a mild form of hereditary spherocytosis, as evidenced by the absence of spherocytes in peripheral smear, sir.
Yeah. So anybody from the fellows?
Sir, here.
Yeah.
Sir, as it is mentioned about the pathophysiological mechanism being linked with other antibody formation as well as with systemic sclerosis and hereditary spherocytosis, and the family history suggesting that both the daughters are also having similar condition. Are the daughters evaluated for the same type of autoantibodies? If so, how many hereditary spherocytosis patients, be it female or female patients or younger or elder patients, developing these kind of autoantibodies, because they postulated that this is the first case of this kind with the three combinations.
Yeah.
Sir, actually the female, that is her daughter, we were not able to trace her. So since she's in a far off place, other state. The second person, that her son, who's also having the same anemia with jaundice and this genetic workup positive. So we have asked him to come for a review. Anyway, we'll further update.
Yeah, so I think genetic susceptibility has a role to play here, because not everybody in hereditary spherocytosis develop all these kind of manifestations.
Sir. That's
so
what I
you are absolutely right in doing a genetic testing of the family members also and looking for autoantibodies. Yes, now it's open. Sandeep.
So did this patient have hyperuricemia? She was more likely to have gout, 20, 30 times more likely to have gout rather than an autoimmune disease. That's my contention.
Sir, she did not have gout, both clinically and lab-wise also. Her uric acid was normal, sir.
That's very peculiar, because whatever else happens, the erythrocyte membrane is pretty benign. It just has lipoproteins.
Yes,
so that becoming a damp and causing this kind of autoimmune disease.
Sandeep, damps are so many things. Damps are your DNA, RNA, ATP, your even iron is a damp actually. So what is the significance of DAMPs? Just for the fellows, these are the most potent stimulus for activating your immune system. That is monocyte macrophages in circulation, and they give rise to a very potent immune response. So DAMPs are very important.
I think there's a nice point to learn here, that to look for, this clearly may look like autoimmune hemolytic anemia with overlap scleroderma SLE overlap with antiphospholipid antibody.
Yes.
So when the patient has a large spleen, liver, to look for hereditary hemolytic anemias is, I think, a take home.
Again, history is very important, because that family history should have given you a clue that this family is having some kind of a hereditary disorder. Dr. Bhojani.
Do we need to club both together is my question, because if we are talking about DAMPs giving rise to fibrosis and immune activation in scleroderma, would you rather not err towards expecting a diffuse scleroderma pattern because of your extensive DAMPs? That's one point. Can you not have a limited scleroderma? Limited scleroderma can definitely have a secondary antiphospholipid syndrome. That's known. They are associated with all sorts of things in the lungs, including chronic thromboembolism. and it just happens that this is a hereditary spherocytosis. So the beauty of the case is that these two things can can overlap each other and cause multiple complications. But do they really need to be clubbed under one umbrella is the question.
Yeah, so can you
Sir,
tell
actually, so with regards to this dams, mainly this dams has been associated with APS more compared with systemic sclerosis. Since actually there are not too much of studies or no case reports based on these combos, or we are not able to explain exactly why it is also. But dams mainly hereditary spherocytosis, that is chronic hemolytic states and antiphospholipid syndrome. It has a very good connection, sir.
Yeah, no, you are right, Ashant. Very difficult to answer this question actually, but but that is it. They are just trying to. One last question, comment. Be it very, make it short and crisp.
No, the same thing that are we seeing too much into this? Because number one, why didn't the others get it? So many had relatives in the family. And if you're talking about women, then what about the other women? And the other is, if you're thinking of a GVHD, scleroderma something, then any kind of hemolysis, any kind of trigger will have apoptosis and scleroderma. So why only them? So I think maybe we are reading too much into it, and it's us.
Sir, one point, sir, actually. In chronic hemolytic states, patients who present with a history of any thrombotic event or presence of pulmonary hypertension, we have to keep in mind antiphospholipid antibody syndrome, sir. In many of the cases of primary APS also, we should also look for an underlying hematologic condition also, sir, rather than just rheumatology conditions alone. We have to evaluate for other hematological conditions also in primary APS. So, and vice versa.
Sir, just a small quick comment. We always have this dilemma in medicine, whether you are lumpers or splitters. One is law of plurality and law of parsimony. Being clinician, we should always step back into the history. We should not miss the wood for the trees. Instead, the thing is, they can exist in isolation. So that is my thing. Instead of going into thing, because it's a clinical rheumatology conference, always, since we have so much of technology and data available, when we are little in the gray zone, just step back and always think of two diseases. Though we are taught to put it together, but now with technology, we are able to do it. So two diseases can exist. So there is a famous Italian saying also, pluralitas et positans. A patient can have as many diseases as he pleases. Thank you.
Yeah, thank you, and I thank Dr. Ashant for a very nice and interesting case. Thank you.
Thank you. Thank you.
So let me call upon the next presenter, Dr. Ritesh. I can tell you that this is the most challenging case one would ever hear in any clinical meeting. So let's hear Ritesh out.
Good morning, everyone. So we faced this case. So it's more of a management dilemma here, which we had. So I'm a senior resident from JIPMER, intervening for one, exposing the other, a clinical conundrum in a twin pregnancy. Little bit of background history. We have a 30-year-old female with hypothyroidism. She is a follow-up case of Sjogren's disease with us for 5 years. She had predominantly extraglandular manifestations in form of recurrent hypokalemic paralysis. Evaluation revealed distal RTA, focus score of 2, ENA blot showed all 3 antibodies, anti-Rho 52, Rho 60, anti-SSB, 3+ positivity done by LIA. She was on portrait supplementation. Looking at her obstetric history, she's married for last 7 years. She had one first trimester abortion in 2018. After that, she was having secondary infertility due to male factor. And so she was currently planning IVF pregnancy. So we had begun her on HCQ prophylaxis of 400 mg. So currently she underwent intracytoplasmic sperm injection and embryo transfer. Total 3 embryos were transferred, 2 got implanted, and later on at 12 weeks, DCDA twin was confirmed in the scan. Screening fetal echos were advised because she was having Sjogren's and Rho positivity. Till 19 weeks, it was normal. Fetal echo just done at 20+4 weeks outside. Showed fetus A to be normal, fetus B had sinus brady. And along with that, a large mid-muscular VSD, normal LV function, minimal pericardial effusion. She came to us 2 days later We initiated her on dexamethasone 4 mg OD. A week later, a repeat echo, it showed progression to complete heart block, and there was also biventricular dysfunction with mild pericardial effusion. In view of myocardial dysfunction, we initiated her on IVIG 2 gram per kg, given over 5 days, along with dexamethasone loading dose of 8 mg OD, followed by 4 mg OD till 29 weeks. A week later, the scan showed reversal of the 3rd degree heart block, 1:1 AV conduction, fetal heart rate of 138 beats per minute, and only intermittent 2nd degree AV block, normal biventricular function after IVIG, and dexamethasone 4 mg was continued. The repeat scans in between 22 to 26 weeks, they showed there was no complete heart block, but the repeats, when she was admitted for next dose of IVIG at 26 weeks, there was complete heart block, but the biventricular function was normal. So received the IVIG 2 gram per kg and dexamethasone 4 mg was continued. But she had a spontaneous preterm delivery, and it was a vaginal delivery at 27 weeks. So it was an extreme preterm delivery. Twin A, which was the normal twin, was extremely low birth weight, 900 grams. He suffered from the complications of prematurity, early onset neonatal sepsis. He also had severe respiratory distress syndrome. He also developed bronchopulmonary dysplasia requiring caffeine. He had a NICU stay for around 3 months, could not receive the live vaccines. Now the baby is, now she is doing fine, developmentally normal, breastfeeding actively, but the twin B, which had complete heart block, died after 2 days due to extreme prematurity and severe metabolic acidosis. He did not have other cutaneous findings of neonatal lupus. If you look at the maternal outcomes, mother developed acne. She had quite high blood sugars requiring insulin in her pregnancy. She had this premature labor leading to a lot of complications. She even developed urosepsis, POD5, which was later managed with antibiotics. So quite a lot of steroid side effects which we are seeing. So let's revisit the case. So was the heart block here completely not structural, not autoimmune, because there was a large mid-muscular VSD. So if we look at the epidemiological wise, the most common would be autoimmune heart block, around 50 to 80% of cases. The second would be a structural heart disease. So if you see here, VSD also comes here. So in what kind of VSD would cause a AV nodal block would be an inlet or a perimembranous VSD, as it is more closer to the AV node. And but here the VSD was a mid-muscular, so the chances of it causing a AV nodal block was less. And since it occurred at 20 weeks, the highest risk for the developing a heart block related to Rho, so it was labeled as so it was likely autoimmune alone. So if we look at was the dexamethasone overdosed or was IVIG given at a higher dose? So if you look at the EULAR guidelines, it stays in 3rd degree heart block. If there is an underlying poor function, definitely fluorinated glucocorticoids plus IVIG has to be given. But they don't mention about the dosing of steroid here. ACR says 4 mg. And why was 8 mg loading dose given? So if you see the BSR guidelines, they quote a study where they have given 8 mg dexamethasone, and there was transient reversal of complete heart block in 5 of the patients compared to 4 mg loading dose where they did not have this reversal of the 3rd degree AV block. And even the largest RCT which is going on in congenital heart block, even they also use the same induction dose of dexamethasone here. And if you look at the IVIG dosing, this was a study, the pitch trial, which had failed, which used 400 mg per kg IVIG. So the authors even mentioned this being the reason of failure of this IVIG. And if we see this recent paper in JACC, they had also similarly used 2 gram per kg, and none of the 9 patients who already had a prior 3rd degree heart block developed a heart block in the next pregnancy. If you look at the twin pregnancy data, it's a systematic review. Around 62 sets of twins were looked up. The concordance rate in the twins was only 27%. And even in monozygotic twins, it was like 25%. So what makes this case special is only 2 cases had been reported of IVF pregnancy-related congenital heart block. So how else could we have avoided extra steroid exposure? So sometimes we felt if we would have left this twin die, so that definitely would have been ethically incorrect, because there were chances of improvement, and later on we could have placed a pacemaker after delivery. And there would be definitely a risk of DIC because there was a dead twin inside and psychological distress carrying a dead fetus inside. And other option was whether we can selectively reduce the fetus. But that would have been more justified if it would have been a monochorionic twin, because if the twin suddenly dies, all this blood will get transferred to this and lead to acute shock in the survivor twin. So if it would have been a monochorionic pregnancy, definitely would have that would have been a better option in managing this case. And what about, so the recent studies are telling weekly fetal echo is not that sufficient because it misses and the 2nd degree AV block progresses very fast within 24 hours to a 3rd degree AV block. So what about using a simple handheld Doppler in the high-risk pregnancy? So the studies have shown FHRM did not miss any blocks, so it detected at early stage, and giving dexamethasone and IVIG at second degree heart block stage led in reversal. So should we be doing it for all of the patients? So this study recently in arthritis rheumatology showed that high titer rho positivity alone had this AV block, low titer rho positivity. So do a ELISA. If there is low titer, the chances of AV block are very less, so don't screen them very actively. So if we see, is the reversal of complete heart block possible? So only one case has been reported by a French cohort. Apart from that, there are no other cases of reversal of complete heart block possible. Only some transient reversal can be seen. The learning points here would be the conversion from normal sinus rhythm to third degree heart block happens quite fast. FHRM doing thrice per day has been shown in studies during 16 to 20 weeks in a high-risk pregnancy would definitely be more sensitive to pick up than a weekly fetal echo. Concordance of this fetal heart block is around 30% only. And complete heart block is permanent. Very rarely transient reversals to second degree blocks can be seen. And IVIG DEXA is definitely useful in myocardial dysfunction, fibrocardial elastosis, and hydrops. And risk versus benefit of steroids in pregnancy always must be weighted. Questions?
Yeah. So thank you, Ritesh, for a very challenging case. And I thank that I am not the treating physician of this lady. So the first question, madam, first of all, the questions have to go to the panelist actually. So the first question is, when is cardiac pacing indicated in neonates born with congenital complete heart block? And why was pacing not feasible in this second twin who was having a complete heart block? And he was a preterm also. Dr. Bhuvnesh?
So cardiac pacing in neonates, there are absolute indications. One is severe symptomatic bradycardia. So a child who's born with severe bradycardia, having a ventricular rate of 50, 60s, having myocardial dysfunction, heart failure. So these are absolute indications where you would not think otherwise you would do a pacing immediately in a child. The problem with this case, this child, is we are talking about a child who is weighing 800 milligrams. It's not even a kilogram. So the technical factors, I think, would be the most important in pacing this child. When I went through literature, they have done cardiac pacing in children who are weighing 1.5 kilograms and above. Less than 1.5 kilograms, the technical difficulty itself is the most important limiting factor in doing a pacing in these children. The other thing is the child is so extremely preterm that even if you do a pacing, the myocardium may not respond to the pacing. The myocardium is so underdeveloped that it may not even respond to the pacing. So it's not only a problem with the rhythm here, it is also a problem with the myocardium here that would have an extreme limitation with pacing this extremely preterm twin.
Can I add one question here from my side? If they would have used a lesser dose of dexamethasone, maybe the preterm labor may not have been initiated?
That is a very, very, very controversial thing, sir. Because we again, whenever we talk about anti-RO pregnancy, the most important challenge is diagnosing them early. Most of the times, we diagnose anti-RO pregnancies and in a stage of third degree heart block or complete heart block. It is very difficult to pick them in a stage of first or second degree heart block. The most important factor for that is you may be doing an echo today, and most of us follow a protocol of doing echoes every week. That itself is a problem because from a first degree to a complete heart block, it takes less than 24 hours. So ideally, we should be looking at them daily. But that is, the logistic problems, feasibility is a major issue over here. And once there is a third degree heart block, the role of treatment, including steroids and IVIG, is extremely limited. Reversal, as you rightly pointed out, is not reported at all. At least a complete reversal. They may have some transient reversals, but a complete reversal is almost impossible.
So let's go to the next question. What is the current evidence-based dosing strategy and indications of dexamethasone and IVIG in autoimmune congenital heart block and myocardial dysfunction?
I think most of the things were covered by you. The dosing strategy is first degree and second degree heart block, you give 4 milligrams of dexamethasone OD. And there is no particular duration to it. They say that you monitor and if possible, you gradually taper it off. Same for IVIG. IVIG, they definitely recommend at second degree. First degree, just steroid might do, but once there is a second degree heart block, definitely a role of IVIG comes into place.
So my question to you, Ritesh, is that why didn't you give it IVIG much earlier actually? Why not 4 weeks earlier, 16 weeks and repeat it at 20 weeks prophylactically?
Just to add on to that question, this particular lady, she had a first child was a abortion, miscarriage, isn't it? So what was the reason for that?
It was a first trimester abortion,
Yeah,
maybe less than
first
12
trimester,
weeks.
Okay. Let's come down to the last question. What factors contribute to the discordant outcomes in this dual chorionic fetuses?
So we can think of many factors. One is it's a DCDA twin, so obviously there are two placentas at play. So the placental factors come into play. The autoantibody expression in the placenta may be completely different. And second is, again, they are DCDA twins, so their genetic makeup itself is different. So I think those two are the major factors that come to my mind.
Yeah. Okay, with this now I open the case for discussion. Yeah, we start from the fellows. If there are any hands. Yes, Nidish.
At 20 weeks, we had this sinus brady with us. So with sinus brady, we even dared to give dexamethasone because just treating a sinus brady was a little bit in dicey. We were in a dicey situation whether to give or not. So that is the main thing, that giving even dexa was even dicey for us. So IVIG was like out of this. No, that was sinus brady. Yeah.
Any more question from the fellow side? Okay, so Dr. Dharmanand.
Great case. We had a very similar scenario where I discussed with our fetal medicine, reduced the affected fetus, and the mother and both normal fetus did not receive any immunosuppression and had a very uneventful pregnancy outcome. So that would have been much more wiser, I guess.
Actually, this was a very precious pregnancy because already the couple was not having any child.
Yeah, but the reduction will be a much better option.
So no, one
compromise.
Then it has got its own complications and problems.
I know.
Yeah. So Dr. Vinod.
I think great case. Not pertaining to this case, but I would like to caution about the high dose of dexamethasone being used. The study which was quoted, a small single study where 8 milligram of dexamethasone was used. In fact, the other study which you mentioned, which is in progress, is actually going to answer, hopefully, detrimental effect of dexamethasone, forget any beneficial effect. So that is one caution. That's why the duration of dexamethasone therapy has not been defined. It should be based on the clinical sort of, the progress of the individual case. So there also, longer you are exposing the fetus and the mother to dexamethasone, the more is going to be the...
Yeah, thank you. Yes, please.
Just want to share my experience. I had two cases. One was previous pregnancy. She suddenly developed CHP, and the patient, subsequently the baby died because of the high drops. So second pregnancy, what I have done, I have considered there is a evidence for IVIG prophylaxis. So what I have given 1 gram per kg at 12 weeks, 16, 20 and 24 weeks, and subsequently I have done the titer SSA and Rho and La. It was positive, but outcome was beneficial as a normal delivery. So I would consider that should have continued the IVIG at least 4 weekly interval. And the second, the manifestation of Rho pregnancy are varied. One more recent case which I have is the endocardial fibroelastosis, which we found there is no other cause, and which we have labeled it as because of the autoimmune, because of the Rho positivity, and we are giving IVIG 2 gram per kg to her every 4 weekly. We are expecting the outcome. She will be delivered.
Okay, great. Sapan, you want to say something? Yeah. Dr. Shanmugam, next.
I think the answer, like we all know that the first time it is 2%, then second time it becomes 18%, that those studies. What is it in the fetus which makes it from 2 to 18%? I'm aware of the paper which you quoted about the high rise in titer, high titer. I don't think that's the only thing. There is something more in the fetus which causes, so we find that, then we'll know what is it in that fetus that And once Ved sir had asked in one of the conferences the role of rituximab, if it is only the titer, you could actually reduce it by giving, in these patients, we are aware of when to give rituximab, when not to give, but you could probably lower the titer. But I think it's not just the titer, there is something more. What is it there in the fetus which increases? It probably is sensitizes the mother more than the fetus, because any fetus second time will have a more chance of getting something in the mother.
Antibody configuration matters.
No, so many factors actually play a role, right from the placental factors to the fetal factors, or the genetic makeup of the two fetuses. Yeah, Colonel Shan Mugandam, please.
Is there any technology where you can monitor, like Holter, the fetal heartbeat minute to minute from 16 weeks and have a constant input, just like a Holter? Moment it goes into second degree, we can give that. Probably it should be available.
Yes, sir. It is there, sir. They have done studies of that also, and shown handheld Doppler machine. The mother will be doing twice or thrice per day. And
no, I am talking about continuous. Okay. Continuous, just like a Holter instead of 24 hours, Holter for the baby for a week. It's possible because now we have handheld device and we have WhatsApp and connection. I think it's a good thing for patent if somebody wants to patent.
Right. So anybody from the fellows? Yes, please.
I will present it, sir. It's a nice case. The way it is, I think, in complete heart block, whenever they go for complete heart block, they go on to have cardiomyopathy as well. And most of these fetus, they do not do well, or they go into IGR, or even post-arrival, they don't do well. That's what the largest evidence so far has shown us. Maybe the early stages, it's okay, but when they go for complete heart block, or they go for IUGR in uterine, or they go for oligohydramnios, I think it's all down there in whatever we do. And most of the case cohort studies, whatever case reports reported, they have shown that most of the times nothing works, whether IVIG or steroids, nothing works. And whether this patient had recurrent RTA, I think these days RTs is an indication for immunosuppression. Maybe for the next time, and there are reports that rituximab, when given well ahead, can decrease these antibodies, and then they go on to have sometimes normal pregnancy. Maybe that can be done in the next time if she's to follow with you.
So with this, I'll just, Bojani, you can just have a short and crisp comment.
No, my question was to Bhuvanesh, not
please.
to him, and it wasn't
ask.
a comment.
Yeah. He's being paid for actually, so you can ask him.
The sinus bradycardia, where it started. So the question is related to your comment. Number one, once CHB comes in, it's almost never reversible. I just needed one expansion on that. And the second one is, when the sinus bradycardia first started, where the ECG did not show a heart block.
Yes, sir.
What other differentials would we have had anyway? Once the sinus bradycardia came in. I was just looking at the fact that could we have stepped in earlier?
I think, but sir, sinus bradys are well documented in normal pregnancies. So that doesn't really tell us anything.
At 20 weeks, 16 weeks?
Yes, sir. Yes, sir. Sinus bradys are documented.
Sinus bradycardia is a well-known sort of a physiological phenomena that happens during the pregnancy. Yes.
And regarding the first question, reversibility, sir, we have absolutely no data to say that these things get reversed completely. There are cases where they get transiently reversed, but ultimately the CHP remains as a CHP. No medical management has proven to complete reversal of a CHP once it is established.
Yeah, Ranjan, you want to make?
No, I have 3 patients. Reversed all 3.
Yeah, you are lucky that way. Well, we are not so lucky because we have never seen actually any complete heart block reversing actually, despite.
Reverse and LSCS, all 3 delivered by LSCS.
Yeah, Ranjan, you want to say something?
So just like we had.
This is the last comment here.
So we had a similar case. I'm just sharing my experience with the
Right,
rituximab.
go ahead.
I think in your case you did not have the heart block in the first pregnancy with the fetus. So we had a case where the child had the first fetus had the heart block. Second time we gave rituximab, allowed the patient a pregnancy 4 months later. The patient is pregnant, so we would know the outcome in the next 4-5 months. So it's something like that. That also can be tried, and it is based on the titers. We did the titers, showed that the titers reduced with rituximab, and then allowed the pregnancy.
Yeah, so you have a point that if you reduce the pathogenic autoantibody, then there is a chance that you may also decrease the prevalence or the incidence of complete heart block in the fetus. With this, I would like to thank Ritesh for a very excellent case, a very challenging case. Okay, so now I invite Dr. Ishan Taneja for another very challenging case to be discussed.
Okay. Good morning, everyone. I'm Dr. Ishantanija, first year DRNB resident from Sir Gangaram Hospital, and I'll be presenting a very interesting case today. So this is a case of a 34-year-old lady who presented with no previous comorbidities. She presented with generalized body swelling and frothy urine for the last 1.5 months. She also reports intermittent low-grade fever and fatigue. There is one history that is present 3 months back where she had a skin rash. It was documented as non-palpable outside. It was erythematous and non-pruritic. This occurred 3 months back on the lower extremities and it resolved spontaneously. There are no other classical autoimmune features like sicca symptoms, joint pain, or any other features. And there is no significant past or obstructive history. So this is the outside workup that was done approximately 1 week back. The patient had bicytopenia with a hemoglobin of 8.4 and platelet counts of 1 lakh. There was proteinuria, 24-hour proteinuria of 1.5 grams with no hematuria at this point. ANA was strongly positive and anti-DSGNA was negative. ANA panel was positive for anti-SSA and anti-SSB. Serum complements levels were low. So a provisional diagnosis at this point of time was made for lupus nephritis outside. There was no biopsy done and the patient received IV methylprednisolone for 3 days. But outside, the serum creatinine increased from 1.1 to 3.5 within a week and the patient also developed microhematuria. Hence the patient was referred to a higher center. So this is when the patient presented to us. On our evaluation, we found that the patient had anasarca with an albumin of 2.6 and a globulin of 4.1. Patient had acute kidney injury, ultrasound ruled out as CKD, and the patient had hematuria, serum creatinine of 2.9, and a proteinuria of 1.5 gram a day. Anemia was present, which was hemoglobin of 7.2, but the thrombocytopenia had recovered. Immunological profiles showed that ANA was positive with the speckled pattern, SSA and SSB was positive, consistent with the outside reports. Anti-DSGNA was negative, C3 and C4 were low, and ANCA was negative. So in view of RPRF, renal biopsy was done, and solumedrol, that is methylprednisolone 500 mg per day was initiated. So this is the most interesting part, the renal biopsy. And as you can see in light microscopy, there is a Glasny eosinophilic intense PAS positive thrombi with glomerular capillary lumen. So as you can see, there is PAS positive material that is present in the glomeruli over here. Apart from this, there was also segmental globular basement membrane double contour that was present and segmental endocapillary hypercellularity that could be seen. On immunofluorescence, it was found that it was IgM3 positive, IgG1 plus, and C1q2 plus along the globular basement membrane and within the intracapillary thrombi. All of these findings, all suggestive of one thing, that is serum cryoglobulinemia with serum cryoglobulin positive. Thus, a final diagnosis of cryoglobulinemic glomerulonephritis was made. Patient was now started on oral prednisolone after giving the pulse initially, and rituximab 500 mg was given. So what is driving the cryoglobulinemia? We have triggers of malignancy, chronic viral infections, systemic autoimmune diseases. So our workup showed that malignancy myeloma workup was negative. PET-CT showed diffuse subcutaneous edema, and there was no evidence of malignancy. There was no lymphoma on PET-CT. Chronic viral infections, HIV, HBCG, and anti-HCV were ruled out. In systemic autoimmune conditions, we found that RF was positive, anti-CCP was negative, SSA and SSB was positive, and anti-DSGNA was negative. So the Sherman's test was normal. We went ahead with a lip biopsy to find the cause of the cryoglobulinemia, and as you can already guess, this is a lip biopsy that is showing a 4 lymphocytic foci in 4 millimeter gland area with a focus score of 4. All of this consistent with Sjogren's syndrome. So we have a diagnosis of Sjogren's with cryoglobulinemic glomerulonephritis as of now. Looking at the complications and the crisis, I hope the case ended there, but the platelets dropped further to 30,000 and there was failure to improve hemoglobin despite 3 units of packed PRBCs and pulse steroids. So what could be the possible causes of this complication as of now? Could it be immune-mediated? Could it be APLA? Could it be infection, HLH, or TMA? So immune-mediated seemed less likely because pulse steroids were already given and even then the hemoglobin continued to fall. Coombs test was done, which was only 1+. APS, the antibodies were found to be negative. In infection, we found that the blood culture was sterile and the CMV PCR was negative. For HLH, we did have a suspicion of that, but high ferritin and LDH with normal fibrinogen and triglycerides. So HLH was still kept in our diagnosis, but that was down the line. So we looked at TMA and we evaluated. We looked at high LDH, retic count, and a negative Coombs test. Schistocytes were found to be 8%, and indirect hyperbilirubinemia was present. RMTS 13 was normal, but based on this, the Complication of that was suggestive of secondary TMA was made. So now we have 3 diagnoses, that is cryoglomerulonic vasculitis, secondary to Sjogren's syndrome, and TMA. So the management, patient received 4 cycles of Plex, received rituximab after the Plex cycles for 4 doses along with high-dose steroids. So this brings me to my discussion. That is just one slide that will sum up everything for me. So in this case, we look at certain things and we'll see the findings in this case and what supports the diagnosis of lupus nephritis or cryoglomerulonic glomerulonephritis. So we look at ANA, it was positive, which can be seen in both. Anti-DSGNA, anti-Smith, and anti-ribosomal protein P was negative, which is against SLE. Complements were low, which can again be seen in both. Importantly, cryoglobulin was positive, which supports cryoglobulinemia. Light microscopy showed MPGN-like pattern, as you remember the double contour pattern, and PAS was positive, which is typical of cryoglomerulonic glomerulonephritis. Immunofluorescence showed IgM was 3+, IgG1+, and C1q2+. There was no full house effect, which was against lupus nephritis, but favored a diagnosis of cryoglomerulonic glomerulonephritis. So what are the learning points? Cryoglobulinemia and hypercomplementemia can mimic lupus nephritis, but the absence of specific SLE serologies and full house IF pattern helps exclude SLE. TMA may exist with cryovasculitis and complicate the clinical course, highlighting the need for early immunosuppression and close monitoring. Rituximab and corticosteroids remain the cornerstone therapy for autoimmune associated cryovasculitis. So that brings me to questions to the panel.
Yeah, thank you. Thank you, Dr. Ishan, for a very nice presentation. I think many of us see a lot of cryoglobulinic associated vasculitis and even nephritis also. And the image of the kidney that you have shown is very nice. Though I may not very much agree with your minor salivary gland biopsy, because that looks very well preserved. The acinar structure was well maintained and there was hardly a single focus, but maybe then the pathologist must have taken it from a different representative area. So let's open the questions for the panelists. Again, Bhuvnesh, you are on the firing line? Yeah, okay. So what red flag features should prompt the consideration of cryoglobulinemia?
Sir, to be very frank, when I first read this case, cryo was never in the list of my differential diagnosis, to be very frank. Because I personally have not seen cryo causing this kind of a severe vasculitis in the kidney. But looking back, why I would have thought of something other than lupus nephritis would be the absence of specific lupus antibodies. Patient never had dsDNA, and extremely low complements, rapidly progressive renal failure in the absence of no other systemic features of lupus at all. Patient didn't have any, palatal ulcer or vasculitis in the periphery. So these are some things which are very commonly associated with phenotypes of severe lupus nephritis. So those things were characteristically absent in this patient, and that would have prompted me to think of something more than lupus nephritis in this patient. This case actually highlights the need for doing biopsy in our patients. So some of us, or even the nephrologists, become hesitant to do biopsies when we say that this is lupus nephritis. But many a times we may be missing mimics of lupus nephritis. So I think biopsy is extremely important in all cases of autoimmune rheumatic diseases where there is a renal involvement.
Yeah. So this is a very important message for the fellows, that you have to generate the evidence, and something which is not fitting in well, better to go for a tissue diagnosis if at all it is possible. This patient never had classical manifestations of cryoglobulinemia, no Raynaud's, no neuropathy, no jaundice. And despite that, look at the kidney biopsy, which is very characteristic of a cryoglobulinic nephritis. So very difficult to think of, and I think he has very rightly summarized. Low complement for which you do not have any explanation, and patient is not fulfilling the criteria for lupus nephritis, could have thought of in the hindsight that possibly cryoglobulinemia could have been there. Okay, the next question is, what are the clinical and the lab markers which best predict concurrent TMA in immune complex mediated vasculitis?
I think in this particular patient, it would have been the refractory anemia, and the second thing is the falling platelet. In spite of immunosuppression, the patient's platelet count never improved at all. So I think that would have triggered, and other things are very high, extremely high LDH, with the DCT being negative. So I think these things would have prompted me to look for a TMA in this patient.
And just a comment for the fellows, please do look very carefully the peripheral blood smear. I think this is a complete one investigation which can give you a good idea about the hematological, all the investigation. You don't need a platelet, you don't need even hemoglobin, because peripheral blood smear can give you a good idea. And schistocytes you will only see in peripheral blood smear. Okay.
So I would like to elaborate on the third question.
Yeah.
Here, what I was reading was that Sjogren's itself can have cryoglobulins positive that is asymptomatic, and that can persist for a long time before it leads to further development, such as even lymphoma. So that can predict the development of lymphoma. So will earlier therapy with rituximab, so B cells target therapy, help prevent the development of even malignancies and even the manifestations of cryo?
Yeah, Bhuvnesh.
So I'm not sure whether rituximab can help prevent malignancies. That I'm not sure. I don't even know if there is data available for that. To answer this particular question that you have put here, I think rituximab is an excellent choice for cryovasculitis, but it works best for immune-mediated cryovasculitis, even though it works well for viral-related or even malignancy-related cryovasculitis. The best documented evidence and what it best works for is an immune-mediated cryovasculitis.
Yeah, I don't think there is enough evidence to suggest that prophylactically rituximab therapy can prevent development of lymphoma later on. To the best of my knowledge, I don't have that kind of information available. Now I will open the case for discussion with the audience. Yes, Bhavani. Yeah, just use a mic, Bhavani.
So even the article I had read had put it as an open-ended question: should we give it or not?
No, Bhavani, mic is not on.
Renal biopsy, it was not showing any evidence of TMA.
So I'm glad that question was asked, because we had this similar doubt whether it is actually TMA or it is cryoglobulinemia. So we did a literature review, we looked at the difference of the biopsy. So the difference we found was that even the past positive can be seen in both is much more in cryo. Secondly, the immunoglobulins that we found at IgM, and IgM is very specific for cryo. It can be in TMA as well. And that is one point. Thirdly, the double contour pattern that can again be seen in both, but is more in cryo. And fourth, most importantly, the pathologist suggested it's cryo. So that was one point.
Yeah, you can't challenge the pathologist. Okay, yes.
Was APLA done for this patient? APLA?
APLA was negative.
Yeah, Abhishek, yes, please.
Hi. You said that the patient had reticulocytosis of 8%?
Schistocytes.
Schistocytes.
Okay. So that's...
Yeah. Any other fellow? Yeah, Danvir.
Yeah. Actually, I was asking yesterday also, is it specific to have the full house effect in the SLE, or it is non-specific to SLE?
Yeah. So your comment?
So full house effect is usually seen in the DPGN pattern of the SLE, but it can be, if it is not there, we can't just say that's not lupus nephritis. That's not like...
So because B-cell mediated diseases such as myositis...
Yeah. So what I'll suggest is that generally you don't see IgM deposition to be that high in a patient of lupus nephritis. It is predominantly IgG and the rest of all.
And regarding the rituximab in this patient, those who are high risk, because we want to control the disease, here primarily we are thinking that disease activity is leading to lymphoma. So rituximab is good option in that condition.
Yeah, no, rituximab is being used to treat lymphomas.
Yeah.
R-CHOP is the standard regime to treat non-Hodgkin's lymphoma. But I don't know whether giving it upfront prophylactically will prevent later on incidences of lymphoma or not. We don't know.
We have to generate data, but I think it should.
Okay, yeah, you have a point here. So now, anybody else?
Sir, here. So what will be the maintenance treatment that is being continued in this patient? Are you continuing with the Ritux, or you're choosing anything?
As of now, we are continuing with rituximab.
What is the dose that you have been continuing?
So we started with the loading dose of 1 gram every 2 weeks. After that, we are giving it 6 months.
Okay. 1 gram?
1 gram.
Okay, thank you.
Yeah, okay. So maybe one last comment from Ranjan.
So the eosinophilic material, was it there within the vessel or outside the vessel within the glomerulus?
So it was in the vessel, and it was, one second, I'll just open it up. It was mainly in the...
Yeah, it was within the vessel. It was very clearly seen.
So then it could be again TMA, it suggests actually TMA.
So here that it was positive within the globular capillary lumen, that was positive. The fourth point of difference, which I forgot to mention, was that the endocapillary hypercellularity, that is the more inflammation is there, more suggestive of cryo rather than TMA. And also one more thing, that as you can see, the immunofluorescence patterns along the GBM and the intercapillary thrombi. In TMA, it's usually within the thrombi. If we find it along the GBM as well, that's more suggestive of cryo.
Okay, thank you, Dr. Ishan, for an excellent presentation. You want to make a comment?
Thank you.
Dr. Ishan, I would like to know if immunotyping was done. Cryoglobulin, what was the type of cryoglobulin? Whether immunotyping was done?
Ma'am, we just found it on the immunofluorescence and we did a serum cryoglobulin qualitative, which was positive.
Have you done an electrophoresis? What did your electrophoresis show?
Electrophoresis myeloma worker was negative.
No, not the myeloma worker. Whether it is IgM kappa. Generally, we are expecting it to be IgM kappa.
Right.
And on renal biopsy, did you have kappa restriction or not?
Ma'am, I am not sure of that. I'll have to review
because this is very important, because this is type 2 cryoglobulinemia. Generally, that is what is seen. And there you get generally IgM kappa.
Right.
So you have monoclonal IgM along with polyclonal IgG. And it would have been very relevant to do an electrophoresis or immune fixation electrophoresis in this patient. You would have got the diagnosis a bit earlier. And the other point I would want to make is that it is the same clone that and rheumatoid factor is a surrogative mark for this. And if you had high titer RF positive, that means that this patient is on the way to develop lymphoma, very high possibility of lymphoma. Thirdly, it is very important to know what is the absolute level of C4. So if you had an inappropriately low C4, that is one clue. So inappropriate low C4, and if you have hyperglobulinemia and electrophoresis showing this IgM pattern, that would have helped us clinch the diagnosis a bit earlier.
Very interesting and very relevant points what Dr. Sandhya has pointed out. Thank you, Ishan. We are running late, so we'll have the next speaker. Yeah, okay. So now I invite Dr. Nirmal for another very interesting case, which is to be seen very rarely by any rheumatologist. So let's hear him out.
Good morning. I'm Dr. Nirmal, senior resident from AIMS Bilaspur, Himachal Pradesh. Today I'll be presenting a case from dust to disease, multi-organ autoimmune injury in silica exposed Erasmus syndrome patient. Patient is a 62-year-old male with no comorbidities, a stone cutter for more than 30 years with chronic smoking and alcoholic history, came to us with a total duration of illness of 3 months, presented with Raynaud's phenomenon, skin thickening involving the upper limb, lower limb, face, thorax and abdomen, and there was progressive dyspnea for 2 months, which was progressed from MMRC1 to MMRC3. And it was associated with dysphagia, GERD, myalgia, arthralgia, and there was significant weight loss of about 10 kg for the past 5 to 6 months. And it was not associated with any digital ulcers or gangrene, and there was no frothy urine or no hematuria, no ocular or oral sicca, no muscle weakness, and there was no fever or night sweats. Examination findings were consistent with the diagnosis of diffuse cutaneous systemic sclerosis, such as a modified Rodnan skin score of 23 or 51, and mouth opening was inadequate, and there was salt and pepper pigmentation of the skin with pinched nose, digital pits and scars, and there were telangiectasias over the face and palms. Respiratory system revealed reduced air entry, and there was bilateral infrascapular end inspiratory crepitations. We proceeded with laboratory findings which showed mild transaminitis, and SGOT was more than SGPT. The creatinine was normal, and urine routine was normal. There were no sediments. CPK was elevated, which was about 7 times of the upper limit of normal. LDH was elevated, and CRP was 64 milligrams per liter. ANA showed 3+ homogeneous, and ENA and scleroderma panel was strongly positive for SCL70 antibody. Chest X-ray showed miliary pattern. Based on this, we made a provisional diagnosis of diffuse cutaneous systemic sclerosis with an asymptomatic CPK elevation and a miliary pattern on chest X-ray with in a patient who is a chronic smoker with a silica exposure of more than 30 years. We further evaluated as the patient had miliary pattern on chest X-ray. We wanted to rule out certain conditions like tuberculosis, fungal infections, miliary metastasis, and obviously silicosis and cold workers pneumoconiosis. So we did microbiological investigations from sputum and bronchoalveolar lavage like CB-NAT, bacterial cultures and fungal cultures all turned out to be negative. Simultaneously, HRCT thorax was done. The lung window showed progressive massive fibrosis along with an SIP pattern ILD. There is subpleural sparing, and the mediastinal window showed eggshell calcifications. And since the patient had rapidly progressive symptoms for the past 2 to 3 months, the skin thickening was rapidly progressive and the dyspnea was also progressive, along with significant weight loss of 10 kg for the past 5 to 6 months. We proceeded with PET CT, which showed only metabolically active lymph node in left supraclavicular region. But we were not able to get the biopsy done from that area, but we were able to get biopsy from axillary lymph node, which was only reactive, and tumor markers were negative. Finally, we had only silicosis with systemic sclerosis known as Erasmus syndrome. Since the patient had a persistent CPK elevation, we proceeded with investigations to rule out the causes for CPK elevation. There was no objective muscle weakness as evident by normal MMT scoring. There was no drug or toxin intake which could cause this CPK elevation, and there was no recent intramuscular injections, and metabolic and endocrine parameters were also normal. Hence, we proceeded with the whole body MR to look for subclinical myositis, which showed stir hyperintensities involving the neck muscles, bilateral shoulder muscles, and bilateral pelvic girdle muscles. And surprisingly, we were also able to find out stir hyperintensities involving the myocardium. So we proceeded with 2D echocardiography, which showed an ejection fraction of 25% with global hypokinesia, and there was no pulmonary artery hypertension. The troponins were negative, but NT-proBNP was elevated. So myositis profile showed strong positivity for PL7 antibody. So hence we came to a conclusion of Erasmus syndrome. Along with that, the patient also had myocarditis with PL7 associated subclinical myositis. So we managed the patient with a calcium channel blocker for Raynaud's phenomenon, and we started prednisolone 0.5 milligram per kg in view of myocarditis. We were a little hesitant to give this as patient, the shortness of breath, we were attributing it to mostly ILD. We asked the patient for an early follow-up and planned to de-escalate the prednisolone early. And we have also given rituximab. We actually had 3 immunosuppressants in mind. One was MMF, rituximab, and cyclophosphamide. Since the patient was not able to afford for MMF and he cannot come once in a month due to his remote geographical location, we had the option of rituximab only. In view of rapidly progressive skin involvement, ILD, myositis, and myocarditis. So we asked for an early follow-up at 2 weeks to plan for the second dose of rituximab and de-escalate prednisolone, but patient came delayed after 6 weeks. So this graph shows the timeline in weeks on x-axis and serum creatinine values on y-axis. During the initial admission, the creatinine was 0.6 and there were no urinary sediments. During that time, we have given rituximab and prednisolone for the patient. When he has come to us for the second visit around 6 to 8 weeks, his creatinine was gradually increasing from 2.2 and it was going till 3.9 and it was maintaining at 4 milligrams per deciliter. Along with that, he had elevated blood pressure and 24-hour urine protein was in the non-nephrotic range. So hence we had thought of scleroderma renal crisis, and we have de-escalated the prednisolone dose from 20 milligrams to 5 milligram, and we have started an AC inhibitor. So however, we proceeded with renal biopsy to confirm the diagnosis and to look for alternate pathologies which can cause this. Surprisingly, we were able to get IgA nephropathy picture on renal biopsy. In this picture, there is mesangial hypercellularity without any crescents, and there is interstitial infiltrates, and the direct immunofluorescence revealed mesangial IgA deposits. So in this patient with silica exposure, he had diffuse cutaneous systemic sclerosis with silicosis and progressive massive fibrosis termed as Erasmus syndrome. Along with this, the patient also had IgA nephropathy and myocarditis along with PL7 associated myositis. So chronic silica exposure is epidemiologically linked with multiple rheumatological diseases, and many meta-analyses are available correlating the odds increased risk of diseases such as rheumatoid arthritis, SLE, systemic sclerosis, small vessel vasculitis, and even sarcoidosis with silica exposure. However, the association with inflammatory myositis and IgA nephropathy are rare, and there were only some case reports for it. So hence, an occupational history of chronic silica exposure is important in these selected cases. And the coexistence of silicosis and autoimmune disease, is there a shared underlying mechanism of autoimmune dysregulation? Questions?
Dr. Nirmal, for a very interesting case. And again, I will like to start with the panelist first. So what he's asking is what could be the possible role of possible silica-associated mechanisms which could have triggered the autoimmunity in this particular patient.
This is like a very good clinical case, because I think most of us might have seen one of the clinical domain or a clinical phenotype. But in this case, especially you're showing multiple domain involved, lung, muscle, and skin involvement. So if you look back at the occupational history and the occupation associated trigger of autoimmune or autoinflammatory diseases, definitely silica is one of the key roles, and it is associated with commonly like rheumatoid arthritis or systemic sclerosis. So in this particular case, probably the inhalational route where the silica goes into the lung, where it is engulfed by the alveolar macrophages, thereby triggering the inflammasome pathway and leading to the autoimmune or inflammatory cascade. And this silica, it is not like a degradable one. So the persistent antigenic stimulation could also be a second factor which may predispose to an inflammatory response in this case. So obviously this occupational exposures, they trigger autoimmunity, and which is especially this scleroderma and silica exposure, it is an established exposure as an etiology for the cause of this autoimmune disease.
So very interesting, and one has to remember that genetic susceptibility also plays an important role, because not all silica exposure patients will develop, or persons will develop a disease phenotype. And here too a multiple autoimmune phenotype is very rare to see. We have never seen any such case ever in my career. Okay, let's go on to the next question. What should be the management strategy if patient develops some autoimmune phenotype after exposure to silica?
So the answer is so straightforward that we should minimize or completely restrict the exposure. That is, you have to advise your patient for shifting to an alternative occupation where this occupational hazards triggering the autoimmunity can be very much reduced. So the complete exposure should be curtailed in this case. And apart from that, the management depends upon the organ involvement. In this case, as you have said, the muscle involvement, the skin involvement, and PL7 associated ILDs and myositis. This can be like how we manage the routine cases of routine autoimmune cases.
Now comes the most challenging question actually, how to manage a patient of myositis or myocarditis with glucocorticoids in a setting of a diffuse systemic sclerosis phenotype, because there is always a risk of scleroderma renal crisis.
This is always challenging for every rheumatologist, be it a junior or a senior. It is always challenging, and we have to decide on case-to-case basis. Definitely when we are starting steroids in patient of scleroderma, we have to caution the patient about monitoring of his or her blood pressure regularly, and we have to educate the patient regarding the risk of SRC. And we also have to insist a very close follow-up with us, which obviously this patient didn't come for your follow-up. Probably you might have missed an early recognition, much earlier recognition in this patient. And this SRC definitely, as we know that a steroid dose of 10 to 15 milligrams of prednisolone or equivalent is at risk of scleroderma renal crisis. But there are situations where we have to treat this patient with high dose of steroids, whether it is a 0.5 mg or a 1 mg per kg steroid, depending upon the organ, especially in this case like myositis and PL7 associated ILD. So in these patients, along with starting the steroid monitoring and education, you have to think simultaneous options of steroid sparing agents at the earliest.
So my question will be, wouldn't it be a good idea to start with IVIG and with a very low dose of glucocorticoid?
Yes, sir. The IVIG is also a good option even before like rituximab and all.
Yeah. So Nirmal, did you thought of that possibility also, IVIG?
Actually, we have considered only MMF or cyclo or rituxi. We never thought of
Okay, okay. And the last question, which is is there a need for periodic screening of patients with chronic occupational exposure to silica? If yes, then what should be the strategy?
Yes, definitely there is a need for periodically screening these patients who has a high risk of occupational hazards. But if you ask me directly what are the screening strategies, till now we don't have any specific guidelines how frequently we need to do. But on verifying the literature, I could say it is most of the papers have indicated an annual screening strategy in these patients who are at risk of developing autoimmune diseases. So this annual screening strategy, it is based on clinical laboratory parameters with or without imaging. So clinically, when these patients develop any particular symptoms like shortness of breath, which is mainly exertional shortness of breath, Raynaud's or GERD, which is very much peculiar to the occupational associated autoimmune rheumatic diseases. And the second thing is regarding the antibodies. Is it really indicated to test these patients, especially with the mild symptoms or asymptomatics with autoantibodies, whether it is like ANA or disease-specific antibodies like SEL70 or centromere? Again, there is no clear-cut guidelines whether we need to do it or not. If the patient is asymptomatic and the patient has a positive autoantibody, again, what we need to do that positivity? Is it just monitoring and waiting for the patient to be symptomatic, or we are doing any preventive things or not? There is no clear literature guiding that. So, but I feel that yes, you have to do an annual screening. You have to check the symptomatology. And according to the symptoms, you can think of doing a serological panel in these patients.
Yeah, absolutely correct. Patient should be examined for a clinical clinical symptoms, and if there is a development of a phenotype, then maybe accordingly one can investigate further. So now it's open for questions from the audience. Yes, please. No, first from the back, beta, either.
Over here, my question is to the panelist about the choice of immunosuppression, because this patient had been a case of silicosis and the combination of silico-tuberculosis is very high. So, and the patient was given rituximab, so how frequently the patient should be screened for TB as well, because the rest of the manifestation can be also a complication of it.
The baseline screening done by him for tuberculosis is negative, including the MONTU and the BAL which was sent for analysis. That is completely
in the
normal.
The development of tuberculosis over
That's
period.
And moreover, in patients who are receiving rituximab, if you look at the mechanism of action, the rituximab is completely a B cell dependent pathways, whereas your TB occurrence is a T cell dependent pathway. So the chances of developing or latent tuberculosis activation with rituximab is very, very less. Okay. So the screening for tuberculosis only in relation to the rituximab is not indicated.
Okay.
Yeah, silicosis per se doesn't mean that all the patients who are exposed will develop tuberculosis. But you are right, one has to be vigilant. We are actually when we are using immunosuppression. Okay, any questions from the fellows? First from the fellows actually. Nobody? Okay, yeah. So start from Ranjan actually. Yeah, Ranjan. Acha, okay, Ranjan, just wait. Yeah, we'll have a question from the back side.
No, actually patient succumbed to death after few weeks.
Yeah, the question is whether cyclophosphamide would have been a better choice because of myocarditis.
May not be the right choice for a myocarditis with an EF of 25%.
Absolutely. That is why I was suggesting of IVIG actually.
Sir, is IVIG okay because that will also cause some volume expansion? So with an EF of 25%.
That you can monitor patient during, because IVIG will be given within the hospital premises only.
Yes.
So,
So we had one patient actually, she was MCTD, she had severe myositis, myocarditis. We gave her IVIG, but then she went into a severe failure after that. We gave her very less volume.
No, myocarditis per se can cause heart failure.
Yes, sir.
Yeah,
But after the IVIG, she worsened quite a lot.
Yeah, because cyclophosphamide is again a cardiotoxic drug, so one has to be very cautious in using for myocarditis. So any other question from the, yes, please. Shyam Sundar. Yeah, I will do that. Okay. Yes, I know.
Yes, this patient I feel had two major risk factors because there was a poor outcome. There were two risk factors for malignancy. One was this rapidly progressive skin tightening. Second was the development of TN. Basically, the patient had scleroderma renal crisis. Antibodies?
Yes, sir. The entire panel was done, of which only ACL70 was positive.
Okay. But still, that left supraclavicular lymph node is a big red flag in this case. So probably the patient could have had a luminal malignancy, something which could have been missed on a PET CT, which was or probably was developing. That's why the patient had so many unrelated antibodies, ACL70, PL7, and multiple autoimmune manifestations, which could have been triggered by a malignancy, which probably was in the development phase, leading to multiple autoimmune manifestations.
Right.
Actually, patient hesitated. There was multiple procedures ongoing, like we did multiple interventions, so that finally only we were able to.
So many times it happens they don't give consent for an invasive procedure. Okay, with that I would like to thank Dr. Nirmal for a very interesting case. Thank you. Now I invite Dr. Sandhya for the report of all these 4 cases. Summary. No, you have to go there.
Professor Agarwal, can I ask you a question before that?
So good morning all. We had very interesting 4 cases, and like the first session, the session presented, the 4 cases highlight the beauty of interplay of genetic and environmental factors in autoimmunity. So if I have to start with the patient with scleroderma first, so we had a patient who had hemolytic anemia that was caused by SLC4A1 mutation, and the case highlighted how the chronic hemolysis and increased reticuloendothelial cell activation and chronic inflammation could influence antiphospholipid antibody syndrome in that patient, and also the endothelial activation, and modify the presentation of limited scleroderma with pulmonary hypertension. And this again brings us to the question that in this patient, pulmonary hypertension could be multifactorial, and how this could influence our treatment choices. So we need to really look at it in a case-to-case basis and decide how we should use immunosuppression in these patients. For example, in this first patient who had SLC4A1 mutation and hereditary spherocytosis, the patient is at risk for autosplenectomy. So we should carefully weigh the risk versus benefit of immunosuppression. So in the first case, there was not really an indication for giving immunosuppression. So that's the learning point. Second, again, the case of scleroderma with silicosis and then causing myositis and IgA nephropathy again highlights how environmental factors in the correct genetic background could result in a lot of autoimmune features. And again, the challenges of immunosuppression in a scleroderma patient with myositis, balancing steroids, balancing immunosuppression, how we could reduce the dose of steroids and modify immunosuppression to that effect. The options discussed were about giving IVIG, cyclophosphamide Ritux, which would enable us to reduce steroids early on. And patients exposed to silicosis or at occupational hazard should be screened regularly for autoimmune disease. The next two cases of Sjogren's syndrome, the case of Sjogren's syndrome and fetal heart block, again a very challenging case, but also shows the beauty of autoimmune disease. You have this two fetus exposed to the same risk factor, external risk factor. Only one fetus develops fetal heart block, the other fetus doesn't. So this again highlights that it is not, it is just the presence of antibody will not cause fetal heart block, and there are fetal risk factors which we do not clearly know about. Again, the important point here, balancing immunosuppression. So we do not have a good, it also highlights the futility of monitoring these patients because we do not really know what is the right way of monitoring. We know that fetal heart block is seen in patients who have high titers of antibody, and this fetal heart block does not progress in a step-by-step manner. It's not that you will get first degree heart block followed by second degree, then third degree. It doesn't happen like that. It is a random chaotic event, and we cannot immunosuppress all people with first degree heart block because it has been shown that first degree heart block can spontaneously reverse back to normal. Again, other thing is there can be very rapid progression within matter of hours to complete heart block. And once the complete heart block has set in, it is generally believed that it is irreversible. So again, in these cases, we need to balance giving dexamethasone and IVIG. So because we know that chronic dexamethasone will increase maternal and fetal morbidity, so we need to consider other strategies, whether we could give IVIG regularly and reduce the use of steroids. The other case was Sjogren's with cryoglobulinemia. So a couple of points. So if we have a patient with autoimmune disease and there is renal failure, what are the possibilities we should think of other than lupus? So if you have very low complements and renal failure, and if you have SSA, SSB positive, always consider the possibility of cryoglobulinemia. The clue would be an low C4 which is out of proportion, lower than SLE, and in these conditions, we should consider doing rheumatoid factor. If there is hyperglobulinemia, look at electrophoresis and find out what is the type of globulin that is present. The other thing, in SLE patients who are not responding to, if we think it is SLE renal failure and patient is not responding to immunosuppression, the other possibility we should consider is TMA, especially if there is bicytopenia, that is low hemoglobin, low platelet count, and persisting renal failure. We should consider the possibility of TMA. Very important to look at the peripheral smear in this patient because the presence of TMA would change therapy. You could consider doing plasmapheresis early. Second point is in renal biopsy, how can you differentiate? Can you differentiate DPGN of SLE from cryoglobulinemic nephritis? So the pointers would be, full house would favor SLE, whereas if you have predominant IgM and C1q and IgG is only 1+, that is when you should consider the possibility of cryoglobulinemia. Because in cryoglobulinemia, there is a block, that pathway beyond C3 is inhibited. So this is the important clue. I think that is all. I hope I've summarized.
Thank you. Very well analyzed. And you have added a couple of points which we have not covered actually. So with this, Dr. Sharad, we are permitted to leave or we have to do some more work?
Thank you very much for an on-time completion of the session.
Right.
I thank the chairperson, our panelists, and the rapporteur for well-conducted session.
Thank you.
Thank you very much. Thanks all the delegates. And we will announce. So now we will announce the winners for the previous session and present session.
Yeah. The winner for the rheumatoid arthritis, spondyloarthritis session, all of them presented beautifully. Very difficult to choose one, but we have to choose one. So narrowly, Dr. Naveen Kumaran R had won the first.
So big round of applause to Naveen Kumar. Can you come here?
I have the privilege of announcing the winner for the second session, and the winner is Dr. Ritesh Kumar Mishra, discordant twin outcomes in anti-Rho positive Sjogren syndrome, a therapeutic dilemma. Very interesting case.
And he is also the ACR Trophy champion. As they're taking the photograph, now we'll move on to the next session, that is inauguration. Inauguration between 11 to 11:15. Exactly at 11:15, we'll have a group photo that may take 10-15 minutes. From 11:30 to 11:45, short tea break. Be on time back 11:45 in the hall again. So now I request Naveen, can you arrange 6 chairs here? So Dr. Jyoti now will be in charge of the inauguration.
तच्चयोरा रुनिमहे गातुं यज्ञाय गातुं यज्ञपतये दैवीं स्वस्तिरस्तु नः स्वस्तिर्मानुषेभ्यः रुचं वच्मि Om Shanti Shanti Shanti. The meaning of this sloka being universal peace and well-being. We worship and pray to the Supreme Lord for the welfare of all beings. May all the miseries and shortcomings leave us forever. May all medicinal herbs grow in potency so that all the diseases may be cured. May the gods rain peace on us. May all the 2- and 4-legged creatures be happy. May there be peace in the hearts of all beings in all realms. I, Dr. Jyoti, Deputy Medical Superintendent at KIMS Secunderabad, would like to begin today's inaugural program with a small invocation to the universe to keep us all safe and sound all through the year. Hearty welcome and a prosperous new year to all the mighty, esteemed, iconic stalwarts gathered here today for the biggest and greatest conglomeration of clinical rheumatologists under one roof. Tamasoma Jyotirgamaya. From darkness to light, from ignorance to knowledge. It is auspicious, divine, and customary to light lamp in all events to quell the darkness of ignorance and lead everyone into the light of knowledge. I request today's dignitaries to light the lamp and grace the stage. Today's guest of honor, Dr. B. Srinivas. So please come on to the stage. Our Chief Patron, Dr. Bhaskar Rao sir, Dr. Vinod Ravindran, Dr. Sharat Chandramouli sir, Dr. Raj Kiran, Dr. Sambit Sahu. Please proceed for the lamp lighting. With rheumatologists since the beginning of my career from Manipal days in 2006. I have always felt rheumatology is a very challenging specialty, and I feel it throws challenges every day. First challenge being the diagnosis, second challenge being the treatment, and third, keeping the side effects and the reactions at bay. So I feel it is the biggest learning platform for everybody who has come here today, taking your time and energy, and we are thankful for your efforts. I now call upon our medical director, Dr. Sambit Sahu, who is also the HOD for critical care and also the unit head in our hospital, to address the gathering.
Good morning, all of you. So the last few days, Dr. Sharath has been, me and Dr. Sharath have been having conversations regularly, and he's been asking, the number of registrations are so much, you need to arrange extra chairs. And I was silently praying that we should have an Indigo-like issue so that I can manage the number of seats. But the way we look at the KIMS Rheumatology department, I mean, it's like if you call Taj Mahal a building, it doesn't tell you the whole picture. So it's not a department for us. In KIMS, Dr. Sharat Chandra Mauri is not only the clinical director, and the Department of Rheumatology is a center of excellence for us. And I can very confidently say that this department has grown to such heights that we now stand shoulder to shoulder with the world's finest, and that's the confidence with which we can announce to the world now. And Dr. Sharath has been always, his motto has been, be a lifelong student. With the same enthusiasm this year, I very proudly also have to, share with all of you that in the ACR Knowledge Bowl, he and his team got the first prize. And that is the first time in India ever this has happened, and that is a real moment of pride for all of us. And you will be witnessing all the DNA of the world-class physicians who are here as speakers, and these are the architects of excellence in the field of rheumatology. So I welcome all of you, sir. And we also have Dr. Srinivas, and NB has also come forward to endorse this event. So wish that you be curious, you ask questions to these stalwarts, and also challenge them and enjoy the CME. Thank you.
Thank you for your thoughtful words, sir. I now invite upon the scientific committee chairperson, Dr. Vinod Ravindran, who is also the president-elect Indian Rheumatology Association and managing director at Center of Rheumatology, Calicut, Kerala.
Thank you. Good morning, everyone. Many of us have been involved in CRC right from its inception. As Sharad will say, Dhamanand, Arul sir, Kaushik, Dr. Sapan. This conference is actually rooted in clinical science with only one objective, that is to teach, improve knowledge, practices among our trainees. So you can see the whole ethos of this meeting is completely different from any other or routine sort of meetings, okay? And we all been benefited over the years by attending the CRC. So it was a delight to sort of, do the same scientific program with minor tweaks which I hope you would have noted, and as we go along to the sessions in the rest of the day tomorrow, enjoy and appreciate the hard work of the team CRC which has gone behind it. And I was here yesterday for about 2 hours, and I would like to mention especially and congratulate the young colleagues from the Sharad's team, okay, who have been really working extremely hard for the last 4 months. So thank you very much, and I wish you a great sort of remaining of the conference. Thank you.
Thank you so much, sir, for that short and quick addressal to the gathering. I now invite upon Dr. Sharat Chandra Moli, sir, who has been the man behind today's program. Sir has been working tirelessly to keep up the department always active and alert in our KIMS Hospital, Secunderabad, which is having one of the highest OPDs in the hospital. So the podium is yours, sir.
I'll be very quick, try to be, Dr. Jyoti. I welcome you all the delegates and the faculty to this wonderful case-based conference, and wishing you all a happy and prosperous New Year. And everybody knows that Hyderabad is famous for the pearls, Pearl City. So now you're all here to collect the rheumatology pearls. Welcome you all for the Pearl City. If one lives for 100 years, how many days one can live? Just now I Googled, not Google. ChatGPT told me 36,500 years one can live. So you are spending, thank you for spending 2 days of your that 36,500 days. So you are exchanging 2 days here of your life. Thanks for that. And I guarantee that you get more than worth of that those 2 days. Thanks for exchanging your knowledge for the rest of the delegates and faculty here. Thank you very much. That's it. Thank you.
Thank you, sir, so much for your words. Last year has been special for us Indians, in that medical fraternity as a whole, and especially for all the rheumatology clinical immunologists, as the 3 musketeers, Dr. Sharat Chandra Moli from KIMS Hospitals, and Dr. Ritesh from Jipmar Puducherry, and Dr. Mohit from KIMS Hospitals again had represented India overseas and lifted the ACR Knowledge Ball trophy along with the medal and the Team Spirit Award at the global stage.
Ritesh and Mohit, please come.
It was held at Chicago, USA, making us all proud Indians. So audience, please big round of applause for all of them.
So we have kept this not just a showcasing only, to encourage all the trainees. When our youngsters from KIMS and Jipmar got it, why can't the others? So to encourage them, we have kept, and Ritesh and Mohit did so well. Please come. Big round of applause to them. First ever Knowledge Bowl trophy winners from India, and excellent scoring. They scored 5,400. The second one got 1,700. So best ever score recorded in ACR. The message was sent by Mr. Gardner, ACR Planning Committee Chairperson. So he greeted personally. So not only that, we got a medal, and also they give the another one called Team Spirit. Anyone can get it. First they select 16 teams, 16 finally 4 will they go to finals. So out of 16, one would get the Team Spirit Award. So we got the Team Spirit Award also. So by default, our team wildcard entry to the 2026. So they get a free registration, free accommodation also for 3 days in Orlando. So I encourage next time the India should beat against India. So I encourage all the trainees, please, all the faculty encourage your trainees to come and participate in ACR Knowledge Bowl next time. Thank you.
Congratulations and all the best for this year's competition again. It is our privilege that Dr. B. Srinivas, who is Deputy Director General, Minister of Health and Family Welfare, Government of India, is with us today, and I would request him to address the gathering.
Good afternoon, KIMS, respected delegates on the dais, also my fellow doctors here. It's a privilege for me to come here. This is my home city also, though I reside in Delhi, to come back here and also to see the young doctors, budding doctors here interacting with each other, the debates that you're doing. I miss that because during my college days in Maulana Azad Medical College, we used to have those debates. But going into the ministry and into the administration, I miss that time when we used to have these debates, these case presentations. I was sitting since morning, and I could sense the kind of enthusiasm and excitement I could see in all the doctors here, debating the finer points and learning from your mentors. This is a golden time for you, and I think you will learn a lot from such instances. And besides that, the Government of India is also committed to the fact that we want to increase the medical colleges, and we have also increased the number of PG seats, including super speciality. You must be aware that at least when we were doing MBBS during that period, we used to have around 30,000-40,000 seats. Now we are having almost 128,000 seats. The Honorable Prime Minister wants us to increase them more, but of course, along with the quantity, we would like the quality should also be maintained. And for that, we are, as a secretary and MC, and also as a member secretary for the counseling committee, we are taking steps. And I just interacted with Bhaskar Rao Garu, who was the chief patron. And I asked him and I requested him that all of you also, that if you have any advices and any suggestions, please give to us, to the ministry, so that the regulatory body in the NMC, because ultimately that has to make the changes. We made certain changes in the TEC last time, where even the non-teaching specialists were given the facility to become teachers and professors. And through that, we want to increase the number of facilities across the country. I once again thank Saratji for organizing such a wonderful event. And I give my best wishes for the organizing team and learning that takes place in such scientific programs. Thank you very much. Thank you.
Thank you very much, sir, for your effort and time and joining us today and addressing the gathering. Now I'll be inviting our chief patron, Dr. Bhaskar Rao, sir, who is our chairman and medical director of our KIMS Empire. Sharat sir joined KIMS in 2004, so it's been a long, strong association of more than 20 years between sir and our CMD sir. And CMD sir ardently believes, supports, motivates and encourages knowledge building and sharing. And he has been one of the strongest supporter of the Chicago event also, wherein our DNBs were also able to go to US and participate in the program. So please give a big round of applause as sir comes and addresses you all.
Good afternoon, everybody. Wish you a happy, healthy and a prosperous new year, because the doctors are also getting sick in an early age because of their tension or whatever it may be. And the most important thing, the young and dynamic Dr. B. Srinivas is being there as an administrator in the medical education and medical governance. The Deputy Director General, Ministry of Health and Family Welfare, Government of India, Secretary in Medical Counseling Committee, and also a National Medical Commission former Secretary also. And Dr. Vinod Ravendran and Dr. Sharat Chandramouli, Dr. Raj Kiran and Dr. Sambit, all the delegates who have come here to participate for this conference. The one important thing what we have been set in KIMS is this Kakala Subbarao Educational Learning Center, which most of the corporate hospitals won't waste this much of space for the learning. And I'm very, very happy that at least 100 days in a year, this auditorium will be used by the national and international conferences, workshops, a lot more learning. You know, sciences keep changing every day. Unless we don't update ourselves, and we will not able to do the good quality work to our patients. So that's why we set up about 2 decades back and established this one. As far as Sharat Chandra Mouli is concerned, since inception he is with us. It's so much of practice that he has, and so much many people might have approached him or even established a specialty clinic on his own, would have made more money. But he continued to stay for the sake of academics, learning, training people, and then give good quality work. I'm sure he is the only one person take all his DNB students for the national and international conferences and let them present the papers, inspire and invite an ignition among the medical fraternity, the DNB students, to see that there are many people. Even Prasanna is also our product, and she like that. And I have seen that Agrawal and all, the way they are communicating the case-based training programs will give a lot of knowledge. With a little bit of my knowledge as a cardiac surgeon, in that case of myositis and cardiac one, when you have a multi-specialty hospital like this, the heart has the biggest thing. If you give rest for 2-3 days, it will be able to pick up everything. But unfortunately, we can't able to give rest on its own. Now, mechanical support can be able to give a rest. I don't know whether you can able to think in a multi-specialty hospital, whether you put the patient on ECMO or LVAD, so that the heart will recover when you give all these IC and all those treatments. That way it will be somehow the multimodality, multi-settings will be able to help our patients to recover. It all depends upon what type of age that the patient is having. Whether you want to give more, we can able to work all these opportunities. The other important thing is I congratulate my Sharat Chandra Mouli and the DNB students who won this bowl, and which is one of the prestigious for the Indian as well as for KIMS. I congratulate once again to Sharat Chandra Mouli on this aspect. This is the year, everybody is enjoying the new year, but you people have come here with an interest to develop the interactions and other things. So we always look for what we have got the training and the medical education is a one-way direction. If we really want to improve our case presentations and interact with them, unless you challenge each other, you don't gain the knowledge. At the same knowledge, you can able to go on treat your own patients. Once again, congratulate all of you to come and participate this, and a very, very active participation. It is the knowledge is flowing just like a walking encyclopedia. That means you have spent a lot of hours with a dedication. That's why you could be able to gain this much knowledge. Thank you. Thank you very much.
Thank you very much, sir. In addition to what I was telling earlier, sir also encourages learning, sharing and awareness regarding knowledge so much that he has dedicated this beautiful auditorium with excellent acoustics, and all the KIMS group of hospitals connect every Tuesday, Thursday, Friday for regular CMEs within the doctors, paramedical staff as well as nurses. So with this note, I would now invite upon Dr. Rajkiran Dudam, who is the Honorable General Secretary, Indian Rheumatology Association, to address all of you.
Respected dignitaries, Srinivas sir, Bhaskar sir, Vinod sir and Sharat sir, I welcome you all on behalf of Indian Rheumatology Association. It's a wonderful gathering, and the origin of this ERC has started almost nearly 10 years before, when myself and Sharat sir were traveling from US after attending ACR when we are coming back to India. So Sharat sir was telling, we have to do something unique in India, a unique conference. So what is our strength over the West? So we were discussing this, and the West has lots of technology and we have a lot of clinical material. So this clinic-based conference and the bedside-based conference is our strength, and with this we can challenge the West. This is our unique strength and unique model which we have over the West. So we will discuss the clinical cases completely for 1.5 to 2 days is what has made this conference start, and I think it's going very successively. For almost the 5th edition is on. So I hope you will all enjoy the next 2 days, and for the youngsters, it's really 2 days of wonderful learning, and most of the young rheumatologists, you are the future custodians of Indian Rheumatology Association. So utilize every minute of this conference, and I once again welcome you all to the wonderful city of Hyderabad. Thank you very much.
Thank you so much, sir. I now request our team to give a bouquet for all the dignitaries on stage for felicitating them. It's time now to unveil the souvenir for this year. It is a digital souvenir. I request Dr. B. Srinivas and all the other dignitaries to unveil the digital souvenir.
So this year we want to go paperless to save the trees, to save money. So I request Dr. Basravaru and Srinivas to digitally release the CRC 2026 digital souvenir. Now after this you can just click the QR code. Within seconds you will have souvenir in your mobile.
More than saving, nowadays nobody is reading the books, everybody is the cell phones, digital. So that way it will help, at least you people can read.
I hope you appreciate this effort. I saved 6 lakhs just by doing this. So do you like it? Yes. Thank you. You can share with the rest of our colleagues.
They are saying they like the 6 lakh rupees.
We are overshooting the inaugural time. We shall conclude this with our national anthem. As end of the day, we are all proud Indians working tirelessly for making our country proud. So please stand up for our national anthem.
गाहे तव जय गाथा
Thank you so much. We'll have a quick photo shoot now. Can all the doctors come on to the center section? The photographer will be towards the stage and he'll take the photo. Please quickly come converse together towards the center section.
Please come to the center part of the hall. We're going to have two types of photos. One only with the rheumatologist, rheumatologist and other elite specialties, all the doctors. Then we have supporting staff. They will join us for the second group photo. So I request everyone to come to the front. Come to the middle of the hall, please. By today late afternoon, your photograph will be ready to take. It will be framed and given to you.
Not just 2 days.
మేడం మీరు అందరూ సైడ్ రండి కార్నర్ రండి అందరూ మేడం మ్యామ్ యు ఆల్ సెంటర్ కి యు ఆల్ సెంటర్ యు కెన్ గో సెంటర్ మేడం సార్ మీరు ఉన్నారు కదా సెంటర్ రండి బ్యాక్ సైడ్ మీరు సెంటర్ రండి చేయండి మ్యామ్ యు ఆల్ Hello, hello. Sir, please come center, sir. Last row, sir. Yeah. Center gap. हाँ सर सर మీరు జరగండి సార్ ఉన్నారు కదా ఈ కార్నర్ జరగండి ఇట్ సైడ్ మొత్తం ఫ్రీగానే ఉన్నారు కదా ఇట్ సైడ్ మొత్తం సార్ ఎవరు వినట్లేదు
హలో రేపు పేపర్లో చూసుకోవాలి మీ ఫ్యామిలీ మెంబర్స్ అంటే కొంచెం ఇటు సెంటర్కి రండి
Can you please?
Back side only, back side. Sir, back side. లేదు సార్ ఇదంతా కనపడదు బ్యాక్ సైడ్ ఎక్కడ వరకు చెప్పండి
let's all join.
All staff, wait, sir, wait, sir. All staff. Back. Geeta, back and the Kali on this, back and the Kali.
Yeah.
Okay.
Please join us in 10-15 minutes back to the auditorium after having a tea break. Thank you all.
Side.
I request all the delegates to have tea and snacks on your left side, and all the faculty and senior IR members to go on to your right side. This side is for faculty and senior IR members, and the other side is for the delegates. Oh, Chennai, sir. Separate తీసుకోండి సార్ తీసుకోండి సార్ చెన్నై సిరమోస్ట్ కంటిన్యూ సీనియర్ సార్ సార్ సత్యపతి సార్ మీకు ఎలా కావాలో చెప్పండి సార్ మీరు జడ్జి కింద పెట్టండి మాస్టర్ జడ్జి You don't want to have a cup of tea or coffee? So I have an announcement for you. The two activities with IPCA and hetero. Hetero, they're giving, you have to answer some quick question. They have a gift for you. And in the IPCA stall, also there is an activity. If you participate and win, you get the latest Rheumatology Secrets book. If you want that book now, you can go. Please. The latest 5th edition of Rheumatology Secrets is waiting for you. Please claim your gift now. Please, go. Faculty for the pediatric session, the exciting session we're all waiting for. I'll ask, can I ask Dr. Suma Balan, is she here around? Oh, thank you. So I invite Chairperson Dr. Suma Balan and panelists Dr. Anjani Gummadi and Dr. Vignesh, rapporteur Dr. Aparna Tangaraj. Over to you, Dr. Suma.
Hello, everybody. It's good to be here. It's good to be here. Before I start this session, I think we need to acknowledge those people who reviewed the abstracts and permitted this session to be presented, to be held here. So, Dr. Supreet Basu, Dr. Saru Shekhar, Dr. Kirti Vardhan, Dr. Siddharth Jain, Dr. Jitin Matthew, Dr. Kausav Mishra, Dr. Fani Kumar, Dr. A.N. Roy, Dr. Saumya Ranjan, and Dr. Anushri Kant. So all these people have patiently gone through and reviewed the abstracts and selected the 4 presenters today. The first presenter today will be Dr. Mahima Khatkar from KGMC Lucknow. Dr. Anjani Gummadi and Dr. Aparna Tangaraj are both from Hyderabad itself. Dr. Aparna works with the KIMS group and Dr. Anjani works with Ankura Clinic, and Dr. Vignesh is teacher to both of them and from PGI Chandigarh, an additional professor in PGI Chandigarh. So welcoming the faculty for the session, the students for the session. There were totally 21 abstracts received, and the top 4, the first is Mahima's with an infant with arthritis, hearing loss, and recurrent infections. The stage is yours, Mahima.
Thank you, ma'am. Good morning to all the faculty members. My name is Dr. Mahima. Coming to the case, my case is 2-year-old boy who presented to us with fever since birth, which was intermittent, 100 to 101 degree Fahrenheit, coming 10 to 15 days in a month. The child was well between the episode, and initially the fever was relieved with antibiotics, but later had no response. There was also associated recurrent respiratory infection, though not requiring any hospitalization or IV antibiotic. This was also associated with erythematous maculopapular rash over trunk and the limb, which was concurrent with the fever and resolving with the fever episodes. There was also pain and swelling of bilateral knees since 1 year, leading to the child with difficulty in walking and squatting. Parents also reported failure to weight gain. As such, there is no history which can suggest the recurrent infection or any TB contact. So, child was born out of non-consanguineous marriage, delivered at 37 weeks of gestation via the cesarean section. Birth weight was 2.5 kg, immediately cried after the birth. There was no ICU admission, suggested that the symptom complex is not related to any perinatal complication. As such, there is no family history of similar illness or any autoimmunity in the family, except for second order birth. Male child was died at 1 month of age due to undetermined cause. Child is vaccinated till age, except for skipped vaccination at 14 weeks. There was delay in language and social milestones. As such, motor milestones were normal. So on examination, child was febrile with pallor present and generalized lymphadenopathy with largest lymph node of inguinal of 1.5 into 2 centimeter. Growth assessment was suggestive of weight, weight for length and length for age. All of them were below -3 standard deviation according to WHO classification. Mid-arm circumference was 10 centimeter and head circumference was slightly higher in the normal range. Systemic examination was largely normal except for the umbilical hernia and hepatomegaly of 2 centimeter below the right costal margin. Bilateral knee were tender and swollen, along with there was bony enlargement. So at this stage, so there was umbilical hernia, along with that there is frontal bulging and slightly enlarged head circumference with signs of malnutrition. So at this stage we have a child who presented from birth and having multi-system involvement with fever, rash and arthritis. Along with that, there is acute on chronic malnutrition, suggesting that their chronic inflammation is ongoing, so leading us to autoinflammatory and genetic disorder rather than to the infection. So we kept our differential as systemic JIA and autoinflammatory syndrome. So lab evaluation was done. It was suggestive of anemia with HB of 6.1, leukocytosis, thrombocytosis with raised inflammatory marker, ESR of 58 and CRP of 82. Workup for anemia was done, which was suggestive of anemia of chronic disease. Workup for fever was done. Blood culture and urine culture were sterile. Gastric aspirate to rule out TB was negative, and serum procalcitonin was normal. CT abdomen was suggestive of hepatomegaly, as such there was no significant abdominal lymphadenopathy. Bone marrow was suggestive of erythroid hyperplasia with lymph node. FNAC was suggestive of reactive lymphoid hyperplasia. So X-ray of the child was suggestive of irregular epiphyseal surfaces with epiphyseal enlargement and metaphyseal widening, suggestive of chronic inflammation ongoing. Ultrasound bilateral knee was suggestive of synovial effusion along with power Doppler update, suggestive of knee synovitis. ENA and RF was negative. So at this point, we have a child with fever, rash, and arthritis, and since birth and signs of chronic malnutrition, we kept our differential as systemic JIA, but having predominant arthropathy along with frontal posing, we also kept the possibility of autoinflammatory syndrome. So assuming systemic JIA, we started the child on steroid 1 mg per kg along with methotrexate, and nutritional supplementation was given. In Feb 2025, that is around 3 months of treatment, the child continued to have fever, with a possible precipitation in the winter, and there was bilateral knee persistent swelling with gradual contracture formation, and there was new erythematous raised urticarial rash present over the trunk and the limbs. Parents also noticed decreased hearing, which was associated with left side ear discharge. ENT evaluation was done, which was suggestive of left ear CSOM. So topical antibiotics were given. There was no history which was suggestive of eye involvement or any CNS involvement, and as such eye examination was also normal. So child continued to have anemia, leukocytosis, thrombocytosis along with raised inflammatory marker. This led to this make us to think towards autoinflammatory syndrome, mainly cryopyrin associated periodic fever syndrome, and we went for whole exome sequencing. So this is the report showing the NLRP variant of NLRP3 gene, in which this particular variant C.1697T2C led to missense mutation leading to gain of function mutation of NLRP3, which is known to be associated with CAPS spectrum, and this gene is mainly associated with familial cold autoinflammatory syndrome. Till now, this variant is, according to ACMG classification, this is likely pathogenic, but this specific variant which was present in our child has not been reported in previous registry which have been documented for CAPS. So clinical evidence for this variant was not documented. But taking the clinical scenario along with the genetic sequencing, we suspected the CAPS as our diagnosis. So to confirm this finding, we went for the functional evidence of NLRP3 inflammasome hyperactivation. So first notice at the baseline, serum interleukin 1 beta level is 0 picogram per ml, which we suspect in CAPS as due to the short half-life of interleukin 1 and locally released. So we went for peripheral blood mononuclear cell functional assay. So at the baseline, mononuclear cell were releasing more interleukin 1 as compared to the healthy control, and after priming and activation.
Nodal centers. I think KJMU must be one of them.
We have already enrolled the child in that, but we through SGPGI, sir.
Yeah, so it is important to pursue actually, because the drug needs to be imported and then given. Yes. So we have started Anakendra. We have started using Anakendra for many of our patients now. So through the National Program for Rare Diseases, and they do exceptionally well. It's like a game changer for them.
I'll take that question on thalidomide. Yes, it is. If you have absolutely nothing, that is probably the best drug to resort to, at least till you can get them on to IL-1 inhibition. thalidomide and lenalidomide do have TNF alpha and IL-1 inhibition properties. It's not as good as anakinra at all, but it does help to some extent. There are patients who have been put on this long term, but they have their own complications in the long term.
Can I just look? A lot of this GIA patient when they become adult, then they are sent to us. I still remember, and I was convinced because we have been teaching earlier when not many pediatric rheumatologists were available in army. We were doing it. So, JAK inhibition. Now, I still remember in our Gangaram hospital, this child had come. He was getting, they could not afford the treatment. So, I put them on JAK inhibition. And with the tofacitinib, absolutely. And about 10 patients I have now, which they do very well on the, so your comment on the small molecules, JAK inhibition.
In systemic JIA, the ones who have predominant arthritis,
fever,
the persistent,
absolute fever gone, and they are in follow-up and they were having fever for a long time.
Yeah.
But absolutely gone, fever gone, and all this. So beautiful response.
Yes, the persistent arthritis, there is a subset of systemic JIA who will respond to JAK inhibition. There is a certain subset of them. If they respond very quickly. Otherwise, they're not going to respond at all. I think, Mahima, we'll close your session and we'll move on to the next presenter.
Excuse me, sir.
Congratulations,
sir,
and thank you.
Excuse me, sir. I have one doubt, sir. In National Program for Rare Disease, if the whole exome is negative and the clinical phenotype is fitting, can we enroll such child, sir? Because
you can enroll provided the criteria is satisfied. So for some of the NOMID, you may not have mutation because there are somatic mutations described in neonatal onset multisystem inflammatory disease.
Yes, sir, because we had issue with enrolling one child because her whole exome was negative because she was not, unfortunately, she also had features of autoinflammatory syndrome, but she couldn't get enrolled because the whole exome was negative. So can we just
the phenotype should match with NOMID. If the phenotype matches with NOMID, you can definitely.
Irrespective of the whole exome negative.
Yeah.
Okay, thank you, sir. Thank you very much.
You might need to convince your geneticist, show them the diagnostic criteria and convince them. Most geneticists are very poorly aware of autoinflammatory syndromes. So you need to do the extra work in convincing them.
Thank you, ma'am. Thank you very much.
So the next presenter, When Bones Whisper Lupus, Unmasking a Hidden Interferonopathy, Dr. Kirti Vardhan Yeram, NIMS, Hyderabad. Please come.
Good morning to respected faculty and my dear colleagues. So, as Madam rightly presented, so I will be discussing about the case about bones whispering about lupus. So our child is a 12-year-old child. He was well until 6 years of age. Then he developed recurrent febrile episodes. The fever frequency was 2 to 3 episodes per month, and it lasted for 2 to 3 days. And he reported chills, and that was intermittent pattern. And he also reported there was occasional painless oral ulceration. And he presented to us at 12 years of age with jaundice and shortness of breath. Other systemic features include failure to thrive and growth retardation over the past 6 years. Normal growth was reported until 6 years of age, and later this growth retardation was reported. And there was also easy fatigability, loss of weight, loss of appetite, and the weight loss was unquantified. Here, going to the significant past details, he was absolutely normal until 6 years of age. At 6 years of age, he had severe anemia with jaundice, and he was hospitalized for approximately 5 days. Then he received 2 units of packed red blood cells, and probably he was treated with oral corticosteroids for 1 month, which we don't have any records available. And he is developmentally normal. Age achieved milestones were normal up to 6 years, and cognition and school performance is normal. He was born through consanguineous marriage, that is 3rd degree consanguineous marriage, and there was no significant family history, no history of any features suggestive of either autoimmunity, autoinflammation, or immunodeficiency. And significant negative history, child also doesn't have any history suggestive of infections. So going to this examination, his height and weight are below par, and height is less than 3 standard deviation, and his body mass index also in lower normal range. And his upper segment to lower segment ratio, upper segment is increased when compared to lower segment. And this is the child. And there was pallor and icterus and cervical lymphadenopathy. There was a short stature, which I've already discussed. Chest was barrel shaped with reduced anterior posterior chest expansion, and there is mild mid-facial hypoplasia and no coarse facies. And there was mild hepatosplenomegaly on examination, and neurological examination is normal. So these were the investigations. So we can see there is anemia, which is macrocytic, and there was leukopenia. Elevated LDH was present. And as a part of evaluation of this anemia, we suspected autoimmune hemolysis. Direct Coombs test is positive, and peripheral smear showed macrocytosis. There is no thrombocytopenia, and bone marrow aspiration showed erythroid hyperplasia without any dysbiosis. And serology, ANA immunofluorescence was 3+ nucleolar pattern, blot was negative, and complements were normal. Immunoglobulins were done, which was normal, and NCCT brain as a part of evaluation was normal. So what are the issues of this child? There were fevers, fatigue, weight loss, oral ulcers, cervical adenopathy, and mild hepatosplenomegaly, short stature, barrel-shaped chest, autoimmune hemolysis, there is leukopenia, and ANA positivity, now presented to us with AHA flare. So what differentials can be considered? So after brainstorming, we have considered our possible favorite diagnosis as childhood lupus, or it can be type 1 interferonopathy, or possibility of autoimmune lymphoproliferation, or IEI with immune dysregulation, which is non-interferon type, or periodic fever spectrum, that is rare possibility, that also was considered. So all these differentials were considered. There are features for and against, but we have considered these differentials. So later, because of this short stature on evaluation, we have done this imaging for this child. What can be observed here? So if you can closely observe the vertebra, the height is less but width is more. There is platyspondyly. And in metaphysis also you can observe they are widened and they are sclerotic. So adding to our issues, X-rays showed platyspondyly with widened and sclerotic metaphysis. We have treated the autoimmune hemolysis part with steroid, and azathioprine was given. Later, monogenic cause was suspected, and monogenic lupus was suspected in this case, and whole exome sequencing was sent. And here we can observe that genetic mutation was seen in ACP5 gene in exon 4, which is a deletion that is causing frame shift and that is causing premature stop codon. And according to ACMG classification, this is likely pathogenic. So what are we dealing with? We are dealing with a condition called SPENCID. What is SPENCID? It is spondyloenchondral dysplasia with immune dysregulation. If you add I, it is SPENCIDI. So Sanger sequencing of mother and father were heterozygous for the same mutation. So we went ahead with protein analysis. So here, before showing you the protein structure, here you can see that there are 325 amino acids in this protein, and N-terminal is shown as green and catalytic is shown gray. What happens here? Because of this deletion, the mutant protein caused shortening of the protein, and there is only 158 amino acids. This caused nonsense mediated mRNA decay, and there was functional null allele hampering the function of the protein. In this 3D structure, you can see that the red thing is the 136 amino acid, which was lost due to truncation. And here also, after extended analysis, we have seen that disulfide bonds are very important in the red structure, which was lost because of this deletion, and that resulted in dampened function. So briefly, this ACP5 or trap protein helps in phosphorylation of osteoprotein. Without that, there will be enhanced TLR9 signaling, which results in interferon alpha production and lupus-like autoimmunity. These are the different manifestations of SPENCID. Our case had platyspondyly, and our case also had this sclerosed diaphysis. And there was also autoimmunity in the form of autoimmune hemolytic anemia. Different mutations are described in literature, but ours is a novel mutation. After extensive search of the literature, we have found out that C407 deletion is not reported till now. So this is a novel mutation in our child. So key points are SPENCID should be suspected in skeletal dysplasia with autoimmune cytopenia and lupus phenotypes. Ours is a exon 4 deletion, which is novel. It disrupts trap catalytic domains, causing complete functional loss. And early integration of radiology with genomic testing is essential for diagnosis, and targeted therapies such as JAK inhibition, which we have not used in our case, may offer disease-modifying benefit by addressing the root interferon-driven pathology. And follow-up of the patient is for 6 months. He is doing well on azathioprine. So questions for panelists would be, what are the red flags that reliably distinguish SPENCD from early onset lupus in ANA positive? And in suspected interferonopathies, should exome sequencing supersede? And which functional assays can be used? And whether we should definitely use JAK inhibitor in this patient, or can we monitor on the azathioprine which we are using? And based on the different types of variants I have shown, whether they correlate with disease severity or treatment responsiveness. Thank you.
Thank you.
Coming to the questions, red flag signs which will most reliably distinguish SPENCD from early onset SLE. First, I would want to highlight the red flag signs to think about monogenic lupus. So in a child with very early onset SLE, less than 5 to 6 years age of onset, a child who is having severe phenotype, child having associated skeletal dysplasias or very distinct neurological manifestations, SLE with infections, SLE in a child who's born of consanguineously married couple or having a significant family history. And when we work up this child, you see that the ANA is positive, but the complements are negative and normal, and the dsDNA is negative. And along with all this, if the child is also having poor growth from early age, then definitely like this child who's having a stunted growth, we definitely have to think about monogenic lupus then, rather than just labeling them as juvenile SLE. Coming to SPENCD, definitely in a child with early onset, severe phenotype, associated skeletal dysplasia, having shorter upper limbs, rhizomelia, and these changes which you have highlighted on the X-ray, platyspondyly and metaphyseal irregularities, we need to think about SPENCD. Also in children who have developmental delays, seizures, spastic paraparesis, along with cytopenias and SLE phenotypes, SPENCD or interferonopathy should be considered. This child didn't have any developmental delay, but in most of the interferonopathies, we do see some component of developmental delay. Coming to the second question, in suspected interferonopathy, should we do an early whole exome rather than immunological and radiological investigations? I would say, when we suspect early onset lupus, whether interferonopathy or anything else, it should be done simultaneously. You do the clinical workup, immunophenotyping, along with a whole exome analysis depending upon the case scenario. Coming to the functional assays in SPENCD, you have beautifully depicted the TRAP activity, which was low in this case. The other parameters which can be done are osteopontin levels. These will be definitely high in the serum, urine, and dendritic cells. Because of the absence of TRAP activity, there will be hyperphosphorylation. That is the reason there will be a lot of calcification and these bone dysplasias. We can do osteopontin levels, but I think that will be only done in research basis and will not help much in our treatment modulation. What is more important and is gaining attention is the interferon signature. Interferon signature and profiling definitely will help us in understanding the severity of the disease and also will help us in monitoring the treatment response. So doing a baseline interferon signature, treating the child, checking the response and repeating the interferon signature will help us in functional validation and also has therapeutic implication. So in this child, once we have a diagnosis, definitely I would want to use JAK inhibitors or targeted interferonotherapy as the treatment rather than rescue treatment. Azathioprine has helped this child for some phenotype, that is for the cytopenia, maybe Azoran is helping, but for prevention of the further progression, stopping the bone dysplasias, we definitely have to add JAK inhibitors. And the last question is, do specific variants correlate with disease severity? I'm not fully aware, but from what I understand, frame shift mutation or the nonsense mutations in which there's complete loss of activity of the protein definitely will have more severe phenotype, and it will be very difficult to treat them with JAK, only simple JAK inhibitors like tofacitinib. They may need some monoclonal antibodies as well.
Again, beautifully summarized. we would invite questions from the audience. Yes, please.
One of the markers is that they'll have basal ganglia calcification. So that is a simple functional assay which you can do to find out whether the interferonopathy is the main culprit here.
Yeah, so if you get basal ganglia calcification, that's a very important pointer for underlying type 1 interferonopathy. But if you don't have that, doesn't rule out. So you always have to correlate with the clinical phenotype as well as the immunophenotyping. The one thing which we have done in this session is, can you go back to the genetic diagnosis slide? I think all the fellows, you should start writing the genetic report like this. Don't just copy paste the reports. Once you start writing it, you would understand it much better. So you need to know what is the gene, what is the type of mutation, whether it is heterozygous or homozygous, whether it is missense, frame shift, because it makes a lot of change in the interpretation. When you interpret it correctly, you will land exact or the correct definitive diagnosis. If you don't know to interpret, then you may land up in a dilemma, whether this is a VUS or whether it has a clinical correlation. So the first step to understand any genetic report and how to correlate it clinically is to understand the genetic report and try to write it, try to understand one by one. You don't get the complete knowledge just with one single case, but at least start writing the report. At least understand whether it is heterozygous, missense, or what is the type of change. So that is very important. Probably we have 2 more cases, sir. Yeah. So in this case, probably I can take maybe. So this is a ACP5 variant, and this is a single nucleotide got deleted at the 407th position, at the cDNA position. So it is in the exon 407th position. And this is leading to a protein change, which is a frame shift variant. As I correctly pointed out, it is leading to a premature termination, probably a loss of exon here. And if you have a frame shift variation, it is going to definitely result in a loss of function. And this mutation is definitely a disease-causing mutation. And you have a suggestive clinical phenotype as well, the skeletal deformity and the autoimmune hemolytic anemia. So the picture is completely matching with the genotype. And one more caution I would suggest you is, whenever you're sending a whole exome, you need to have a complete clinical phenotype. Without complete clinical phenotype, don't ever try to interpret a genetic report, because only with the clinical correlation you would be able to come up with some conclusion whether this variant is really going to, is really meaning for your patient or not.
I think one thing to add, I think for the adult rheumatologists, I think this 12-year-old also can come to adult rheumatologists as well. I think here the striking thing which I understood is autoimmunity, immune dysregulation with skeletal dysplasia, which is very unusual for lupus. So lots of interferon signature type of clinical presentation can also be seen with lupus. But I think this skeletal dysplasia, if any one of us sees skeletal dysplasia in 12-year-old, 15-year-old, I think with the background of lupus-like picture, even though ANA positive, I think we need to look for this genetics.
Definitely, yeah.
If there are no more questions, we can stop this case and move on to the next one. Well done, Dr. Kirtivardhan. And next, I'm calling Dr. Vimal Manekshaw from KIMS Hyderabad to present Gaining by Staining, Unmasking IgG4-RT.
Good morning, everyone. We shall see what we have gained by staining in our case. So, our case is a 13-year-old male who presented to us with complaints of painless, diffuse, red fleshy swelling of the gums over the right lateral incisor, canine, and premolar, associated with minor bleeding on brushing since 9 months duration. Regarding other history, he had no history of halitosis, which indicates poor oral hygiene, no history of prior dental procedures or orthodontic use, no history of wisdom tooth or discomfort after meals, which indicates any local irritation which can cause reactive gingival enlargement. There was no history of recent change in toothpaste or any chewing gum habit, which are known triggers for plasma cell gingivitis. There was no history of mouth breathing, which could indicate chronic gingival dehydration and reactive irritation and gingival hyperplasia. There were no history of any drug intake like valproate, phenytoin or cyclosporin. He had no constitutional symptoms. There were no recurrent epistaxis, nasal crusting, otitis, hearing loss, hemoptysis or hematuria. No recurrent red eye, chronic cough or skin nodules. No EC fatigability, recurrent infections or EC bruising also. On examination, he had good oral hygiene. There were no dental crowding or dental plaques, no ulcers. The swelling was ill-defined, diffuse, erythematous. It was smooth and fleshy, soft in consistency, non-tender, and it bled easily on manipulation. There were no ulceration or discharge. It extended from the marginal gingiva to the labial mucosa, involving the interlining attached gingiva and the alveolar mucosa also. No pallor, skin rash, lymphadenopathy, hepatosplenomegaly or bony tenderness. Other systemic examination and his vitals were normal. So with these history and the examination findings, he was evaluated outside and the initial biopsy was done in an outside place. And this biopsy had shown dense chronic inflammatory infiltrates which contained fibroblasts, plasma cells with Russell bodies. And the evaluation outside had shown anti-Jovan antibody to be positive, and that was the reason for his referral to rheumatology department. On reviewing his other investigation reports, his CBP was normal, ESR was mildly elevated, and his renal function tests were normal. LFT showed mildly elevated globulin. ANA by AF was negative, and ANCA by ELISA were also negative. So what we had here was a chronic inflammatory gingival enlargement, but that inflammatory gingival enlargement was only localizing to a few group of teeth. But history and examination features ruled out any local causes which could explain this gingival enlargement. And history, examination and evaluation so far did not provide us any clue for any other systemic causes. And then the initial histopathology demonstrated dense plasma cell infiltrate, but there was no trigger for PCG as there was no use of any high mint flavored toothpaste, no chewing gum habit. He did not use any strong spices like cardamom. So the trigger for plasma cell gingivitis were not there. So at this point of time, we considered the possibility of IgG4 related disease. And now further workup revealed serum IgG levels to be 2350 mg per deciliter and IgG4 subclass to be 515 mg per deciliter. Again, the upper limit of normal was 198.5. And further IgG4 staining of the histopathology sample revealed the IgG4 staining showed more than 10 IgG4 positive plasma cells per high power field and IgG4 IgG plasma cell ratio to be more than 40%. However, there was no storiform fibrosis or obliterative fulvitis, which was exempted because in oral lesions it is uncommon to have fibrosis and obliterative fulvitis. And when we did screening examination to look for any other internal organ involvement, a CECT of the head and neck with chest and abdomen was done, and it showed a mildly bulky right more than left submandibular salivary gland. So coming to the 2020 revised comprehensive diagnostic criteria for IgG4 related disease, item 1, we had one organ involvement which showed diffuse or localized swelling, and we also had serum IgG4 to be more than 135. In our case, it was more than 500. And for the histopathological involvement, we had plasma cell infiltration with IgG4 positive plasma cell and IgG4 to IgG cell ratio of more than 40%. So we had definite diagnosis of IgG4 related disease. So following this, as he had no other organ involvement, he was started on low dose glucocorticoid with methotrexate. And on follow-up 6 months post initiation of treatment, the gingival lesion was on the regressing trend. So the key learning points here were isolated gingival involvement is an extremely rare manifestation of IgG4 related disease, and storiform fibrosis and obliterative fulvitis may be absent in oral lesion and are not mandatory for diagnosis. Both IgG4 related disease and plasma cell gingivitis both shows dense plasma cell rich infiltrates without any storiform fibrosis. This makes routine histopathology insufficient for distinction between these two similar conditions. This case underscores how IgG4 immunohistochemistry becomes the only decisive tool to differentiate between IgG4 related disease from a clinically and histologically similar plasma cell gingivitis, highlighting a rare but important diagnostic pitfall in this scenario. My question to the panelists would be, what is the optimum long-term management strategy for isolated gingival lesion in pediatric IgG4 related disease, and what clinical and imaging surveillance protocol should be followed to monitor evolution into a multi-organ involvement in cases presenting with initial isolated oral involvement? Thank you.
Excellent presentation, and Dr. Vignesh,
Yeah, so pediatric IgG4 related disease, we tend to see more of a localized. Head and neck is the common site. So commonly we see proptosis as a major presenting manifestation because of the involvement of the orbital and the retroorbital tissue. Salivary gland we do sometimes, but I haven't seen gingival presentation of IgG4 related disease as well as our the co-panelists here. Management is not adequately defined here, so either mycophenolate mofetil, azathioprine, or a methotrexate for a localized disease. I'm not talking of a systemic disease. For a localized disease, they may well respond only to azathioprine or a mycophenolate mofetil. The long-term data is scarce, but whatever our experience is, they don't tend to progress to a systemic disease, at least in the pediatric age group, what we have seen so far. When if they develop relapse, it occurs at the same site actually. Don't develop a systemic disease. So we don't do a PET scan, at least in the pediatric age group. So I would ask the other co-panelists to comment more on this.
I think at onset I would do a PET to see what systemic involvement is there, and to some extent you can use IgG4 levels to monitor. The rest would be clinical monitoring. I mean, if you don't have any evidence at all of disease elsewhere, I don't think there would be much mileage in repeating PET scans, whole body PET scans to monitor. I have one question actually. How did this patient reach a rheumatologist?
So, Joan was positive.
Sometimes, thank God for people doing ANA blots, no? Very good. The other thing is that I actually saw a case report from PGI Chandigarh in an 18-year-old, exactly similar presentation, where they elected not to use any medical treatment. They used surgical excision. And they've been following up the patient closely and finding the patient to be stable. So maybe when you have very localized disease, that is also something you can think of.
Ma'am, I have a comment. I have had the opportunities, 2 patients who have been having IgG4. They have been going to various specialists. It's over many years. It's a 11-year-old boy. For 4 years, he's been having a jaw swelling. They are treated as osteomyelitis, ATT, then somebody suspected lymphoma. Finally, they came. We did a PET, of course, and we did the IgG4. We actually got the slides back and got it strained from the block. And what I have given is only naproxen. For 2 years I have been following up, and extremely, sometimes in the past 2 years, 1 week of steroids sometimes. He is doing absolutely well. He gets recurrent swelling which goes off with NSAIDs. And I have been following from 9th standard, he's going his 12th. Every 6 months or 9 months he gets it, but again it disappears. So the phenotype can be very variable. So 2 things, even NSAIDs probably will suffice in a milder case. And second is PET, of course, can finally clinch the diagnosis that is inflammatory. Inflammatory, non-infective. PET is quite good. So 1 exposure, I think, at least as you correctly said, initially. So probably it's correctly said as IgG4 RD. We really do not know much about it, and maybe it's evolving. But we are picking up.
When you say jaw swelling, you're talking bone or?
Bone and soft tissue.
Bone and soft tissue. Bone involvement, especially in pediatrics, is extremely rare with IgG4 disease. And I would actually contest your diagnosis to a CRMO of the mandible.
Yeah, in fact, there are certain reports, because I went and read up. I initially diagnosed only as CNO because of response to NSAIDs. But I thought, why it is coming? Because of its recurrence. So maybe it's secondary IgG4 following to CNO. Really, I do not know. Because he has got all features, both in the, I not keen to put it as IgG4, but both in the values and in the biopsy also IgG4 staining was there. And the thing is, CRP actually goes out, and good response to steroids. Good response to steroids. So it's really, in fact, I do not know whether you should do a genetic analysis. Because of economy, I have not done it. I'm just following up. He's doing well.
Yeah, so I'm really not sure with the diagnosis of IgG4 related disease here, but for the fellows, the commonest presentation of mandibular swelling, which comes recurrent form in childhood, is one of the important differential diagnoses, Caffey's disease. And you can get chronic non-infective osteitis of the mandible as well, but Caffey's disease is also one another disorder which you should keep in mind.
Cafe happens in very young children, so we see a lot more. I mean, we now our current count of CRMO is 105, and nearly 20% of these patients have mandibular lesions. About 12% of our patients have isolated mandibular lesions, and what you described sounds to me more like CNO. In fact, you would need to do a whole body MRI to know whether it's CRMO or CNO, because you can have, you can have. I would think this is more likely to CNO, and try bisphosphonates in your patient would be my advice. That would completely wipe it out. It's not, I don't think it's, because I can tell you one thing, the Sentinel paper on IgG4 disease, John Snow, Vikram Deshpande is my batchmate and very, very close friend. So once some kind of a patient like this, I had discussed with him, and he said, bone IgG4, no, no, no. That's something he told me, which I remember very clearly. I mean, this thing. So I think twice before you attribute bony lesions to IgG4 disease.
Yeah, and IgG4 related disease, the management is corticosteroids and DMARDs. So isolated NSAIDs is not advocated because of the fact that it may result in organ damage. So that is the thing which we want to prevent actually. So steroids and DMARDs and biologicals are the cornerstone of the management of IgG4 related disease, provided the diagnosis is sure shot, either by histopathology or by imaging.
So what I understood is, like in pediatric, it is very localized and limited. So it can be managed by excision rather than exposing the kid to the systemic steroids.
It's difficult.
It's difficult to do. So like just fundamentally, I wanted to understand why is it the same disease behaving differently in children? Like, do you have any problem with, because it's an inflammatory, fibroinflammatory disease. So do you have any issue with fibroblasts here? What exactly is the problem here? Like, can you add mechanistically?
I don't know the answer to that question specifically. We do see retroperitoneal IgG4 disease. Overall, the incidence is very rare in children. So each of us, even who see a good number of pediatric rheumatology patients, will have a small single-digit numbers only of IgG4 disease, proven IgG4 disease. So I think overall it's a rare disease. So to be able to answer your question would be very difficult. And yes, possible. Yes.
Yeah. How long to use the steroid? Any preference of steroid? And does it have effect on the growth? Because they are children. Any preferential steroid to be given? How long to give in?
Any long-term use of steroids has effect on growth in children. And generally, therefore, we are very loath to use long-term steroids. I mean, in diseases like lupus, JDM, etc., where you definitely need high-dose steroids in the beginning to start with, even those patients, we are much more aggressive with the secondary immunosuppression to bring down the dose and try to get down to an alternate dose of low-dose alternate day steroids by 6 months, 8 months or so. Because definitely it has impact on growth. There are two things here. One is the longitudinal growth. The second thing is that remember that your bone mineral density is largely laid down during adolescence. Peak bone mineral density formation is during adolescence. And around that time, if you give them too much of steroids, you're actually reducing their bone bank for life, actually. So there are many implications when we use steroids in children that we need to be little careful of compared to the use in adults. Regarding any kind of steroid being more protective, I don't really think so. I think the answer would be to limit the use of steroids as far as possible. I personally, I don't think many of us use deflazacort with that understanding. Vignesh?
No, they say that deflazacort has a little effect on the growth plate compared to the other steroids.
I'm not sure that we are adequately impressed with that thing. Generally, our thing would be to reduce the exposure to steroids as far as possible.
Ma'am,
I think we will have to move on to the next case.
One question. As it is just the localized, only on gingiva, whether the topical steroid we can apply and see, rather than, because we have screened systemically, there is nothing. Even there are case reports which they have just applied the topical and they have done well, ma'am.
I think it's a very good point to consider in this scenario, actually.
Yes, because of the steroid side effect, growth and all those things are there. So we can consider.
We are in a rarefied area. There are no specific recommendations for this group of patients. Because this kind of just gum involvement.
It was used in this
case,
two cases in OMFS, they have managed with topical steroid and they are doing well, ma'am.
So you should publish it when you've used it so that
It's OMFS, not in our this thing, but when they have presented the case, they have managed with this.
Okay. Thank you very much. Very interesting case. And now we'll move on to the last case. And this is being presented by Dr. Trisha V. from Rainbow Children's Hospital in Bangalore. And she's going to present a case on recurrent cellulitis and pyoderma gangrenosum, the diagnosis journey in a child with recurrent facial lesions. Carry on.
One second. At 1 p.m. there will be poster presentation and all the presenters should be ready at the poster podiums.
All poster presenters and judges are requested to present at their designated poster area by 1 p.m. sharp. For the round 1 group, 1 to 1:30 should be present now.
So what you have done is that, so we have divided 1 hour into 2 halves. The first round is now for the first half hour 1 to 1:30. Then the second round will be the rest of the poster session. Is it clear? So you have circulated the, okay. So the judges also. Thank you. So I request the judges and the poster presenters, please go on to the poster area, which is on your left side. There is a hall next to the washroom area. It is signboards are there. If you need, you can take our help. Thank you.
Should I start? Good afternoon, everyone. Today I'll be presenting the case recurrent facial lesions in a child, recognizing the pattern in this disease. So this case is regarding a 4 years, 5 months old boy who first presented to us in the month of January 2023 with history of fever for 5 days and painful left upper lip lesion, for which they consulted to a general pediatrician and investigations were done, which showed neutropenia with monocytosis and high inflammatory markers with CRP of 79. So the child was referred to pediatric surgery department and he had undergone debridement and he was found to have a defect of 3 into 3 centimeter with tissue necrosis involving orbicularis oris and vermilion. He was managed as cellulitis with IV antibiotics for 5 days and there was apparent improvement in his condition in this episode. So the second episode was at 4 years, 8 months of age. There was recurrence of fever with swelling and ulcerative lesion of upper lip. He had history of chickenpox 1 week prior to the current episode. The child was started on oral antimicrobials, but there was progression of lesions. He was hospitalized and was started on IV antibiotics. Rheumatology opinion was taken at this point of time. So our differential diagnosis was pyoderma gangrenosum-like lesion or primary immunodeficiency with neutropenia or autoimmune or autoinflammatory diseases. So on detailed history and examination, we found that there was failure to thrive with height and weight less than 3rd percentile. Child was immunized, born of non-consanguineous marriage. He had one elder brother who was well according to the history provided by the family and no family history of any rheumatological disease. So on investigations, there was again neutropenia with monocytosis which was persisted and high inflammatory markers with CRP of 52 and ESR of 113. Further workup was done. Bone marrow was done because there was neutropenia with monocytosis. So we wanted to rule out if there was any bone marrow suppression or failure, but it was normal reactive bone marrow with mature neutrophils ruling out production defect. Immunological workup was done. ANA, IF and anti-dsDNA was negative. ANCA was negative. PID panel was asked, but only IgG was done. Fecal calprotectin was normal. HLA-B5 was negative, and eye screen was uveitis was also normal. APLA showed anticardiolipin IgM positive. IgG was borderline, and beta-2 glycoprotein was IgM was positive. So the child was started on IV antimicrobials and IV methylprednisolone followed by oral taper. So steroids we started because there was rapid progression despite starting of antibiotics and there was high inflammatory markers which were present. And aspirin we started because of APLA positivity. So the third episode was in November 2023. He presented with left eye lesion. So there was fever with left eye lesion, purplish ulcerative in appearance. He again consulted to a general pediatrician and he was diagnosed with preseptal cellulitis. Started on oral augmentin but there was no response. He was admitted and started on IV antibiotics. So investigations here again showed neutropenia with monocytosis and high CRP levels of 174. Rheumatology review was taken and at this point of time our probable diagnosis was recurrent pyoderma gangrenosum secondary to query vasculopathy, Behçet's or congenital neutropenia. We started on IV steroids and also started on azathioprine because of recurrent episodes which he was getting. The child improved clinically but neutropenia persisted, so we suggested genetics for confirmation. So what are the red flags against simple cellulitis? First is clinical clues. The child had recurrent necrotizing lip or eyelid lesions, poor or absent response to multiple antibiotics, steroid responsiveness but relapses on taper, recurrent fever without a clear infective source and failure to thrive. Laboratory clues for neutropenia with monocytosis and normal bone marrow. So in February 2024, he again had flare-up of symptoms on tapering steroids. So at this point of time, the child's phenotype was fever plus ulcerative skin lesions on face or limbs, leukopenia with neutropenia and monocytosis and elevated CRP and ESR. So we continued the child on azathioprine, but the dose was increased and we reinforced the need for genetics. So these are the serial investigations which were done, which showed persistent neutropenia with monocytosis and high inflammatory markers with raised CRP and ESR levels and even elevated transaminases. So differential diagnosis at this point of time was vasculitis or vasculopathy, small or medium vessel vasculitis, pan-like disease or thrombotic vasculopathy. Second is monogenic autoinflammatory disorders. So in April 2024, we got the genetics report which showed homogenic variant of ADA2 gene mutation, which was likely pathogenic. So we diagnosed the child with DADA2 and started on weekly etanercept 0.8 mg per kg per week. Aspirin was stopped because of high risk of hemorrhagic stroke in a child with DADA2. So after getting the genetics report, we re-explored the family history. That time we got to know that there were multiple consanguineous marriages in the family, along with multiple family members who had stroke, from infantile to adult onset. His elder brother also had short stature with skin lesions. So his genetic reports was also positive for homozygous variant of ADA2 gene mutation. We had asked for Sanger sequencing of the parents as well. So fathers, they had got it done. Father was heterozygous variant only and father is asymptomatic. So the learning points in this case is not all recurrent cellulitis is infection. Persistent destructive antibiotic unresponsive lesions mandate reevaluation. Pyoderma gangrenosum like lesions and cytopenias should raise suspicion for monogenic vasculitis. Ask about family history of early stroke. It is a crucial diagnostic clue in DADA2. DADA2 can present primarily with mucocutaneous disease in children. TNF inhibitors dramatically improve outcomes once the diagnosis is made. So at the end of case presentation, my questions to the panelists are, for how common are the pyoderma gangrenosum like or necrotizing ulcerative skin lesions as a presenting feature of DADA2? Underlying pathogenesis of ulcerative lesions, is it vasculitis or neutrophilic dermatosis or ischemic vasculopathy? Importance of persistent neutropenia with monocytosis in this child? Any other clues that should have pointed towards DADA2 earlier on in this child? Starting etanercept for the sibling if the sibling is asymptomatic and father is asymptomatic, so any role of etanercept in the father.
Yeah, a very interesting case indeed. So I think the family history is the biggest clue here towards underlying ADA2 deficiency. I think you have taken the family history after the genetic
No, sir,
report.
we had asked the family history before, but actually we didn't think in terms of DADA2, so the stroke history we didn't ask.
Okay.
So after getting the genetics report, when we asked the leading questions that time, we got to know that there were multiple histories of stroke in the family.
So-
And brother, they were initially from the beginning for brother, they said he was doing fine only.
So may I ask you, do you think the father would have a ADA2 deficiency?
No, sir, it is an heterozygous variant, so he wouldn't have ADA2 deficiency.
He would never have?
No, I mean, he's asymptomatic, sir.
He had stroke.
Father didn't have stroke.
Okay, the grandfather
the
had.
father's brother and brother's son and grandfather had, sir.
So yes, so heterozygous forms, they have been increasingly being reported, especially with a
Compound
late
heterozygous?
onset phenotype, especially with vasculopathy and strokes. So we should not discount the heterozygous ADA2 positivity. Yeah, so that is one important point. Skin lesions do happen. So ADA2 deficiency is a very pleomorphic phenotype. You can have phenotype ranging from vasculitis to cytopenia to lymphoproliferation to immunodeficiency. So the skin lesions could well be part and parcel of the pro-inflammatory presentation of ADA2 deficiency. Underlying pathogenesis, it's well known. So you have a pro-inflammatory macrophages here, the M2 macrophages. The importance of persistent neutropenia, yes. So neutropenia in this child, even when you have a persistent neutropenia, that warrants a genetic evaluation, because neutropenia can be the first sign of any underlying immune deficiency or an immune dysregulatory state. And bone marrow evaluation would give you a very important clue. So if you have a loss of precursors that would indicate a production defect, so that we call it as a severe congenital neutropenia, which can present with similar lesions, the pyoderma gangrenosum-like lesions. Versus if you have a marrow which is full of mature neutrophils, it means it's a production defect. So here your marrow is absolutely normal, which rules out a production defect actually. So that would give you a clue whether this patient would need a granulocyte colony stimulating factor. Any other clues that should have pointed out ADA2 deficiency in this child? The family history, of course. That is the...
Family history was not there.
It was there.
Suppose it was not there.
Still, I would have done it. Still, I would have done it considering the atypical cutaneous lesions and the neutropenia which is ongoing. Starting etanercept, what would you do? I would ask you, there is a homozygous defect.
So we'll start etanercept for
Why
the
would you start it?
It is homozygous variant, so he will present with the symptoms, sir.
Yes, the neurological
Hour
disability can happen if you don't start
Stroke,
them
he
on
might
anti-D.
develop
At least you
stroke,
can
yeah.
prevent the stroke and the comorbidities. Father, I would definitely advise you to do the ADA2 activity. And if he is asymptomatic and if he is heterozygous, ADA2 activity is normal, I would just wait. I would not advise to start an etanercept.
Actually, I would add one thing. Doing functional validation for these patients can be very useful. So looking at the ADA2 enzyme activity by functional testing can also, like for your father's question, that would be the answer. If he has very low ADA2 activity despite being heterozygous, then you may need to think of treatment for him. Okay. And that test is now available. It's sent to Gangaram. It's available in-house in India for us. So it's not that difficult to get done. In PGI is also doing it. So it's not very difficult to get it done. And that would be definitely complementary to your genetic diagnosis so that you know what the level of functional activity of the enzyme is. Okay. Yes.
Initial part, was the biopsy from the skin done? If it is done, what would you expect there? Would that have helped you to arrive at a diagnosis a little faster? Because a lot of biopsiable lesions were there.
Yes, sir.
My hands were itching to biopsy it.
So the first time it was done, sir, so it was culture negative, but the inflammation and all was, no, for the hands we didn't do, sir, only for the upper lip lesion when he had presented for the first time, that time only it was done. Hands we didn't.
What would you expect? Neutropenia?
Sir, inflammatory cells.
Diagnosis was sepsis. Would you see a neutrophilic dominance?
Sir, inflammatory cells we will expect of more of inflammatory cells in the biopsy.
So I think the more important question here is, why doesn't the child have the strokes? Why does he have this peculiar skin lesion? And then, is that true that the ADA variations will present with pulmonary hemorrhage, with stroke, with skin lesions, but not all of them all the time?
Yeah.
Is that how it is?
Yeah. That is the beauty of ADA2 deficiency. In childhood, we see more of immune deficiency phenotype and immune dysregulation phenotype rather than the vasculitic phenotype. Of course, we do see that. But that is more commonly seen in adults compared to the pediatric age group, because it is probably somewhat related to the ADA2 activity. If the activity is very much low, they tend to produce, present with more of a immune deficiency rather than a vasculitis phenotype.
So very quickly, I have a young boy of 15 who's had 3 episodes of pulmonary hemorrhage and has had ANCA positivity and has responded to therapy. His father had GPA, very severe GPA, and I was thinking of Copa syndrome, but when I sent the test, ADA2 gene comes back positive, heterozygous state, but they report it as Sneddon syndrome. So I was sort of...
Yeah, so it is probably the phenotype which they are trying to mention there, the stroke and the livedo reticularis phenotype. That's what they're trying to hint at when they mention the Sneddon syndrome.
But would that technically be still ADA2-like?
Yeah, it doesn't explain the complete phenotypic spectrum. That is one of the phenotype, but the phenotype can be very variable, like the cutaneous lesions which we have seen in this patient. So I think for ADA2 we need to have a separate conference actually.
So it's the ADA2 which is the pathogenic gene here, and it doesn't matter what the manifestations are. These could be very, very variable.
Yeah, the manifestations can be very variable.
They could be GPA, they could be stroke.
They can be arthritis, there can be stroke, there can be asymptomatic lymphoproliferation, benign lymphoproliferation, just hepatosplenomegaly ongoing with cytopenias. So the phenotype, there is a hematological phenotype, there is a rheumatological phenotype, there is immune deficiency phenotype. So these are the 3 main, but of course we may have other phenotypes as well. But as rheumatologists, we are much sensitized towards the vasculitic phenotype, but we should also be aware of other phenotypes as well.
This patient was APLA positive also, so what should be done? You anticoagulate them also, or?
I had a patient, I just joined that time Gangaram, and I didn't know about DARA2. So this patient was ankylosing spondylitis, some VIP, child. It's about, child means about 20-22. And she had very unusual skin lesions, which I could not, frankly speaking, diagnose. Whole back was, and this was in that Aman series, this case is there. And ultimately skin lesion is skin lesion, and Yeah, stroke. He had a stroke in the eye. So we read, and that was first case I2 Dada 2. So the skin lesions. So that I learned about skin lesions in Dada 2.
Many of the Dada 2 patients are there even with the hematologist because isolated neutropenia is also one of the manifestations. Sometimes
I learned today that
isolated neutropenia. There's a series of hematological manifestation in which they have seen 100% of them had neutropenia to start with. And lymphoma as a presentation of Dada 2 has also been reported. So the spectrum is huge and anything can be as a part of manifestation of Dada 2. Coming to anticoagulation, definitely because this child is having Dada 2 and we are quite sure, even the APLA is positive, it could be just a component of the inflammatory or rheumatological manifestation. We will definitely not anticoagulate this child at this point because there's a risk of hemorrhagic stroke.
Can the enzyme activity be low in the absence of a genetic mutation? What do we do in such cases?
So there are large deletions reported with AD2 deficiency which may not be picked up in the routine clinical exome. So you need to have that at the back of your mind. You may miss large deletions, you may miss intronic variants. So if you are very sure about the clinical phenotype and if you don't get the genetics positive, do the enzyme activity.
How is your patient doing on etanercept?
The lesions have improved now, but he's doing better. Both the siblings are doing better after starting etanercept.
The one thing in this spectrum that you have to consider is that, see, not all patients with Dada 2 respond to anti-TNF. There are, especially the ones who have more predominant hematological symptoms or gangrene kind of skin manifestations, do better with bone marrow transplant. So that is the one thing to keep in mind. So if your patient's improving, that's good.
And I forgot actually, because for ankylosing spondylitis, I gave anti-TNF. The skin lesion was improving. So that's the first time he said the skin lesion is improving.
Great. Okay, I think, thank you very much. Very interesting. And we'll get Dr. Aparna Tangaraj will be the rapporteur to wrap up the presentations now. Thank you.
Good afternoon, everyone. So we had 4 pediatric cases, of which 3 were autoinflammatory disorders. So that shows the importance of monogenic diseases in pediatrics compared to the polygenic rheumatological illness in adults. So coming to the autoinflammatory disease, we have seen one inflammasomopathy, one interferonopathy. Apart from that, we have rhelopathies, cytoskeletopathies, enzymopathies and all. So why do we need to classify them? Because targeted therapy is one of the main things that we have talked so much. So the first case that we have talked is an inflammasomopathy, that is through NLRP3. So for which the target therapy, inflammasomopathy is like IL-1 and IL-18 mediated. So the target treatment here is anakinra. So that is important. And the first case that showed the importance of the diagnosing it early, the child had like a very early presentation, infantile age group, child had neurological manifestation, child had systemic inflammation. And one important point is like that child did not have arthritis, the child had an arthropathy. The child had a bony overgrowth. The child had a physeal and metaphyseal dysplasias. So that is like an important pointer for an NLRP3 there. So apart from that, we talked about screening of ear and eyes for the and CNS for the other inflammation systemic manifestation in the case. And then we also talked about somatic variants and de novo mutations in that. So we need a deeper sequencing, and then we need to, first of all, we need to have an idea it can be a NOMID or NLRP3 spectrum to write the phenotype in the whole exome sequencing. And of course, the treatment point in that case is like IL-1 inhibitors like anakinra for the treatment. The second case is an interferonopathy. So that is like a monogenic lupus case along with spinal platyspondyly leading to SPEN-CD. Yes, we have a lot of monogenic lupus, and we think of monogenic lupus when the child present with lupus-like manifestation in less than 5 years of age, when they have a significant family history, a consanguinity, a recurrent infection, when ANA is positive but dsDNA is negative with C3, C4 being negative. And these are the important manifestation. And these patients have, coming to the clinical picture, they'll have like a very bad neurological and skin manifestation when we usually see a very significant renal manifestation in the polygenic forms. In these patients, we generally see a lot of neurological and skin manifestation. And of course, this being an interferonopathy, a role of JAK inhibitors come upfront for these patients. So this is also one of the targeted therapy that we see. The third case we have seen is IgG4 related disorders. We have seen like how it is different from adult and pediatrics, how in pediatrics it is a localized form, and sometimes a localized steroid treatment also works, and or else systemic steroids works. And here also we talked about the importance of not using long-term steroids in pediatric age group because it can affect the longitudinal growth and bone mineral density it can affect. The final case is DADA2. Like Dr. Vignesh has pointed out, it has like a varied spectrum. It can have bone marrow failure symptom. It can have immunodeficiency. I think in PJ we have like 2 patients with pure red cell aplasia as presentation. Yes, congenital neutropenia is one of the form. Apart from the ones we see like recurrent strokes and vasculopathies that we generally think of DADA2. So these are the other varied presentation of DADA2 that we have to think, and then we have to do ADA2 levels, whether we have to consider the heterozygous variant as significant or not. I think recently we have one patient who had a heterozygous variant of ADA2 with ADA2 levels were low. So then we have consulted Dr. Isabel Mites, who's one of the person who's working in ADA2, and they have published dominant negative ADA2 variants in which the heterozygous form who have dominant negative effect, and even with the heterozygous form they can have ADA2 like presentation needing the treatment. So I recommend everybody to go read that paper also, and I conclude this. Thank you so much.
Thank you very much. We close the session now, and we'll announce the prizes later. Okay. It was a very interesting session. Congratulations to all presenters. Very interesting patients and very interesting cases. Yeah.
Everyone please leave for lunch. The faculty lunch is on this side and the delegates lunch is on this side.
బాటిల్స్ చేసిన బాటిల్స్ అని తీసేసాను.
Good afternoon, everyone. Back to business. And autoimmune diseases. Now I invite Chairperson Dr. R. Subramanian and the panelists Dr. Mithun CB and Dr. Fanikumar, rapporteur Dr. Sriharsha VS. Over to you, Dr. Subramanian.
Good afternoon. We come to this session of inflammatory myositis and autoinflammatory disease and inborn errors of immunity. At the outset, I would like to thank the organizers of CRC for giving me the opportunity to chair this session. And to my left, I have my learned colleagues. There is Dr. Mithun, he's from Kochi, AIMS Kochi, and Dr. Fani, he's from Nizam's Hyderabad, and Dr. Sri Harsha from KIMS. Without wasting much time, I would like to go on to the first presenter, who is Dr. T.G. Sundaram. He's going to talk about teenage muscles put through a shredder, a rare case of juvenile necrotizing myopathy. Over to you, Dr. T.G. Sundaram.
At the outset, I would like to thank the organizers for giving me this opportunity. I think for me, it's an achievement to just be on this podium and present this case. So I'll be presenting a case of myositis in a child. So this was a 14-year-old girl, previously healthy and developmentally normal. She presented with difficulty in rising from a chair or floor and difficulty climbing stairs for the past 1.5 months. And 1 month prior to presentation, she had difficulty in combing hair, and 15 days prior to presentation, she had difficulty in getting up from bed. The weakness was equal on both sides. It was preceded by a small episode of low-grade fever, myalgias, and coryza for 5 days, for 3 days. History of presenting illness: she had no weakness of hand grip, no dragging of feet, no slippage of chappals, no sensory loss. That means no distal weakness, no sensory loss. And then she did not have any signs of connective tissue disease, antisynthetase syndrome, or dermatomyositis features like myalgias, no rash, photosensitivity, Raynaud's, cough, dyspnea. There was no history of bulbar weakness like dysphonia, nasal regurgitation of liquids, or dysphagia. And then, because she did not have any other features of a CTD or lupus, we considered possibility of other myopathies which can be seen in teenage. So there was no history of drooping of eyelids, no squint, no double vision, no reduced vision to suggest extraocular muscle weakness, no diurnal variation of symptoms to suggest something like a myasthenia, no history of seizures, which we thought a mitochondrial myopathy should be a consideration. And then there was no systemic symptoms like weight loss, there was no lump in the neck, chest, axilla, or groin. And past history and family history are unremarkable. She did not have any allergies, she was vaccinated up to date. Examination: her BMI was 17, she was a lean child. Her vitals were essentially normal, a single breath count was 26, so there was no respiratory muscle weakness. A vital examination was normal, skin and mucosa was normal. The general physical examination was essentially normal. On examination, she had significant neck flexor weakness. It was 2/10 on the MMT-8 scale. Deltoid weakness was 4/10 on both sides, so equal on both sides, and she did not have any biceps or wrist dorsiflexor weakness. And coming to the hip girdle, gluteal maximus power was 3/10 on both sides, gluteal medius was 3/10, and quadriceps hip flexor was 4/10. There's no knee extensor or ankle dorsiflexion weakness. And the childhood myositis assessment scale score was 28 out of 52, implying a moderate level of disability. She had a waddling gait because of the gluteus medius weakness. Her palatal and gag reflex were normal. There was no muscle tenderness, and the other systemic examination was normal. We also considered a possible, she could have a subclinical myocarditis, but that was also normal. Her CPK level was more than 20,000 in multiple values. AST was 504, ALT was, I've just written a representative value. All reports were in this range. She had some leukocytosis with 70% neutrophils. HP and platelet count were normal. CRP was normal. Creatinine, electrolytes, lactate levels were normal. Thyroid function was normal. Serum cortisol was normal. And so we, considering an autoimmune pathology in this patient, we ordered a 16 antigen myositis profile which checked for JO1, MI2, PL7, PL12, OJ, EJ, Rho52, MDFI, TIF1 gamma, NXP2, SAE1, PMSCL, SRP, and COO. Everything was negative. So this patient was managed in collaboration with the pediatrics department at my hospital. We gave her methylprednisolone 500 milligram into 3 doses and 1 milligram per kg for 1 month. Absolutely no response. In fact, after 1 month, we reassessed her. Her muscle examination was essentially the same, but to our surprise, her CPK levels at one level, at one investigation was 1 lakh. So the differentials we thought were refractory idiopathic inflammatory myositis, heritable causes like limb girdle muscle dystrophy, facioscapulohumeral muscle dystrophy, mitochondrial myopathies, then other myopathies like Pompey's and McArdle's disease, CPT2 deficiency, carnitine palmitoyl transferase deficiency, and then rare milder forms of congenital myopathy which can come in the second decade like core and myotubular myopathies. And to look at the specific features of these differential diagnoses, this patient did not have any mechanic signs or Haiker's feet. Skin and mucosa were normal, did not show any signs of dermatomyositis. Chest exam was normal, and her pro-BNP was also normal. So there was no myocarditis as well. And went through what all heritable myopathies she can have. So the possible myopathies which can happen in the second decade can be dysphorinopathies, then calpainopathies which can be autosomal dominant or recessive, and then there are multiple sarcoglycanopathies and dysglycanopathies, and then there is this titin associated muscle dystrophy which can happen in the second decade. To look at the features associated with these conditions, the patient did not have any extraocular muscle weakness, no diplopia, no distal weakness, no facial weakness, no winging of scapula, no facial asymmetry, no scoliosis, no pseudohypertrophy of the muscles. And then looking at mitochondrial myopathies, she had no features of fatigue. But she could not even perform the 30-second chair stand test, which is used to test for muscle fatigue. She did not have any muscle vision loss. The fundus and pupillary reflexes were normal. There was no optic atrophy. And then she did not have any history of seizures or intellectual disability, which can raise suspicion of mitochondrial myopathies. And then there was no dyspnea or PND to suggest a myocardial pathology. And then we are faced with this dilemma. What to do next? Whether to do a genome sequencing to look for a muscle dystrophy, or we go ahead with a muscle biopsy. So we thought doing a muscle biopsy should be the first natural step. And what we found was that this patient had multifocal endomysial macrophage infiltrates with severe necrosis and wide variation in nerve fiber diameter with severe myophagocytosis. So I've shown the IHC picture here. This patient had diffuse sarcolemmal staining for MHC1 in the non-necrotic fibers as well, which is strongly positive for polymyositis. Plus she had features of myophagocytosis without any features of mitochondrial myopathy like ragged red fibers or rimmed vacuoles. So because she had a very specific finding, we put off the plan for a muscle imaging as well. And then we thought, okay, she is showing signs of muscle necrosis, severe necrotizing myositis. So we can put off the genetic sequencing. And the only antibody we had not tested so far was the HMG-CoA reductase antibodies. We did that and it was significantly positive. So this gave us the impetus to test for, because she was steroid refractory without any worsening. We diagnosed her as juvenile anti-HMG-CoA reductase necrotizing myopathy. Her disease phenotype was fitting with that and she was steroid refractory. So we gave her IVIG. In India, necessity is the mother of invention. So we could not give her the full dose. So we just gave her 1 gram per kg of IVIG per month because of financial reasons. And we could only give for 3 months. But after the second dose, when she came for the third visit, her muscle power was 150 on 150, improved from 90 to 150. And CPK levels improved to less than 1000. At 1 year follow-up, she is just on maintenance treatment with methotrexate, she has normal power. Even though her CPK is still between 1000 and 2000 on maintenance immunosuppression with methotrexate. So I just wanted to highlight some data on how rare this entity is, juvenile HMG-CoA reductase associated immune-mediated necrotizing myopathy. From the UK juvenile myositis cohort, so they have tested for 21 autoantibodies in around 100 patients. 0 patients had HMG-CoA reductase antibodies. And this is a cohort from the US. This had some 550 patients. And only 5 patients had this HMG-CoA reductase associated antibody. And only 3 among them had necrotizing myositis. 2 patients had a dermatomyositis-like phenotype. So this is extremely rare. And in another UK cohort, this was found to be a severe refractory disease in 4 patients. And they had treated with IVIG, Ritux, infliximab, and the disease course was refractory. But thankfully in our patients, the patient responded to treatment. So biopsy is necessary for diagnosis of immune-mediated necrotizing myopathy because the patient did not have any other findings to suggest an autoimmune diagnosis. And so in atypical groups, especially in juvenile idiopathic inflammatory myopathy and adult seronegative inflammatory myopathy, we need to do a muscle biopsy to document muscle fibrosis because we don't have antibiotic. And in juvenile, a lot of times muscle dystrophy can present like that. So if the biopsy was negative, we would have definitely gone for a genetic sequencing. So we need to test for inherited metabolic and mitochondrial myopathies. The HP was strongly suggestive of immune-mediated necrotizing myopathy. And so in seronegative cases, usually our panel, the 16 antibody panel does not have this. So we need to specifically test for this antibody. And if positive, the treatment is IVIG across cohorts. So most of the data is from adult
Dr. Sundaram, just
myopathy.
go to the last slide, please.
Yeah. So, and it's extremely rare, less than 1% of patients in the juvenile myositis cohorts. So, these are my questions.
Thank you, Dr. Sundaram. I think Dr. Fani will take up this case.
It was a nice case. I think, as you said, juvenile IMNM is only 1% of the whole IM with a lot of databases, because you have a UK database, European, and you have a US database also. But in adults, it is almost to 20%. So only one thing clinching in your presentation, when you have an URTA to start with, 3 days prior, and having 1 month history. So when you have a respiratory illness, IMNM is being known. So whenever it is a trigger, so I think infections as a trigger for IMNM is known. So that should be considered, because you consider a lot of dystrophies, mitochondrial myopathy. So those are all, but as you said, there is a lot of negative. So it doesn't look like. And acute presentation, when you have this high CP case, you should think of IMNM, the preceding viral infection. And juvenile IMNM, I think one thing, it is a very rare asset, it is only to 2%. So whenever you see this acute type of presentation, and you said we are doing 16 antigen, you will definitely miss HMG-CoA. HMG-CoA available by CLIA or ELISA now in the lab, and now we have a line blot, which has HMG-CoA, which is an 18 antigen test, which I think very easy to do, because you can replace your 16 antigen with 18 antigen. On a case-to-case basis, you can do HMG-CoA. And it's as it is rare. So I think SRPs and HMG-CoA, SRP comes under with this line blot. But HMG-CoA, as you said, it should be tested if the initial 16 antigen panel is negative. Then the next question is the lower.
I wanted to know the experience with low dose IVIG, because we always are faced with the question of money in our patients.
Yeah, in the adult IMNM, I think we have data, because it is 20% in different databases. IVIG is given as a full dose, I think 2 gram per kg, and it was given monthly. And that too with the HMG-CoA subtype of IMNM, they respond very well, giving IVIG for 3 to 6 months, and followed by any of your maintenance immunosuppression like methotrexate, or you can give rituximab at that time. We too have patients which we have done that. But low dose IVIG, it is definitely worked for your patient. Maybe as said with economics. So I think, I think the case is doing better at 1 year. After giving 3 dose of IVIG and on methotrexate, I think that is okay. I think we don't have any control data to say low dose IVIG definitely works. Then for preventing relapse, I think your third question, as said, how high you give, because the data, there is data from some Mexican group in adult.
Pulmonary function test did not reveal any significant abnormality. Urine examination showed proteinuria of 1.3 grams per day, but there were no ACT. So now with this symptom complex of myositis, nephritis, and cutaneous manifestations with constitutional symptoms, we went ahead with making differential diagnosis, and our first differentials were probably he had MCTD because he had Raynaud's, myositis, nephritis, and some vasculitic manifestations, or probably he had lupus. Otherwise, it was probably a case of overlap syndrome where myositis or systemic sclerosis was overlapping with lupus nephritis, or even rarely he could have myositis with amyloidosis or myositis with one type of glomerulonephritis. We sent antibody profile. His ANA was cytoplasmic positive, but ENA and dsDNA were negative and complements were normal. However, he was strong positive for anti-MDA5 antibodies, which fits the phenotype, clinical phenotype that he had. However, proteinuria was still not explained. So we went ahead with renal biopsy, which showed that there was no global glomerular sclerosis. It was a normal looking glomeruli. There was no significant inflammation, and IFTA was also very low. It was only 5%. And you can see the glomeruli, which looked almost normal. There is absolutely no inflammation. However, in some of the glomeruli, we could see an eosinophilic material within the vessel, which was suggestive of a thrombus. And if we see on silver stain, he had segmental reduplication, as you can see in this part, reduplication of the GBM. We did electron microscopy, which showed these subendothelial electron lucent material deposition or mesangial fibrillosis. In some of the areas, there were myelin figures. There was reduplication of GBM made out here, or there were tubuloreticular inclusions. All these electron microscopy features are suggestive of chronic endothelial damage. Now, with all this, we made a diagnosis of MDA5 myositis with thrombotic microangiopathy. Giving the background that he had, it was probably a secondary TMA of immune-mediated nature because he had autoantibodies which were positive. Anyway, to exclude non-immune-mediated TMA, we did APS profile which was negative and ADMTS 13 levels were normal. He was induced with steroids and mycophenolate with a suboptimal response at 3 months when proteinuria increased from 1.3 to 1.6. We added rituximab, and at 6 months of that is total at 9 months, his proteinuria decreased to 600 milligram per day. He was maintained on mycophenolate, low-dose steroids and ACE inhibitors. However, he required a repeat infusion of 9 months of rituximab. With that, his clinical symptoms, skin manifestations, and the renal, he is maintaining complete remission, renal remission. So you can see that his ulcers had healed, general well-being improved, hairs had regrown. So this was our case of myositis, nephritis, and ulcerated skin, and the answer was actually within. So what is the incidence of TMA in inflammatory myositis? So this series takes cases from 1991 to 2016. Of 159 cases at one center, they had only 3 cases with TMA. You can see here. However, they dug up the literature 60 years in past, took all the available literature from 1946 till 1991, and they could find 13 more cases reported elsewhere. And with all this, actually it made that incidence is only 1.9% of TMA in patients with IIM. With all these cases, what they had in common, you can see that hemolytic anemia was present in almost all of them. And TMA had exacerbation with the disease activity, which means that TMA in such cases is immune-mediated TMA. Treatment outcomes in these patients were poor because biologics were not available. You can see that only 3 patients survived after without that, and almost all of them had passed away. However, there is a single series available of TMA in myositis from University of Tokyo Hospital, where they have taken their all patients diagnosed within last 13 years. They had 26 cases of MDA myositis, and they had only 4 patients with TMA. All 4 of them had hemolytic anemia. All 4 of them had a high MDA antibody titer, and all 4 of them had high ferritin levels. These patients were initially treated with MMF. 2 patients also required rituximab, and all 4 of them survived as compared to the series that I just showed you, telling us that these patients with today's treatment, probably patients who have nephropathy and who do not have nephropathy, have almost similar treatment outcomes. And ferritin and DCT positivity is a marker of it. So learning points would be that MDA5 myositis with TMA is a rare phenomena. 4 cases have been reported by this series. There was another case report available in literature, and ours is probably only the 6th case reported till date. Since myositis and is an interferon alpha mediated disease, probably that also plays a part in developing nephropathy. And patients who have MDA5 nephritis with renal involvement have almost similar treatment outcomes. Thank you, and these are my questions to the panelists.
Thank you, Dr. Ranjan. I think Dr. Mithun will be taking this case.
Hi, Ranjan. A nice case. Although we have seen MDA5 cases, this is a unique case because of the presence of TMA.
Yeah.
Could this first question was whether it's a SLE? Because as after the investigations, as ANA was negative, only cytoplasmic fluorescence complements were negative. And biopsy was also not suggestive of lupus nephritis. Therefore, it's likely a MDA5 dermatomyositis with TMA. Unlikely to be SLE coexisting with it. Initially, we should suspect SLE because of the protein.
So DCT should be negative. But all the 4 cases that I showed, reported from Tokyo, all 4 of them had DCT. And what these authors conclude that DCT positivity and ferritin high, these 2 are the markers when you should actually look for development of TMA, renal and renal manifestation.
And surprisingly, your case doesn't have a lung involvement because whenever you say dermatomyositis, TMA, the disease will be too high disease activity. True. And this case doesn't have a lung involvement.
Yes, he does not have lung involvement. No, sir. Patient did not have calcinosis. So they were non-healing ulcers. He was not getting the right treatment. Nobody had prescribed continuous steroids. So once we started treatment with steroids and other drugs, so it healed. He did not have calcinosis. Sir, I have, what I am telling you is all clinically. I have not done X-rays for this. Yes. Yes, true. Absolutely true. True. Fine. I'll keep in mind. Yes, he has ulcers over the hands and knuckles. Yes, he has. Sure, sir.
Yeah. So, my question is having TMA a protective factor against rapidly progressive ILD? Like in your, you showed a cohort from Japan, and Japan has some of the worst MDFI ILD.
Yeah.
So, is the mortality in that cohort because of RP-ILD or because of TMA?
So their cases, all 4 of them survived.
Okay.
So saying that TMA could be a protective factor for ILD, I'm not sure. But then I personally, I have my experience that our patients who I have seen, at least I have 4 or 5 patients of MDFI, none of them have ILD. So I do not know how it goes, but then I don't think it can be called a protective factor.
Yeah, because I think the first 5 patients I saw, everybody died. So
yeah,
I
it
have
happens.
dismal,
MDFI, that's what we are worried about, but then it did not happen.
Yeah.
Very nice presentation, doctor. So in MDA5, we see kind of 3 phenotypes. One of them who are aggressive, present with rapidly, progressive ILD and have a very poor outcome. The second one is vasculopathy, which you have presented with ulcers, Raynaud's. And the third one is the arthritis and myositis predominant. So this patient, considering the age, hemolytic anemia, and young patient, I would probably use rituximab initially, so as to reduce the dosage of steroids long term. And also, as Dr. Mithun was pointing out, if the lesions of the skin don't improve, then consider TOFA. With my experience in MDA5, tofacitinib has been very good,
yes,
and especially with ILD, rituximab upfront, we've been able to salvage some patients.
But here actually the limiting factor was number 1, nephritis, for which tofacitinib is not good. So we needed to choose a medicine which can work on both.
Yeah.
The
So
muscles,
in this case,
skin,
maybe mycophenolate and rituximab
That's
would
right.
have been the ideal choice.
And the other problem was with finances. So later on he procured, but initially they were not ready for rituximab. So we had to treat with mycophenolate.
I mean, here combination immunosuppression was given or only mycophenolate was given?
Initially mycophenolate, he did not improve with that. Proteinuria increased at 3 months. Then we had to give a combination. We treated with rituximab.
So rituximab plus mycophenolate.
Yes, yes.
Doing quite.
Even now he is on rituximab plus mycophenolate.
And the review of literature that you showed,
Both.
all of them, they had
all
TMA?
So all 4 of them had TMA. All 4 of them received mycophenolate. Only 2 of them received rituximab. And all 4 of them improved.
I think there's one more question from the audience. So 2 more questions. Mike.
Yeah, but then complements are normal. We cannot call it atypical HUS. If you call it atypical HUS, complements have to be low, or there has to be complement deficiency, which was not there. Now talking about non-criteria antibody, you mean to say IgA subtypes?
Sir, any other anti-vimentin, other anti-phosphoryl?
So again, we did not look for it, and probably we can look for it. Yes, you are right, but then the problem will again come with finances. I have not discussed it also. Maybe they'll agree.
And the second question, sir, is when we were talking about tofacitinib, considering that the patient has a lot of gangrenous changes, is tofacitinib safer in that condition also, considering that it's vasculitis at the end of the day? But would it be safe in that situation as well, is my doubt.
So I would be reluctant to give. Yes, I would probably try with mycophenolate and rituximab initially. If required, maybe IVIG, but not tofacitinib as some point of time, at least as long as he doesn't develop ILD. Yeah. So cyclophosphamide was always on the cards, but the good thing was that he improved with mycophenolate and rituximab. If he had not improved on this, I would have probably gone ahead with the cyclophosphamide.
Sir, I have a similar case who had not responded to rituximab mycophenolate,
since he was a young boy, I was hesitating on using cyclophosphamide, but I gave 3 cycles of cyclophosphamide and he's now better.
Yeah, so it's always, I mean, it is one of the drugs that you can use.
Dr. Arun, last question.
Yeah, Ranjan, there was one Japanese paper I remember around a year back. They said that with baseline high ferritin with MDA5, you have to use either double or triple immunosuppression. Have you read that or any comment on that?
So
for ILD.
Yeah, so maybe for ILD. So I am not aware of it. Yes.
Thank you, Dr. Ranjan.
Thank you.
Next, we have Dr. Mahesh S. Kant, the great ocular masquerader, unraveling a decade of misleading uveitis. I think he's from Bangalore, Narayana, Bangalore. Over to you, Dr. Mani.
Good afternoon, everybody. Today I will be presenting the case, The Great Ocular Masquerader, Unraveling a Decade of Misleading Uveitis. The examination revealed chronic granulomatous inflammation with anterior segment showing iris granuloma and bilateral and the posterior segment showing bilateral heat choroiditis with choroidal neovascular membrane. Given the chronicity of the disease, he was referred to Rheumatology Department, Narayana Health City. A comprehensive autoimmune workup was done of ANA profile, ANCA profile, rheumatoid factor, angiotensin converting enzyme, and HLA-B27 were done, which are all negative. Given the recurrent panuveitis, serum immunoglobulins were done, which revealed low IgM levels with less than 0.25 gram per liter. And hence he was planned on a treatment of a combination of methotrexate with TNF inhibitor or methotrexate with mycophenolate. So we have a patient of bilateral recurrent refractory panuveitis who was not responding to the treatment properly. Hence, critical turning point arrived when we looked at his past history, which was not integrated with the ocular illness. 2 features withstood. So that was the childhood onset scrotal calcinosis and the year 2006, at the age of 32, erythematous skin lesions. So the game-changing indicators were the past history of long-standing scrotal calcinosis with normal serum calcium and serum phosphorus, and at the age of at the year 2006, steroid responsive erythematous skin lesions on the hands and face, and also a strong family history of musculoskeletal tuberculosis in his brother and renal tuberculosis in his mother. So, to summarize, here we have a patient of granulomatous panuveitis and an atypical family history of tuberculosis, and also steroid responsive skin lesions in the past. So, connecting all the dots, we arrived to consider the diagnosis of Bloss syndrome, and to confirm it, whole exome sequencing was sent, which revealed a pathogenic heterozygous variant in NOT2 gene. So, the unique features in this case were low immunoglobulin M and childhood onset scrotal carcinosis. Placing our case into the context, here the first case, the case 1, is the true adult onset Bloss syndrome, whose onset of disease started at the age of 22 years with maculopapular rashes, and there was no arthritis, and also bilateral anterior uveitis was present, which was consistent with our patient. So this makes our patient as the oldest age of onset of Bloss syndrome. And also the case 4 shows low IgM values, which is consistent with our patient. Key learning points are the granulomatous uveitis in block and mimic TB uveitis, especially in endemic region. Adult block can have incomplete presentation. So even in the absence of arthritis or rash, it does not exclude the diagnosis of Bloss syndrome. Failure to respond to multiple courses of antitubercular therapy in granulomatous disease, we should always consider a non-infectious etiology. And diagnosis relies on the pattern recognition, which includes granulomas, refractoriness to antitubercular therapy, and familiar TB like tuberculosis like clustering. Questions to the panelists?
Dr. Fani will be taking up this case.
Yeah, good case, Mahesh. I think the case also says uveitis, because when we see younger population, because blah, I think most of them present within less than 10 years. The skin rash is the first to come, then arthritis, then the uveitis. And you have seen an adult case with uveitis, and people has reported a lot of different mutations in NOT2. So the penetrance will be different, and they can present at later age. So that is the reason your case are later age. And coming to our first question of scrotal calcinosis, and you said since childhood, but I think it looks like a benign idiopathic scrotal calcium, nothing to do with your Blouse syndrome, and a lot of theories are there why they happen.
Yes,
and people require surgical excision. I don't think that is anything related with your blood. And second, low IgM. So I think not to is not only about inflammation, it is linked with allergy, it is linked with immunodeficiencies. So I think it can be part of it because there are syndromes like a CVID presentations with not to reported. So I think that can be part of your spectrum. So that is why you seen low IgM in your case. So that is an phenotypic extension. And one question to you, whether these cases are being looked for any IBD also?
He did not have any gastrointestinal
Any gastric complaint. Because subclinical colitis is also known in this case. And you said in your EBUS, you have seen some lymphocytic infiltrate. So lung involvement, renal, as you said, the family history. One having musculoskeletal TB, maybe I don't know whether it is a biopsy proven, they seen granuloma and they said musculoskeletal, I don't know. The renal TB, people have a TINU-like presentation, so they can have tubulointerstitial nephritis. So you said the other one in the family had a renal TB. So whether all can be, but the typical will be the rash, arthritis and uveitis. And most disturbing will be uveitis, which has a lot of morbidity over time with different complications. And coming to our second question, I think the treatment strategy, I think how you treat all the autoimmune uveitis is the same. So as you tried in your case, methotrexate, later now thinking of a combination.
He's currently on methotrexate and mycophenolate.
Yeah. So and TNF inhibitors are known, the third one.
Yes, sir.
The next of it, I think IL-17, JAK inhibitor, they're all being tried, but nothing data to say that they're being used in blood. Maybe into small case series being used.
Can the scrotal calcinosis due to calcified granulomas, which has happened before, long standing? I don't know, just ask.
Might be, we don't know whether it is associated or not associated.
Granulomas can calcify later.
Yes, sir. Chronic granulomatous inflammation.
So can I ask you, how sure are you of your diagnosis of Blau syndrome in this patient? The low IgM could be because of immunosuppression he's been taking for 10 years. Yeah. And how do you, was it persistent? Did you stop the drug and see it? Was it there? Did you look at the B cell subsets? And just finding a variant does not mean that the patient has Blau syndrome. All features are totally atypical. And did we do a family screening to say that this variant is only in him or it is also there in other members who are absolutely asymptomatic? So was any of these done?
Family members, his brother had musculoskeletal TB and mother had renal. But for them, the genetic evaluation must have been done.
Yeah, Dr. Vignesh.
Yeah, I also don't think this fits in with Blau syndrome. Just because you have a NOT2 variant doesn't make this case as a Blau syndrome. Though you have uveitis, you don't have the arthritis or the rash, which you commonly see in Blau syndrome. And low IgM, I don't think it is a feature of Blau syndrome that has been ever seen.
Association, I think it is being linked.
Yes, an association, but it is not
a typical
seen in Blau syndrome actually.
Usually we see hyperglobulinemia.
I think you said about a rash in the childhood. You said some erythematous rash responding to steroids.
Erythematous rash was there which responded to steroids.
That is since childhood?
Yes, sir. It was in childhood. No, sir. It was at the age of 32 years of age.
Okay. Was any biopsy was done? The skin biopsy?
Skin biopsy was not done, but it was responsive to steroids.
So how will you proceed in this patient? Immunosuppression and this thing, or?
Currently the patient is meeting, he hasn't had a relapse of uveitis with methotrexate and mycophenolate.
Well controlled.
Well controlled, sir.
No steroids.
No steroids.
Any other questions from the audience? No. No other questions. Thank you. Thank you, Dr. Mahesh. Next we have Dr. Vishnu K. Konneru from JIPMER. He's going to be presenting an orphan disease, pyoderma gangrenosum, acne and hidradenitis suppurativa, that is PASH syndrome. Over to you, Dr. Vishnu.
Good afternoon, everyone. I'm a recently graduated resident from JIPMER, and I'm going to discuss on seeking greener pastures and the challenges of navigating treatment in an autoinflammatory syndrome. So this is the story of an 18-year-old man who presented with a 2-year history of painful pus-filled blisters in the axilla, groin and limbs. He was born of a non-consanguineous marriage. There was unremarkable birth and family history. Developmental and vaccination history was normal, and there was no prior hospitalization history. In terms of his self-recalled history, 2 years before presenting, he had these blisters as I described. He also had papillonodular acneiform lesions on the face, upper arm and the trunk, which later formed large painful interconnected nodules which evolved into abscesses forming deep cysts. He also had axillary lesions in the form of inflammatory abscesses with sinus tracts. He also complained of right medial femoral condylar pain. At the superomedial margin of the patella, there was no joint line tenderness, and clinically as well as on ultrasound, it was seen to be enthesitis. There was left hypochondriac pain as well, with no physical examination findings indicative of anything, and he was planned for CT. So this is what we saw in examination, corroborating with the history in chronological order. The patient had a blistering lesion on the arm first, morphologically labeled as blistering pyoderma gangrenosum on the arm, followed by pustular pyoderma gangrenosum on the thigh, and eventually developing acneic conglobata lesions on the face. This is what we found on in investigating him with relevant labs. His complete blood count was normal. His renal function test was normal. There was no abnormalities on liver function test or urinary. There was no proteinuria or hypoalbuminemia. However, his lipid profile showed hypertriglyceridemia, and he had raised LDL levels. Infection workup was done both serologically with multiple blood cultures as well as exudate cultures which were negative, and also procalcitonin was normal multiple times. Immunological profile in the form of ANA was negative. However, he had increased HSCRP with a value of 29.2 at the maximum. RF and complements were negative. CT scan for the left hypochondriac pain revealed splenic abscess, and on fibroscan there was F0 F1 fibrosis as well. On histology, we saw of the ulcer, we saw neutrophilic infiltrate, and also there was some epidermal coagulative necrosis as well, which was compatible with diagnosis of pyoderma gangrenosum. There was no evidence of granuloma, dysplasia or malignancy noted. So on the basic clinical profile was that of an adolescent male with biopsy compatible pyoderma gangrenosum lesions which were categorically sterile, nodulocystic acne of severe quality, HS with sinus tracts, elevated inflammatory markers, and a visceral abscess in the background of a normal immunological workup, otherwise consistent with possible diagnosis of autoinflammatory syndrome involving follicular occlusion, possibly a primary immunodeficiency disorder, and IBD associated neutrophilic dermatosis. However, lymphocyte subset by flow cytometry, immunoglobulin profile as well as DHR assay were normal, and colonoscopy was normal as well, possibly ruling out the already less probable IBD associated neutrophilic dermatosis. So final diagnosis was the acronomic diagnosis as we guessed by that time, that was pyoderma gangrenosum, acne and HS, hidradenitis suppurativa, along with inflammatory markers and autoimmune workup being negative, that is PASH syndrome. So on the genetic clinic evaluation, mitochondrial genome sequencing was done, which did not show any pathogenic variant. However, clinical exome sequencing did show 2 heterozygous variants, with interestingly both were of cutaneous, possible cutaneous phenotypic abnormalities, that is neonatal inflammatory skin and boil disease with EGFR gene mutation and OSMR gene mutation as well, with possible association with a familial primary localized cutaneous amyloidosis, but in this particular case, they were of uncertain significance. So coming to the treatment course, the patient was initially treated with high-dose prednisolone and dapsone, but the response was suboptimal. He was then switched to subcutaneous adalimumab 40 mg subcutaneous. This was given for a few weeks, but the response was good retrospectively on history taking. But he was unaffordable, for which he had to be switched to cyclosporin. However, the dose of cyclosporin could not be optimized due to hypertension and elevated creatinine levels. Tofacitinib was also attempted, but there was no improvement. And eventually, when he presented to us on day 0, as we can see on the timeline. We started him on tapering 1 mg per kg prednisolone, along with initially a dose of 40 mg fortnightly adalimumab, but again there were few new lesions developing on 40 mg fortnightly adalimumab. Possibly it was just the course of illness and we could have waited a little bit more, but we increased the dose to 80 mg adalimumab fortnightly, and we also added cyclosporin, with which he had excellent response. So the treatment basis, the basis of our treatment decision was on the basis of these 2 phase 3 RCTs that were the Pioneer studies. Both are basically the same study in 2 different subsets, which were based on the staging of the severity. So Pioneer 1 with a little less severe disease and Pioneer 2 was more severe disease. Both have 2 periods. Period A, patients are randomized to either placebo or adalimumab at week 0, 160 mg, week 2, 80 mg, followed by 40 mg weekly dosing. And later re-randomization is done in the period B, where the adalimumab already taking patients are either given 40 mg weekly adalimumab or every other weekly 40 mg adalimumab or placebo, and those taking placebo are re-randomized to 40 mg adalimumab weekly versus placebo. And all of them essentially are given an option to opt for the open label extension study, where 40 mg weekly is given for at least 60 weeks. So the results were this, that weekly dosing provides superior and sustained outcomes compared to every other weekly dosing or even treatment interruption after a while. And that was seen across all primary endpoints, and clinical benefits were maintained throughout 36 weeks of continuous therapy, and interruption always gave a risk. So on examination, this was how the treatment which we gave showed effect. So the blistering pyoderma gangrenosum healed well, so did the pustular pyoderma gangrenosum, and even the acne conglobata lesions, as specifically seen on the forehead, decreased in size, although they led to some scarring, but there was significant improvement functionally as well. So PASH syndrome, that is pyoderma gangrenosum, acne and hidradenitis suppurativa, is most frequently associated with PSTPI, P1 mutations and NCST and gene mutations, also, although not as strongly as we see with PAPA syndrome. In this case, however, the mutation is in the EGFR gene, illustrating the very commonly described genetic heterogeneity of PASH syndrome. Mechanistically, these mutations increase IL-1 beta activity, with effective treatment being TNF-alpha inhibitors, anakinra, cyclosporin, and even IL-17 inhibitors have been documented to be given. This case underscores the importance of dose escalation in achieving effective resolution of symptoms in complex autoinflammatory syndromes like PASH syndrome. These are my points to ponder and the questions to.
Thank you, Dr. Vishnu. Just before we go to the points to ponder, did I hear enthesitis in your presentation? Because you said some knee pain, ultrasound was showing some enthesial picture.
Yes, sir. At the outset itself, he had right femoral condylar pain he had right superomedial pain, sir, and ultrasound findings as well as so he had this right medial femoral condylar pains.
And ultrasound was suggestive of
enthesitis.
Yeah, you can go to points to Dr. Mithun will be taking notes.
Vishnu, very nice case. And regarding the EGFR mutation instead of PSTP1, which is the classical one, basically you have made a clinical diagnosis. Here this is a clinical diagnosis. Even if the genetic study comes as negative, your diagnosis will remain the same. And it's, you already told it's a genetically heterogeneous disease. I think in studies show that only 50% of the PASH syndrome are PSTP P1 positive. Therefore, this fits in with your diagnosis. And also, as one of your questions says that, the last question, EGFR inhibitors, which are used in malignancy, it is one of the side effects is the pustulosis and acne, folliculitis. That means that the EGFR has a function to maintain the follicular skin barrier. Therefore, any mutation, loss of mutation in EGFR can cause pyoderma gangrenosum like neutrophilic dermatosis. And does an aseptic splenic abscess justify routine internal screening? It causes neutrophilic infiltration in the skin, as well as in severe case it can infiltrate the visceral organs also. If you have clinical symptoms to such like a fever, then you can screen for routine evaluation. Difficult to say. And escalating most of the skin disease like hidradenitis suppurativa, and even if you take even psoriasis also, most of skin disease usually need a higher dose of usual rheumatological dose, like as in this case 40 milligram weekly can be given. And de-escalation that you have to try and do. It's basically a try and error method.
Any comments from the audience?
In this case, it was a heterozygous mutation, ma'am. It was not a loss of function mutation.
Significant. It will become significant.
Nowadays, no, available to see what impact does this mutation have on the protein before you attribute, even if you've not done functional studies, but you can figure out something. Otherwise, every mutation will be saying that is a disease, while that is not the disease.
Any other questions from the audience? Dr. Vignesh.
This is not EGFR. EGFR, the clinical phenotype is completely different. You see ectodermal dysplasia, inflammatory bowel disease. So this is not the phenotype. Here what you have is a pyoderma gangrenosum. You have some acneiform lesion and you have some variants in some genes. So unrelated might be. You cannot make a association with the genetic defect which you have there.
Sure.
Anything else? If none, thank you, Dr. Vishnu, for your presentation. May I call up upon Sri Harsha to summarize the clinical cases.
Good afternoon. A quick review of all the 4 interesting cases that have been presented. The first case is a case of a 14-year-old patient who was diagnosed, who presented with pure motor syndrome in the form of proximal muscle weakness, which is symmetrical, very high CPKs, and myositis-specific antibodies and myositis-associated antibodies were negative. There was a doubt whether it is presenting like a muscular dystrophy or a myopathy or an inflammatory myopathy with severe involvement. Muscle biopsy has been done, which shows features of severe necrotizing myopathy, and which has been followed up with anti-HMJ-CoA reductase enzyme, which was found to be elevated. And then, because of the initial steroid refractory nature of the disease, periodic IVIG has been instituted as a treatment modality with which the patient improved significantly. So it is always important to have a suspicion of muscular dystrophy in a patient who is presenting in the pediatric or the adolescent age group, though we have features suggestive of severe inflammatory muscular disorder. So the next second case was a 17-year-old male patient who presented with features of myositis, nephritis, cutaneous vasculitis, and severe constitutional symptoms. Had serological abnormalities like DCT positivity and raised inflammatory markers in the form of ferritin. Complements were normal. Autoimmune workup in the form of ANA blood was negative, and the myositis profile showed strong MDA positivity. So we went ahead with a renal biopsy which showed insignificant inflammation, but the presence of thrombotic microangiopathy prompted consideration of a coexistential TMA type of disease in this kind of patient, and the TMA was suspected to be chronic nature because of the biopsy features and because it is thought to be immune-mediated endothelial damage, and as a consequence to the primary inflammatory disorder, it has been treated with immunosuppression, and the patient achieved a good outcome. So the third case was a middle-aged male who presented with bilateral recurrent uveitis with granulomatous inflammation of the choroidal tissue and the iris, both involving the both anterior and posterior segments of the eye, and then had prior history of treatment with anti-tubercular therapy, not responding, tried different immunomodulatory regimens, still the disease has been progressing. And then there was a family history taken which showed there was significant history of extrapulmonary tuberculosis. So that prompted, because of the additional history and clinical examination suggesting of scrotal lesions and steroid responsive erythematous skin lesions, diagnosis of Blau syndrome was considered. And we always have this kind of doubt whether it is an intrafamilial spread of tuberculosis infection or it is an autosomal dominant transmitted genetic disease like a Blau syndrome. So the whole exome sequencing was showed heterozygous mutation of the NOT2 gene. And the fourth case was an autoinflammatory syndrome presenting in an adolescent male who had flexural severe cutaneous involvement with predilection of flexural areas in the form of pyoderma gangrenosum, acne conglomata, and visceral abscesses, and the infective workup was negative and the cultures were sterile in all the areas. It prompted the diagnosis of IBD related granulomatous disease, but the colonoscopy was normal, and which is why because of severe cutaneous features and mild extracutaneous features, autoinflammatory syndrome like PASH syndrome was considered, and it was tried with different immunomodulatory agents, and finally the patient responded to a combination of adalimumab and cyclosporin and steroids. Usually we expect PST, PIP1 mutations in PASH syndrome, but this patient turned out to be positive for a different gene mutation altogether, which was of uncertain significance. Thank you.
Thank you, Dr. Sri Harsha. We come to the end of this particular session. I would like to hand over to the organizers to take over. Thank you.
Everyone, please head to the tea break. In the next 15 minutes, the next session will start.
Yeah, sir, for the faculty on your right side, for the delegates on the left side, faculty and all the senior IRM members go towards your right side. We'll be back in 15 minutes, so maybe 3:35. But I don't much better. So much better.
23, 43, 43 plus 4.5. Next. 5, 4, 9, 13, 19, 57, 93 to 57.
Sure.
Please just arrive that side. And here is a mission now.
Ask more questions, we will not have those questions at all. So we have the first person, Abhishek. From, okay.
Please introduce, no, just your contribution. Sure. The abstract reviews.
These are the abstract reviewers who have selected the cases.
Okay. So we have a team of 10 eminent people who have selected these 4 abstracts out of the abstracts which were submitted in the section for lupus. And I think their choice is excellent. All the 4 cases have different facets of lupus. And we have Abhishek from SGPGI who will be presenting the first case.
So good afternoon to everyone. My case is titled A Gut Feeling, and you'll get to know why in a matter of a few minutes. So this 31-year-old gentleman presented with a 5-month history of dyspnea on exertion, pericardial type chest pain for the last 3 months, low-grade intermittent fever and inflammatory polyarthralgia. He was initially worked up outside, elsewhere, incidentally detected to have pericardial effusion and bilateral pleural effusion. And he visited a cardiologist who prescribed him methylpred 4 mg per day and aspirin for 3 months, to which he had a partial response. He was never investigated for a CTD prior to referral. Further down the line, he accrued a few clinical features in the form of polymorphic skin rash for 1.5 months, painless palatal ulcers, and diffuse non-scarring alopecia. When he presented to us, he had an evolution in his symptoms. The initial low-grade intermittent fever had evolved into a high-grade continued type of fever. He had worsening polyarthritis and was ACR functional class 4 when he had presented. He had worsening dyspnea and pleuritic chest pain. So we started him on prednisolone 0.5 mg per kg per day, and we started IV antibiotics considering a recent change in the pattern of the fever. He was conscious oriented, slightly on the obese side. His BP was 92/70. Saturation was borderline, 94% on room air. He was tachypneic, he had tachycardia, he had edema. He had a polymorphic rash, some of the lesions resembling tinea corporis, while some resembling a psoriasiform SCLE. He had multiple painless, multiple shallow ulcers over the buccal mucosa and hard palate. He had diffuse non-scarring alopecia, multiple tender and solar joints, reduced air entry in bilateral basis. He had ascites. He was conscious-oriented and had no focal neurological deficits. So his serology was consistent with SLE. ANA was 4 plus homogeneous 1:200. ENA was 3 plus GSDNA, nucleosome and histone. APL antibodies and LAC were negative. Anti-DSDNA titers were elevated, although he did not have any hypocomplementemia. Urinalysis showed a proteinuria of 1.68 gram per day without any active sediments. And what I've tried to show here is a table showing his lab over the course of the first week of admission. So on day 1, his peripheral, his hemogram was more or less normal. ESR and CRP both were elevated. Procalcitonin was 0.5, which was borderline. Ferritin was done on day 1 considering a recent change in the pattern of the fever, suspecting mass, which was normal. Neutrophil CD64 assay, we had the privilege of doing that, so it was elevated, indicating an activated state of the neutrophils. And since he was having persistent tachypnea and tachycardia, we thought of myocarditis, but his NT-proBNP and TROP-I remained normal over the course of the first week. 2D echo also ruled out any myocarditis, and CT chest ruled out DAH. So as you can see, on day 5, there was a slight dip in his platelets and a slight drop in his ESR. Procalcitonin remained 0.1, which was normal. There was a slight increase in his ferritin, and the neutrophil CD64 remained elevated. On day 7, we observed frank pancytopenia, a drastic fall in the ESR, and rise in his ferritin levels, which is when we thought of mass. So the persistent issue was fever. High spiking fever, 103 degree Fahrenheit with new onset cytopenias. And the possibilities considered at this point were sepsis and mass, as we would normally suspect. So the points favoring infection was a rising procalcitonin and a persistently high neutrophil CD64. And the points favoring mass were negative cultures till now. The first set of cultures was negative. And rising ferritin with a plummeting fibrinogen and ESR, and a very high H score indicating a more than 99% probability of the patient having HLH. But still, there were a few cultures which are pending, and there is, as in clinical practice, there is always a lingering suspicion of infection. So since sepsis could not definitively be ruled out at this point, we decided to go with the safer route with IVIG 2 gram per kg along with dexamethasone. equivalent to prednisolone 1 mg per kg per day. And he received IVIG over the next 5 days, but had no improvement, continued to spike fever. Tacrolimus was added, but then he developed a new complication, which was new onset diarrhea, not responding to antibiotics, antihelminthics, and antisecretory agents. And followed by that, he developed obstipation and progressive abdominal distension. So when we got a CT done, it showed a massively dilated colon with no features to suggest obstruction. Naturally, a surgical gastroenterology consultation was taken, and they opined conservative management with nasogastric decompression, flatus tube insertion, pro-motility agents. Electrolytes and all were normal. Proctosigmoidoscopy was done, which was normal, no ulcers. Rectal biopsy showed no evidence of viral proctitis, and tissue CMV PCR was also negative. And stool cultures, parasitology, Clostridium difficile, the usual suspects for toxic megacolon, all were negative. So we were in a fix at that point of time. So we decided to send a peripheral blood multiplex viral panel, which was awaited. This poor fellow then developed further complications in the form of myocarditis. Now, the NT-proBNP after 10 days of admission was more than 30,000 and drop I was elevated. Procalcitonin was 0.1. ESR was still low, ferritin was rising, fibrinogen was dropping, cytopenias were worsening, and no positive culture still now. So all of this favored macrophage activation syndrome over sepsis due to disease activity rather than sepsis. So we decided to give methylprednisolone pulse 1 gram per day for 3 days. Despite that, he continued to spike fever, and on one day after the pulse is when his multiplex PCR returned positive for EBV. His fever continued, myocarditis continued to worsen. He was requiring BiPAP at that time. So, like the title of my case, we had a gut feeling that this is all disease activity, so let's treat the disease activity. So we gave him NIH cyclophosphamide first dose, 1.2 grams. And he was immediately, after cyclophosphamide, shifted to the ICU because we were fearing that he would require mechanical ventilation. Let me tell you that this patient was an ICU candidate from day one itself. Since I have managed this patient, I know. And he was afebrile within 3 days of ICU transfer with no change in antibiotic regimen, no change in immunosuppression. And the cardiopulmonary failure also settled gradually over the next 7 days. After 10 days of ICU stay, we received him back. His ferritin was declining, cytopenias were resolving, and he was afebrile by that point. His megacolon or bowel dilation also resolved only with conservative measures. No surgical management was required. And this poor chap again developed another complication, which was proximal muscle weakness. Could be steroid related, but his muscle enzymes and inflammatory markers were normal, more likely to be critical illness myopathy. So follow-up at 1 year, he completed 7 doses of cyclophosphamide and is currently on MMF 1.5 gram per day with only one minor flare in the interim. So the challenges we faced in this case was a difficult to treat macrophage activation syndrome, not responding to multiple lines of therapy, glucocorticoids, IVIG, tacrolimus being tried, and the rarity of non-infective toxic megacolon as a manifestation of MAS. Why cyclophosphamide? Because EBV MAS carries a particularly poor prognosis, and B-cell depleting agents like rituximab have improved survival significantly up to 43% in a recent case series. And the decision to give cyclophosphamide in our case was based on the presence of a rapidly progressive myocarditis. Rituximab might not have acted in the time frame that we wanted it to. And learning points are gastrointestinal involvement, albeit uncommon, may occur in MAS with GI sepsis and lupus enteritis being the closest differentials. And viruses as a trigger for MAS must be particularly looked for in refractory cases.
You can leave it here.
Before the questions to the panelists, if anyone wants to ask.
Questions from audience first. Any suggestions anybody would have done differently?
Yes, sir.
Yes. 1 second. Sandeep first.
Which one? It was PCR, sir. PCR.
That was a PCR.
Yes, sir.
So why wasn't he treated with an antiviral alongside the
What antiviral would?
cyclophosphamide?
What antiviral
The
would?
EBV.
No virus.
No
There's
antiviral for EBV.
Won't you do something?
B cells are the natural reservoirs for EBV infection, so it makes sense to treat with rituximab. And in pre-rituximab era, actually the 5-year survival of EBV-related HLH was close to 5%, which has now increased to 43% in a recent series where rituximab was used in around 43 patients with EBV-related HLH.
Suma? Short
I
question.
just have a comment. I mean, I completely agree with everything you've done. When you have very high procalcitonin, to tell you the truth, most of the very high procalcitonin I've seen are in mass. The levels, it's sometimes maybe fungal sepsis or severe invasive sepsis can produce, but over 7500, those kind of levels of procalcitonin invariably is mass before sepsis.
Completely agree, ma'am. But the
Dr.
procalcitonin was not actually very high. It was the max which we had seen was 2. So, and in the initial stages, there is always a doubt prior to cultures returning positive that it could be infection.
See, but when
Yes,
Just one
ESR
second,
was
one
2,
second. Dr.
ESR
Chaturvedi, next.
Sorry.
You've done. Okay, Yojana.
So if ESR was 2, sepsis would have been much less below in the differential diagnosis, and mass would be very high on the consideration.
You're exactly right, ma'am.
So
Sepsis is also a trigger for mass, so we cannot definitely rule out sepsis in a case of macrophage activation syndrome with a low ESR. We have
cover of highest antibiotic possible.
Yeah.
Give treatment for mass,
Which we
steroids
did.
and cyclosporin.
First IVIG, because that was the considered the safer choice initially, but that can be.
Yes, let's go to the questions for panelists now. Quickly, just put the question.
Okay, so tacrolimus was added, ma'am, to answer your question.
Okay.
So were the gastrointestinal complications secondary to lupus enteritis, mass, EBV, or something else? And should routine screening for viral etiologies be considered in all cases of mass? Yeah.
So in mass, the common gastrointestinal complications are usually enteritis, loose motions. It's less than 20% actually.
Yes.
Toxic megacolon is not usually seen in mass. It's usually seen with underlying IBD. Second thing, it's seen with CMV, which was negative. So overall, it's really rare. I mean, I haven't seen. And this biofire that we do in peripheral blood is like very sensitive. Sometimes you don't know what to do with the reports, Even a small, this could lead to a positive report. You don't have resistance, you don't have sensitivity. So I wouldn't be too sure whether we should give so much importance to EBV.
Yes.
You are right in treating as with IVIG, steroids and cyclophosphamide later. And so the patient is doing well, I think it's fine. The second question, yes, ideally we should be screening for viruses, but sometimes it's not cost effective. Institutional policies do matter. But the trigger would be if you're not done it in the beginning and in 48 hours of steroids, there is no improvement, and definitely you should order a viral panel. Now the third
And do you
one
favor any other?
Yeah, so rituximab you've already described. You can use that. Other drugs are etoposide. I think the hematologists use it, though. So you can discuss with them and use. And there's a new drug, I think, emapalumab. That I don't know if it's available. Is it available?
The only approved indication is SGIE-MS.
Yeah,
for that.
so that's another new drug which can be used because the IL-18
Yes.
new cytokine.
Interferon gamma.
Yeah.
I think we can explain with almost all of these the gastrointestinal complications. Mass with a lot of huge cytokine load, they can have toxic megacolon. But I think the scene would be completely different treating the patient at that particular point of time. Lupus patient with high procal and mass-like symptoms, we also think of other differentials like other infections like CMV. A lot of these things will move in our mind because now once we have done with the case, we are discussing, it's a different thing. I think at that scenario, we'll get a lot of other differentials to look for infections. But I think mass also can have, like if you can explain pathogenetically, it can have all these things. And routine screening, because most of the mass in lupus are because of stopping drugs or simple infections. So if you restart the medications or treat the infections and increase the dose of steroids, add cyclosporin, they should get settled. And if they are not improving, yes, I think EBV we need to look for, because the therapy changes. Because if the patient, if the EBV triggers the mass, and if you don't, we can think of rituximab as another choice. I think the last one anyway you have said about the rituximab.
I mean, the only thing I want to add is that you don't take EBV here at all. People have shown that almost 30 to 40% of patients with active lupus can have EBV DNA positivity. So that, don't put too emphasis on it. Yes.
It would have helped if we had a quantitative PCR.
We don't have time. So we want to stick to time, absolutely. So more questions at tea time. Thank you, Abhishek, for a wonderful case. You want us to be on time, no?
Good afternoon, everyone. I am Dr. Tejashwi, DRNB resident at Max Super Speciality Hospital. Today I am going to present a very unique case and difficult to manage, which was titled as refractory lupus nephritis in a young girl, and who had achieved a therapeutic success with some unconventional therapy. So let's see what is this unconventional therapy. So coming to the case summary, this is a 20-year-old girl with 10-year-old long follow-up. So initially she is presented in 2015 with PUO, oral ulcers, malar rash, alopecia, arthralgias for 2 months. There was no renal symptoms historically. On workup, she is lupus like ANS positive with 4+ homogeneous, multiple autoantibodies was positive, complements were low, and dsDNA titer was high. However, the APLA workup was negative. Further workup showed active urinary sediments at the proteinuria of about 2.3 gram per day. With this, we underwent a first renal biopsy, which suggested of class 4 lupus nephritis with a high activity index of 10 and a full house IF pattern. After discussion with the patient, the treatment was initiated with IV steroids, followed by MMF plus hydroxychloroquine and AC inhibitors. With this, she had a very good improvement with decrease in the proteinuria to less than 500 mg in 6 months, and this was maintained till 2018. Only in 2018, although she is clinically stable, her proteinuria further increased to 2 grams with active urinary sediments, raising dsDNA titer and low complements. So again, for this, she underwent a second renal biopsy, which was suggestive class 2 mesangial proliferative type of lupus nephritis. Here, for this, the tacrolimus was added along with pulse steroids and MMF. With this, she also responded with decrease in the proteinuria, and this remission was maintained till 2021. Only to have a major relapse in 2021 with the proteinuria about 5.1 grams with active urinary sediments and a low C3-C4. And with this, a third renal biopsy was underwent, which was suggestive class 4 lupus nephritis with a very high activity index of 16, full house IF pattern, and focal foot braces effacement of 60%. With this, after discussion, we underwent with the we move forward with the B cell depletion with rituximab, which was given at induction, and 3 maintenance doses along with MMF. With this, she only had a fluctuating level of proteinuria, only partial reduction in the proteinuria. The protein remained around 2.5 gram per day. So along with this, adjuvantive methods such as SGLT2 inhibitors in the form of dapagliflozin was also added for renal protection. Despite this, proteinuria persists. In 2023, she had a major relapse with persistent nephritic proteinuria, and the proteinuria increased to 6.7 grams with normal complements and creatinine. Here, she underwent a final biopsy, which was suggestive of class 5 plus class 3 lupus nephritis, with an activity index of 2 and a chronicity of 4 and a full house IF pattern. So here for the further B cell depletion, deeper B cell depletion, we consider for the obinutuzumab, which is given at induction and maintenance, along with MMF and tacrolimus. With this, she doesn't had any response, and the proteinuria remained around about 3 grams. So we came to a therapeutic dead end. So this is the biopsy summary in the 2015 showing class 4, 2018 class 2, 2021 class 4, and finally 2023 class 5 plus class 3 lupus nephritis. So this is the treatment summary. Initially she received MMF plus HCQS, for which she had remission followed by relapse. Then in 2018 she was added with tacrolimus, for which she also had a remission followed by relapse. In 2021 she was depleted with B cells with rituximab, which showed only partial remission. And 2023, obinutuzumab was a clear failure. So we came to therapeutic dead end with adequate immunosuppression, deeper B cell depletion, and renoprotective measures. She remained in partial response and refractory lupus nephritis. Here, the plasma cell-driven disease was suspected with ongoing autoantibody production despite the B cell depletion. So turning point was in November 2024, where eniguratimod was added on an add-on therapy for the existing MMF plus tacrolimus plus low-dose steroids. To our surprise, her proteinuria had a drastic decline in the proteinuria from 3.2 grams to 185 milligram per day within 1 month, and this was maintained in complete remission till 1 year now, with normal complements and normal creatinine. So this is a complete proteinuria timeline offered with initially added with MMF, next tacrolimus, rituximab, obinutuzumab, which is a clear failure, and with egrotimab, there is a drastic decrease in the proteinuria to 185 milligram within 1 month, and she was in complete remission till 1 year now. So why do we think the egrotimab worked? So rituximab and obinutuzumab might have failed because the disease might be a plasma cell driven predominantly, and because of ongoing immune complex production despite the B cell depletion. And the inflammation might be maintained through other other non-B cell mechanisms such as interleukin-17 mediated and NF-kappa mediated mechanisms. So why would our egoratimod succeed? So to know that, we have to know the actions of the egoratimod. So egoratimod has a broader level of immunosuppression. It has a plasma cell suppression mechanism, broader immunomodulation beyond B cells. It also depletes the interleukin-17 and NF-kappa beta pathway. It inhibits a macrophage inhibitory pathway, thereby reducing the inflammation. Also, the animal studies have shown it has an anti-fibrotic renal protection and a regulation of innate immune response and cytokine pathways. So this is summarizing this. So first one, it shows it has anti-inflammatory mechanism by inhibiting MIF. It blocks the Th17 pathways and it's down-regulating cytokines, thereby decreasing the pro-inflammatory cytokines. Also, by binding to TNF, it blocks the cytoplasmic to intranuclear translocation of NF-kappa beta, thereby decreasing the pro-inflammatory cytokines. It also had immunomodulatory mechanisms by decreasing the conversion of B cells to plasma cell by blocking at the ERG pathway. Also inhibits the Th17 and activates the Treg pathway. Also, it has osteoprotective mechanisms. By binding to NF-kappa beta, decreases the osteoclast activation, and by acting the SMAD signaling, it increases the osteogenesis. So this might have led to a dramatic and sustained response in our patient. So the learning points from this patient is refractory lupus nephritis is challenging even this biological era. Pathology might not always be a B cell driven, consider a plasma cell predominant disease. Serial renal biopsies revealing the dynamic class changes are essential whenever the phenotype changes. So egoratimod, based on the studies, it might be a promising add-on therapy in refractory lupus nephritis, especially of the biological failure. And it was also shown to be, in the studies, it was also an alternative induction therapy was also. The dramatic proteinuria reduction suggested new mechanistic pathways for treatment-resistant lupus nephritis. But although the more high-quality RCTs are needed, but this may show the early evidence that supports its role in difficult-to-treat lupus nephritis. Thank you.
Thank you, Tejasvi, for a wonderful case. So we are just going to put some questions to the house. How many would have used, in this case, at biopsy number 4, IV cyclophosphamide? So you can see Tejasvi.
Yes,
the
ma'am.
second,
We have
being
discussed
other
this.
drugs which people use is leflunomide. How many of you would have used leflunomide? Maybe 10.
So basically,
Would anybody would have used bortezomib for plasma cell removal? 1, 2, 3, 4. Any other drug anybody would advocate? Daratumab. Okay, we are not talking, we are talking. So would anybody would have used egrotimab? None. So Tejasvi, you were really brilliant, I must say. So just for, yeah, so she showed us the mechanisms. Okay, Tejasvi, why were you so different?
So, basically, sir, at the 4th renal biopsy, so we were also planning what further treatment has to be added and all. So to take out the time, just we have added her with egoratimod. And to our response, like she had a decrease in the proteinuria, then we went back and find out the literature.
So it is serendipity. Absolutely. Yes, Sapan. This time you have a chance. Dr. Chaturvedi, you want to speak up?
Yeah, I think serial biopsies we do. We often do, even both KDIGO and ULAR ACR recommends to do serial biopsies if the patient is not responding. So even ULAR ACR we observe we have a time frame of 6 months. So give adequate therapy and watch for 6 months, and if it's not responding, then I think renal biopsies needs to be done. And the most important thing is renal biopsy, as you all know, it's to understand the acute and chronicity. That's one thing. And the other thing is, I think in your case, what I feel is, I think there is a whole change in the endotype. So initially the pattern would be more of an immune complex mediated diseases. Subsequently at the late stage of lupus nephritis, it might be skewed towards Th17 driven pathways. Probably that is the only way which we can explain your egrotimod philosophy. And regarding third, should iguratimod given its immunomodulatory antifibrotic mechanism? Yes. So it's most promising on paper. Iguratimod is most promising on paper. It has activity on the blimp, and it has an antifibrotic properties, anti-TGF properties, and it acts on IKK pathways by inhibiting NF-kappa beta. So like it has some TLR9 inhibition properties. So it's wonderful on paper. Iguratimod works in most of the areas in plasma cells. So, but realistically, as we have not found that wow effect in treating other diseases. In lupus, it's really a surprise for us. Within 1 month, you have seen that. In RA, a lot of other cases we have been treating, but we could not find it. That's what actually makes us surprised.
So lupus nephritis likely. So patients, I think, who have very heavy proteinuria from the beginning, 6.5 grams or so. So they could be early CD20 non-responders. You feel that they're responding, but the anti-dsDNA levels are very high. I don't know whether we do BAF receptor levels, any BAF levels anywhere if they are high. So these are the, in this patient, there was a class switch. Like she responded, then she had nephritis, then she went to a nephrotic proteinuria picture. So maybe she was into a podocytopathy there. Yes, and that is why your both the B-cell depletion drugs did not work. So and that is why the alternative mechanisms of plasma cell, etc., maybe there iguratimod may have a role. Because podocytopathy, you give ARBs, you give SGLT2. After that, you don't have anything. So it's worth a try. Regarding the trials, so they're just East Asian trials. You have refractory lupus nephritis add-on trial. You have some salvage therapy, and you have an ongoing IGILU trial. Yeah. So these three, they are some of the current one is head-to-head trial. The others, they have shown response as much as 70%. Complete remission is 35%. All small numbers, 24, 14 patients. The current one is an ongoing trial. So definitely we need more Indian data and collaborate and discover.
Okay, thank you everyone. So now, you have more questions? Okay.
Do you have any experience of iguratimod in regular lupus nephritis patients? This is a refractory. Anybody has experience?
As I showed you, nobody had used it. Okay, so thank you, Tejasvi.
Ma'am,
okay,
ma'am. So one final point. Like I think, like most of the youngsters should know that this both rituximab and obinutuzumab, they are not going to act on long-lived plasma cells, which are the major producers of these antibodies in the late stages. So most of these long-lived plasma cells, they live in niches, so where they don't express CD20. So like these drugs, rituximab and obinutuzumab may not work, and obinutuzumab may not work if rituximab fails. There are some cases it might work, but usually the mechanism of action is slightly different. It works on a different epitope, but still the chances of failure are quite high.
There is a single study from UK, sir, where they used obinutuzumab and non-rituximab, like who had not responded to that, and in that they had a good response.
Sir, one more doubt.
Yeah, my question is to all the panelists and the speaker. See, because you have said that iguratimod works in so many different ways, I'm not really sure whether the plasma blast or plasma cell directed action has worked here. Is there any way to figure out whether this patient has a plasma blast signature, or like doing a peripheral blood mononuclear cells, looking at a plasma blast signature? Or I heard in some talk previously that in UK they did bone marrow biopsy to figure out that this patient has a more long-lived plasma cell-driven disease. Is there something like that? Is there
So there are studies where people are looking at renal biopsies. The infiltrate in the renal biopsy, can that tell you what the patient is likely to respond? So most of the information which has so far come is for interferon signature. There is some data to suggest that if you have a lot of B cell infiltration, those patients are more likely to respond to B cells. If you don't have the B cell signature and you don't have the type 1 interferon signature, those are the patients where you should use calcineurin inhibitors. So that is what is based on the renal biopsy. But I am not aware of a bone marrow based plasma cell analysis to advocate therapy. Anyway, we can read it up. There are lots
this is the
of
same
which are
follow-up
coming.
question, ma'am.
Okay.
Ma'am, here.
Yes.
Same follow-up question of Rajkaran sir and Sundaram sir. I am really surprised to know that whether this iguratimod really works in plasma cells. If it is, then the CAR-T, which we are using for the long-lived plasma cells, I mean, we need to actually suppress long-lived plasma cells by using CAR-T. So do we really...
No, this could be just serendipity. You do not know, did this drug work or it was a spontaneous remission? So one flow doesn't make the truth.
That's
So
exactly I need to know, sir. See, because we are actually saying this patient is clearly plasma cell-driven refractory disease.
No.
And we are actually saying that egrotimod
No,
works.
we are not saying...
Arthritis and grandson suffering with ankylosing spondylitis. All this story was started in July 2024, at the end of the July 2024. So she got evaluated elsewhere, where her routine CBP has shown WBC of 37,800 with neutrophilic predominance and mild transaminitis, but not going more than 300. And total bilirubin is 3.68. Mild bilirubinemia is there with mild ALP elevations also. And there was a hypoalbuminemia. Along with that, routine fever workup has been done, which was negative, and the ultrasound revealed a hepatosplenomegaly, and 2D echo was absolutely normal at the time, and serum amylase and lipase were normal. But she still had a persistent fever spikes in spite of giving an empirical antibiotic for more than a week. So she got referred to our center. So initial examination done by the gastro team, because since patient had a fever with diffuse abdominal pain, so she got referred to the gastroenterologist, and her vitals, she had a tachycardia and tachypnea in the emergency, and she had a mild icterus and generalized edema and diffuse abdominal tenderness, and there was no active synovitis at that time. And she got admitted under gastro, and her repeat CBP has shown still persistent leukocytosis with neutrophilic predominance. And ESR CRP were astonishingly normal, and SGOT, SGPT were still showing a mild transaminitis. And they have repeated the CUE for 3 times, and all the 3 times there was a 1+ proteinuria. And so 24 hours urine protein has been done, which showed there was a mild proteinuria, that is 795 milligrams per deciliter. Her, with this much of fever and WBC also, her procal was normal, and blood culture and urine culture of 2 sets which were showed no growth, and viral markers are also non-reactive. So our gastroenterology colleagues have gone one step higher because of the PUO, and they did the rheumatological workup by themselves. That is ANIF, that is 1+ positive. Obviously, when they see ANIF, whatever might be the pattern, they will do the rest of the test. That is C3, C4, which came low, and anti-DHDNA, anti-Smith-Eliza, anti-LKM, and anti-mitochondrial antibodies were also done, which were negative. So this DHDNA positivity and SM-ELISA positivity, they kept it aside for some time. So, and they did the imaging. So CECT done showed a hepatosplenomegaly with mild ascites and with bilateral minimal pleural effusion. So what they were expecting, some could be a TB here, but it didn't reveal anything. So then they went to the cardiac, and they did the 2D echo again, suspecting infective endocarditis because of the persistent fever spikes, and to their surprise, they found a vegetation on the mitral valve leaflets and the chordae tendineae with mild mitral regurgitation. So at this point, they suspected IE could be a strong possibility, but 3 sets of blood culture showed no growth, and rheumatoid factor was done negative, and no other peripheral signs of IE, and ocular examination also didn't reveal anything. So at this point, still the fever spikes are persistent with the antibiotic, and they did the bone marrow biopsy, and the initial bone marrow biopsy shown only hypercellular marrow with mild marrow fibrosis changes, and there was a prominence of immature cell clusters in the interstitium. Lot of debate has been done with the pathologist, and the pathologist scored more towards the sepsis because of the high WBC and persistent fever spikes with acute episodes. So ascitic fluid analysis was done, which showed a transidative, but WBC is 576. So they sent it for the culture, which grew Acinetobacter baumannii, but it is a pan-sensitive, and ADA was negative, to their surprise again. So at this point, she still had a persistent fever spikes with leukocytosis, and transaminitis persisted, and ALP has jumped to 824. So ideally, they should have gone here for a liver biopsy, but because of the long-standing stay, and with the Acinetobacter baumannii in the blood culture, they have gone to treat with the antibiotic meropenem 1 gram IV thrice daily for at least more than 7 days. That was the plan at that time. And surprisingly, on the day 10 of antibiotics, everything has become normal. Total bilirubin has reduced to 1.68 and the transaminases has improved and albumin is 2.7 and hemoglobin is 10.1 and WBC has become to normal and platelets are also absolutely normal. So by this time we have reached August 2024, that is in the first 2 weeks of August. So patient clinically improved, no further fever spikes and got about to discharge. Before discharge, they remember that patient was dsDNA positive. So what to do further? So they have even given a rheumatology referral at this point. So when we went and saw, so we took the whole history and we found that patient had a systemic features with fever with chills lasting for more than 4 weeks, and she had a possible vegetation on the mitral valve, and there was a definite hepatosplenomegaly, which is again it is massive splenomegaly. I cannot neglect or leave it. And there was a definite transaminitis with mild hyperbilinemia and cholestatic type of jaundice pattern. And there was a hypoalbuminemia and musculoskeletal features lasting only for a week. So we didn't give much importance to that. And renal, there was a mild proteinuria, again cannot be neglected with low complements. So then hematological leukocytosis with 37,800 and positive antibodies like ANA, anti-dsDNA and anti-Smith and low complements. So at this point, since the patient has become normal, so everyone thought it is sepsis predominantly from the gastro team, but we had banging our heads what it could be. Is it lupus because of the antibodies, or is it sepsis since the patient has improved with the antibiotics, or could it be an autoimmune hepatitis where serology can be negative but still a possibility, or is it a malignancy, or have we missed anything? So at this point, patient got discharged, and after a week we did the routine CBC and we did the routine ultrasound abdomen and 2D echo also. 2D echo, surprisingly the vegetation is not there now, and ultrasound abdomen also there was a mild decrease in the size of the spleen and the liver, and CBC was absolutely normal at that point and patient was also asymptomatic. So we didn't had any chance, so we told her to observe. So 3 days later, she presented to the emergency with complaints of fever lasting since 2 days and loose stools, watery, associated with abdominal pain. Family also had a similar history of loose stools, and she this time because of the antibodies positivity, she got directly admitted under rheumatology. So CBP, again the same story with WBC of 27,000, but this time there was a mild thrombocytopenia and high ESR this time and high CRP and mild transaminitis with very high LDH and lactates were very high. Again the blood cultures and urine culture were no growth. So in view of persistent fever spikes and the leukocytosis, PET-CT and repeat bone marrow has been planned. So PET-CT, this was the CECT done in the July 2024 and this was the PET done in the August 2024. Yes. So there was a one lesion which has not been picked up in the CECT prior, and it has a very good SUV with a good uptake also, and new focal liver lesions has been identified in the PET-CT. So the repeat bone marrow showed CD20 positivity with cyclin D1 diffusely positive, suggesting a B lymphocytic proliferative disorder, and the same lesions has been noticed in the liver biopsy also with the diffuse CD20 positivity and cyclin D1 diffusely positive. So finally patient has been diagnosed as leukemic non-nodal mantle cell lymphoma, but the treatment, by the time we start the treatment, she is already deteriorated, and I will tell you that this is the day 7 of second admission, and she already received the IV steroids and the cyclophosphamide, but pancytopenia was markedly, and clinical deterioration developed severe tachypnea and respiratory failure, and intubation has been advised, but patient family opted for DNR and patient suffered cardiac arrest and expired.
So okay, we'll leave the learning point there. Any questions from audience? What do you think went wrong? Sapan?
Sir, there are so many things in here. I am not able to explain that. One is that transient improvement of leukocytosis and the echo being normal again after 2 weeks, just 2 weeks. So a few theories that we thought could be whether that lymphoma had a secondary infection that might have caused the vegetation, with the antibiotic it might have got improved.
Any other questions from audience? Yes, Ranjan.
Sir, we thought it could be we thought it could be a contaminant from the hospital because it was a mostly 90%. And she received the same meropenem previously also. That again, people will debate that it was a long standing. So since we need to treat the IE for a long time, so whether it is that long course of antibiotic that has worked or it was a transient improvement with the lymphoma.
The first PET scan was normal.
Sir, there was no PET scan done prior.
It was not done.
Only CECT abdomen was done and it was only showing hepatosplenomegaly, no lymphadenopathy.
So fever responded, that's why they did.
Yes, sir.
Okay, Ranjan. I think the alkaline phosphatase at first visit itself was high.
Yes,
you
sir.
have not
Yes,
highlighted,
sir. Yes,
so I
sir.
think that was somewhere the clue
Yes.
at the beginning itself.
Okay, so actually there were lots of red herrings in this case, which should have given you clues. If you see the first bone marrow had immature clusters of cells, we left them there. Because in an elderly lady at 62, if you make a diagnosis of lupus, you really need to think. That's what I'm saying. Lupus was never there in the picture. Never there in the picture at all. Low complements can occur because of liver dysfunction itself. Yeah. Okay, Mohit, let's have the questions for the panelist. So we have 3 questions. So this time, Kavita, you can take 1 and 3. And Raj,
Okay, so I think transient improvement has been spoken by others because of the antibiotic. Some infection was there and that got treated because of the high antibiotic and the improvement was there. What's with strong lupus serology but red flags for malignancy? When do you start? So obviously we should not fall into this serology steroid trap unless proved with tissue diagnosis. There was a large spleen also. So we couldn't really ignore that, immature cells in the bone marrow. So I wouldn't really start steroids unless I'm sure of the diagnosis. There were many things against lupus over here. We should really save steroids till we have a clear diagnosis.
Yeah, I think even if the transaminases had shown some transient improvement, if we don't get the diagnosis, I think because you did a bone marrow initially and somehow it's missed, but later on subsequently, I think if we are not getting the diagnosis, I think we can go ahead and do a liver biopsy, because ultimately we need to save the patient. We have lost her. So I think if that can give the clue, because the lower complements could be because of the liver infiltration, as madam was telling. So that could be sinusoidal infiltration. Because again, it's in a non-nodal disease, it's always difficult to suspect.
Thank you, Mohit. It just keeps us thinking that we are always fallible, despite making so much effort, so many tests. Thank you. So we have the last case now. This is by another Abhishek.
Very good evening, one and all. Today's case will be dealing about a double hit meningitis in a newly diagnosed case of lupus. She's 43-year-old female, symptomatic for a duration of 3 months, with no prior comorbidities, no significant past history, presented to us with the chief complaints of skin rash for a duration of 3 months, fever for 15 days, arthralgias for 15 days, seizure-like activity for 1 day, and altered sensorium for 1 day. She had diffuse skin rash for 3 months, involving upper limbs and lower limbs, which healed with central depigmentation and surrounding hyperpigmentation. Fever for 15 days, which was high grade, associated with chills, arthralgias for 15 days, involving small and large joints of upper limb and lower limb. She had seizures involving left upper limb in the form of tonic posturing, lasted for a duration of 1 minute, associated with uprolling of eyeballs, no tongue bite, clenching of teeth, or urinary incontinence. Post that, she was in altered sensorium for 1 day in the form of drowsiness, not obeying commands, and not responding to attenders. They also gave a history of oral ulcers and alopecia for the last 3 months. On examination, she was ill-built, poorly nourished, drowsy, arousable, obeying commands intermittently. She was vitally stable. CNS examination revealed neck rigidity, Kernicks were absent, power couldn't be assessed as the patient was in altered sensorium, but she was moving all 4 limbs. Skin examination revealed diffuse skin rash involving the periauricular area, nose, and the entire back. It was maculopapular rash with central depigmentation and surrounding hyperpigmentation and present over the entire back, over both arms and the legs. Oral cavity did not reveal any oral ulcers. Pallor was present. This is the diffuse discoid rash over her back. We went ahead with MRI brain plane and contrast 48 hours after the seizure episode, which revealed altered signal intensity involving the gyri of the left frontal, left parietal, left temporal, and left occipital lobes, suggestive of infarcts or post-ictal edema. Her baseline investigations revealed anemia which was predominantly normocytic normochromic, neutrophilic leukocytosis with normal lymphocyte count and mild thrombocytopenia. OTPT were within normal limits, creatinine was within normal limits, CUE showed 4+ protein with plenty of RBC and pus cells. ANA was 4+ nucleolar, DSDNA was positive with titers of 166, C3 was marginally low with cutoff of 90, 89. Her viral markers were negative. We went ahead with CSF examination which revealed an opening pressure of 15 centimeters of water. It was lymphocyte predominant cells, 100 cells, all of them being lymphocytes, protein rich with protein of 153 milligram per DL. CSF Biofair, CSF CRAG and CSF India Inc. showed cryptococcus. This is the CSF staining of the patient, CSF India Inc., CSF APAS and Music Carmine showing Cryptococcus neoformans. So we were dealing with a case of newly diagnosed lupus, immunosuppression naive, symptomatic for a duration of 3 months with diffuse discoid rash in the background of inflammatory polyarthritis with constitutional features, hematological manifestations in the form of anemia and mild thrombocytopenia and probable nephritis and symptomatic cryptococcal meningoencephalitis. She was initially started on 1 mg per kg equivalent of dexamethasone, liposomal amphotericin B 4 mg per kg equivalent and flucytosine 100 mg per kg equivalent divided over 4 doses. But her sensorium continued to be drowsy, there was no improvement in the sensorium and high-grade fevers were present. She developed hypotension and ventilator-associated pneumonia and started on inotropes in view of the same. Lipoamphotericin B and flucytosine were continued, Dexa 1 mg per kg equivalent were continued, and meropenem was added in view of ventilator-associated pneumonia. By day 10, she had persistent high-grade fevers and new onset seizures involving left upper limb and lower limb. She developed bicytopenia in the form of worsening anemia and thrombocytopenia. Possibilities considered were probable drug-induced flucytosine or a macrophage activation syndrome. Bone marrow aspiration and biopsy was done with cultures. Repeat CSF analysis was done considering the fact that she was in persistent altered sensorium, fever spikes were persisting after 10 days of liposomal amphotericin B and flucytosine. By day 12, fever spikes persisted, shock persisted requiring dual inotropes, bone marrow examination was suggestive of HLH and IVIG was started. We considered alternate causes of altered sensorium and a concomitant COX was also considered, considering the fact that she did not respond to 12 days of liposomal amphotericin B and 10 days of flucytosine. Empirical ATT was started, but the patient succumbed and whole body autopsy was performed. These were the investigations in hospital. We went ahead with CSF analysis, which was repeated after 12 days. That the cause was she was having persistent altered sensorium and fever spikes was persisting. It was protein rich, lymphocyte predominant, and CSF Gram-stain in India Inc. grew Cryptococcus, and CSF cultures also grew Cryptococcus neoformans. But the subsequent cultures in the second CSF sample which were sent subsequently grew Mycobacterium tuberculosis. But what was interesting to find that CSF gene expert is negative, and in the second CSF analysis, we went ahead with a more sensitive test, that is CSF gene expert ultra, that also came out to be negative. These were the investigations in hospital. She had anemia, which was normocytic normochromic, neutrophilic leukocytosis. She had worsening thrombocytopenia in the course of hospital, mild transaminitis. PTINR was within normal limits. She went on to develop AK in the due course of time. Her ANA was 4+ nucleolar, DSDNA was 166, C3 was marginally low. Immunodeficiency workup was done, serum immunoglobulins were within normal limits, and lymphocyte subset analysis was within normal limits. APS workup was negative. Mass workup showed high ferritin and high triglycerides, but fibrinogen was within normal limits, but bone marrow was showing evidence of
infection you can't exclude.
Ma'am?
No. These patients, especially when they develop autoantibodies to interferon gamma, they present very late. They can present in adulthood. If you see the series in NEGM, which came from Thailand, and they've clearly shown that if you get these two infections together in adult onset, always think of them. Do you have her, Sira? Do you have stored this sera of this patient?
No, ma'am.
No. Okay. Otherwise, SGPGI is doing anti-interferon gamma antibodies. We could have done it for you. Okay. Any other cases from audience? Yes, please go ahead.
I don't have a case. My name is Maurya. I'm an intern. I just want to know, I just want the panel and you to describe your process of how you convinced the patient and their family for getting an autopsy.
Okay. It's a very relevant question. Yes. So, Abhishek.
They wanted to know the cause of her death. That's persistent altered sensorium. She was not responding and high-grade fevers and cytopenia. And one more thing is the economic burden they had with prolonged hospital stay. That would be waived off with the autopsy. So these two things. They wanted to know the cause of the death. They were keen on that. And their economic burden would also help. The hospital bill will be waived off if we are going ahead with autopsy. That's the reason.
Ma'am.
Yes, Sapan. You give immunosuppression.
Because otherwise the mass was due to the infection.
Rituximab is given to those patients.
That's why we started IVIG, but eventually...
Yeah, but if it's anti-interferon, as she's saying, then IVIG won't help you. On the contrary, you'll have to actually...
Yes, we had some hand from there. Yes.
Ma'am, one more question here. Ma'am, this side.
Yeah, just let me finish. We are going one by one. Or you can shout.
Like, few of my pulmonology colleagues, like we had this difficulty sometimes, like when gene expert comes as negative, they tend to do MGIT sometimes. MGIT sometimes gives a positive, and like when I discuss with my friends in pulmonology, they say that sometimes they slow spot us, sometimes they may not be adequate in the sample to enough to give a gene amplification, but sometimes they turn out to be MGIT positive. Maybe, I don't know, that could be one point to be considered.
Yeah.
And MSMDs could be a realistic possibility.
Thank you. Yes.
Why the patient has initially got cryptococcus at the first place, despite the TLC count is too high and not on any immunosuppression. Cryptococcus is in immunosuppressed patients usually, but despite in the first itself the patient got cryptococcus. So it is very odd thinking of cryptococcus in the initial site. Yes. And what could be the reason the patient?
That is what we are discussing. That is what is the rarity in this case. So one is autoantibodies to interferon gamma. Second is, as Vignesh said, inborn error of
so that could
immunity.
become later in the...
Yes, they can present late also. Absolutely. So can we have the questions for the panelists? So we have 3 questions. So this time 1 and 3 with Rajkiran and second with Kavita.
So in practice, how often do you encounter dual TB cryptococcal CNS infections? Quite rare, especially of this kind. What clinical or laboratory clues should make us strongly? Yeah. So I think because anyway you have diagnosed as cryptococcal in the initial phase and patient is not responding. Maybe we may expect a response between 3 days, 4 days, 5 days. I think that's the time we need to look into the second diagnosis, because in an endemic country like India, TB is always there. And just to answer this, and SLE itself is a disease of immune dysfunction, we know. Very bad SLE presenting itself is a disease of immune dysfunction. Lots of interferon signature, as gamma interferon problems, Th1 defective, and CD8 NK cells won't work properly. So lots of these will help in making these intracellular organisms survive, cryptococcus and TB, and they travel and they disseminate and cause the infections. And 3, in newly diagnosed immunosuppression naive SLE, how could clinicians distinguish between active disease?
Severe infection, which can flare, can look like.
Yeah, I think we look for other clinical features of lupus, because lupus asymptomatic meningitis will also go ahead with other clinical features of lupus, like active clinical features like very bad rash and cytopenias, nephritis, pleuropericarditis. I think we look as a disease, entire lupus. And if these things are not there and isolated CNS problems are there, only meningitis is there, I think we always need to think of infection.
Even the CSF sugar, there was hypoglycemia throughout. That also is usually not so common with the NPSLE or aseptic meningitis. Okay, how should gene expert ultra? So now CSF is a paucibacillary fluid. So even ADA levels actually, how can pleural fluid, it is 30, 35. CSF, the cutoff is 10. Similarly, now Gene Expert Ultra is a very specific test, but you need a colony, a CFU of more than 16 to diagnose it. So if it's less than that, you may not pick up. So if you get it, it's definitely helpful, but if it's not, it can still be TB meningitis.
So thank you. Yes.
So it looks quite logical, but I have something to contribute here in the Expert Ultra thing. I think in Gene Expert Ultra, we actually detect that nucleic acid, the DNA. And in cultures, we look at the bacteria. So what actually I feel is it's in this hematogenous spread. It's the TB bacteria it's engulfed by the macrophage, and it's the dissemination. It acts as a Trojan horse and it travels through that. I think maybe it's, as Madam said, it's a possibulary. They were not killed and the nucleic acids were not exposed. And again, the quantity of like fluid what we send, that also matters. I think if you send lesser fluid, I think it might not pick it up. And I think possibly it's a possibulary thing. It might be living within the macrophage, and it might have been cultured, and it could not have been detected in the Gene Expert Ultra.
So thank you, Abhishek, for a wonderful case. And how much time we have? We have some more time, so if any more questions from audience? Yes, sure. Dr. Singhal.
I just wanted to share a recent, there was a patient he had a psoas abscess. So, the ortho consultant, he was, they did the Gene Expert twice, and, the picture, vertebral involvement and the abscess, everything. And we all have seen TB abscess, so from so many years we are seeing. And in fact, psoas abscess, I hardly remember any non-tuberculous psoas abscess. Many of you will agree with me. So, sometimes I was, called. They were not willing, for whatever reason, to exhibit ATT. The pulmonologist wrote. I wrote twice. Second time I wrote, you call for a meeting, call all these, PATH, everybody. Let's have a discussion on this patient. Then he came and met me. I said, yeah, see, whatever right from my MBBS days till now, whatever, I still remember psoas abscess. I wouldn't even say 9. 10 on 10 I have been seeing is only tuberculosis. Anyway, they started ATT. So this old man, he's 81 years old, and he also had shoulder problem also, shoulder pain. Patient is better. Now what I'm saying, if you, I don't know, this Gene Expert and all, as what you really nicely explained. You very well explained the Gene Expert, that sometimes it may not come positive, and the culture may take time. So anyway, this was my view.
Makes patients of SLE susceptible to infections, or is it non-SLE patients who are susceptible, like immunodeficiency workup?
To be functional antibodies. So functional antibodies are usually seen in elderly, mostly reported from Southeast Asia. They have these opportunistic infections like Cryptococcus, non-tuberculous mycobacteria, salmonellosis, which also can occur in MSMD, which is the inborn error of immunity. And occasional patients with lupus patients can have antibodies to interferon gamma, but occasionally they can also be functional.
Can I add one thing?
Madam?
Yes.
Madam, would you comment on the comparative efficacy between the Gene Expert Ultra and pyrosequencing?
I am not the expert at all, but I can ask Kavita or Raj Kiran if they have any idea on this pyrosequencing versus Ultra Gene Expert.
No idea.
No idea. So we will leave it for Nilesh to comment on that, the brilliant man here. Yes, Raj Kiran has one comment before he lets Nilesh
just
summarize the thing.
Regarding this lupus and HIV, so for the benefit of students, I think because HIV it's more of a quantitative defect of basically the CD8, CD4 or NK cells. And in lupus it's more of a qualitative defect. So the cell count will be appropriate, but the function of CD8, NK cells won't be proper. The perforants won't work properly, then the granzymes won't get entered into that. So the qualitatively they are defective. So this is, I think, one point I would like to.
Okay.
Just one comment. Can I just?
Yes,
so
okay.
The last two cases had very brief illnesses
Absolutely.
of the lupus or whatever the connective tissue disease. And it almost seems as if the infection which was brewing inside, whether it was the gastrointestinal infection in the elderly lady, 65,
Yeah.
which happened twice, or this other patient who developed cryptococcosis, it's almost as if the cryptococcosis made the lupus sort of become evident. It's almost as if
infection
it was
and
waiting
inflammation coexist.
Something like that.
I think they are not separate. They coexist in lupus.
Okay, Nilesh, the floor is yours.
Thank you. I was thinking that you guys keep on speaking and I don't have to summarize. So thank you. I have a very bad throat. I'll probably keep it short, but probably try to inject some humor if I'm able to. So this was a dreary session. Lupus is one disease which I feel that how much ever you try, you are not going to win some battles. And I have been in Nair Hospital for now 3 years, and the one reason I stopped admitting or dreading corporate hospitals is that I had to admit lupus patients, because admitting complicated lupus patients is a nightmare, because every day is a challenge. You lose weight. My family used to know कि नीलेश के अंदर lupus admit है. And my first day in Wokhad Hospital, I had a lupus patient who was CNS lupus, and there was no history available. The notes got available to me 4 days later, and somehow I had to give pulse steroid, and somehow she survived. So lupus is dreary, and this session actually made us realize that particular thing. So I was not aware of what was the role of rapporteur till yesterday. So I messaged on the group and I reached at 3 AM and I saw the reply that what I was supposed to do. I totally missed the meeting which was supposed to be done on Zoom, and I had no idea what the 4 cases were, so I sat down and saw those cases yesterday, and this was very, very difficult. But you know, when Dr. Amita is there and lupus is there, you really don't have to worry. Ma'am has actually, I think, has got better with AIMS Bimbisar and UG exposure. She is getting more livelier. Probably we'll get more snippets from her. And if you really, I think ma'am has been here only for 1 hour, and she has probably spoken like 30-40 sentences. Every sentence is gold, and I really don't know how she does it. I really don't know. I really don't know. Every sentence ma'am says, I think you can frame it and you can use it in clinical practice. Probably I have learned more in this last 1 hour than I in the last whole day. Yeah, so I'm pretty sure the SGPGI people are lucky. I was in Lucknow, so I had an exposure to ma'am, but not probably as much as people who are directly under her. So without wasting time, we were having this 4 people who presented it. There were 2 Abhisheks, one Tejasvi and one Mohit, his Hyderabadi wit, and he did not do much to the gastro people. So he did not insult them much. He was very nice to them. So Abhishek Kulkarni, I think I just saw a patient yesterday referred by Abhishek to me, so it's very fresh in my mind. So Abhishek presented a patient who is proper patient of SLE. The patient had a very florid course of possible sepsis with macrophage activation. And remember that when you are in practice, it's very easy to discuss things, why you did not do this, why you did not do that. But when you are in practice, you are actually limited by a lot of social issues, monetary issues, counseling issues, what pathologies you are having available, what microbiologists you are having available. And with some amazing workup, despite having very high procals, we could come to a conclusion this was macrophage activation because the cultures were persistently negative. The diarrhea symptoms, the addition of tacrolimus, the addition of IVIG to this patient without much response, this biofire PCR of EBV further confused the picture. The learning point here, probably Kavita ma'am suggested that when you have these biofires which are positive, they are very, very sensitive assays. So don't be over-reliant on these biofires where you are suspecting infection. You have to actually see the clinical context. And I agree with that, because in EBV and CMV infections, even most ID specialists cannot really make a conclusive call to say whether this is an active infection or this is just a PCR which is positive. On the basis of this, we saw the H scores which were very high, progressive fall in ESR. There was some argument whether we should have straight away considered mass, but I think the treatment given was in line with what we were thinking, IVIG, steroids, tacrolimus, and no response, and we gave cyclophosphamide and it responded. And as Amita ma'am and Kavita ma'am said, probably that EBV infection is not relevant. There were options of one more drug which probably did not get discussed, was interleukin-1 inhibitor, anakinra. From what I know, it is now can be available within 24 hours. And you can get a per day injection which is around 5,000-6,000. So if you have to really tide over the crisis in a patient whom we are suspecting sepsis with macrophage activation, you can really use this drug because it is relatively safe, and you will be faced with this scenario where you have a relatively not so poor or affording patients whom you are actually seeing sepsis versus macrophage activation or a combination of both, and you will have to consider this therapy because it is still probably cheaper than IVIG, provided which institute you work in. In some institute IVIG is free, but again, this is one option when you are not sure of whether you are dealing with infection. Fortunately, this patient responded to cyclophosphamide, and rituximab was an option in this patient. Then we went on to presentation by Tejasvi, very fiery presentation. She could actually accommodate 4 lupus biopsies in the time allotted to her, and it went from class 4 to class 2 to class 4 to class 3+5. And we know that straight away triple therapy is the flavor of the season, and almost all guidelines are coming with. But I think we have to be pragmatic of what we do in India. We don't have that much wherewithal to actually diagnose and treat infections, so we have to be careful. The patient received almost everything which is available in India, including obinutuzumab, which is not cheap. Obinutuzumab, from what I understand, really works in lupus nephritis where they don't have very significant proteinuria. By the time she was having the 4th biopsy, the proteinuria was very high, and there was not much extra renal symptoms. In such cases, you have to optimize your SGLT2 inhibitors, your ACE and ARBs. There are 2 new classes of drugs which are going to come in the future, or probably already there. There's a mineralocorticoid receptor agonist, and one is GLP-1 agonist. We have to look into data in the future. From what I know, there is a randomized control trial of SGLT2 inhibitors going on in India in PGI under Dr. Manish Rathi. Let's see what that data shows. But this lupus nephritis case really shows us how difficult it can be to treat this patient. Probably in these patients, ma'am said, what will you have tried? You will have tried leflunomide, cyclophosphamide, and bortezomib, suspecting plasma cell subset problems, and even leflunomide. But probably nobody will have thought of igaritumod. Maybe it's serendipity, maybe it's event by chance, maybe it's something patient's body wanted and it got better, but we probably need more trials on that, and that's a case probably which we can discuss with our nephrologist to start randomizing patients to give igaritumod and see, because I think it's a very well tolerated drug, but we really don't know whether it worked in this case, but we'll probably keep it for a try in such patients. Voclosporin is one drug which probably could have suited here and which is not available in India, but probably that could also be given a consideration, especially if the patient had class 3 plus class 5 with almost nephrotic range proteinuria. I have one patient who has had now 3 biopsies. She's in UK right now, and she has been offered voclosporin. She has received cyclophosphamide, rituximab, mycophenolate, tacrolimus, and still hovering around 7 grams of proteinuria. And I probably told her that you should go ahead with voclosporin since you are in UK and you are being offered that drug, and hopefully that should respond. Mohit presented a case where you can argue whether this was an SLE or not an SLE. I was trying to squeeze in some immature questions to ma'am in between the lectures and in cases, and ma'am was clear that this doesn't look like SLE because there was a lot of leukocytosis, there was fever, the antibodies could be just coincidental, the progression was very rapid, and there was immature cells in the marrow. These are all red flags. So the problem with us rheumatologists is for most of our things we don't have biomarkers. we have to use something which is between the ears, and that is sometimes very difficult to use, especially when there are other specialties involved. Because you have to try to explain them that this is not lupus, but they will say na ANA positive hai, Smith antigen positive hai, DSJNA positive hai, this is lupus, you immunosuppress, and it's always a fighting game. So Mohit circumvented that very well, and somehow we could diagnose the patient, but we could not actually make a difference to the patient's ultimate outcome. But the red flags were very evident. The patient did not have any features of lupus, though there was a strong family history. There was significant leukocytosis, there was bone marrow with immature cells, there was persistent fever, high ALP. If the patient had already received steroids, maybe a PET scan would have not revealed things. So again, all these three cases are actually making you think that whenever you are not getting the appropriate response or anything which is not fitting into it, don't try to fit the disease into that particular investigations. Try to question the validity, try to recheck what have you missed, and always start writing it on paper or making a PPT and rediscuss, and probably ask your seniors what you are missing. Then Abhishek again presented on double hit meningitis in new onset lupus, and this case was a revelation in the sense that the patient had cryptococcemia, cryptococcal meningitis, and also grew mycobacterial tuberculosis. And probably this concern was raised by both Dr. Vignesh and Dr. Amita ma'am, that probably there was some kind of inborn error of immunity or acquired autoantibodies to interferon gamma, which may have resulted, because frankly speaking, it's very, very rare for a new onset lupus without having received immunosuppression of any sort, without having lymphopenia, to develop these two opportunistic infections. And if we had the sera, we could have probably looked into it, but unfortunately we don't have it. And I think the only intern in this forum did ask a very pertinent question on how did they manage the autopsy, and which is very, very important, and even the autopsy confirmed that particular things, and which was very relevant, because sometimes in these patients, without actually doing autopsy, we are always thinking whether we missed anything else, but the autopsy also reconfirmed those things. There was a discussion on what is the difference between gene expert, I don't know what is pyro sequencing different, but gene expert and ultra gene expert, the difference is that ultra gene expert can detect very, very low loads of mycobacteria. The sensitivity can be as high as 7 to 10 times. So probably if this can detect around 180, 190 colonies, probably this can detect around 16 to 20 colonies. The problem is specificity. So if you have a trace positive or even a strong positive on gene expert ultra without the right clinical context, ultra sensitive PCRs have that problem. And also if you have trace positivity, the rifampicin resistance cannot be relied upon. So these are the problems with ultra gene expert. So use it in the right clinical context. And the question was raised whether the sample was adequate, and some theories to whether this sample adequacy can also play a role. And ultimately culture is the gold standard. I also looked up on what percentage of people can be gene ultra expert negative and still have culture positivity. It depends from fluid to fluid. So probably in smear positive cases, this should be less than 1%. The gene expert will be negative in less than 1%, but in pleural fluid, it can be negative in 20 to 40% of the cases, and it can still grow mycobacteria. So don't be surgeons, be rheumatologists, send the proper sample, send cultures, always send proper tissue sampling. The one thing I make sure before sending the tissue is write all the investigations I want before sending the patient for aspirations or biopsies, because those who are doing aspirations are unaware of what we want, and it's better to write the patient and give them and ask them to go to a desired lab if you want the desired result, otherwise you won't get the sample again. So I hope this is it, and I have summarized everything for you, and I sincerely wish you none of us get any of these cases in our life forever, and we continue to see plain vanilla rheumatoid arthritis with 6 swollen joints who respond to 5 mg of omnacotil and call us gods. Thank you.
Thank you, Nilesh. So we have had a wonderful session. So I think everybody has woken up in the lupus session, and all the 4 students did exceedingly well. Everybody has scored more than 80%, but obviously you have to find a winner. And The person who got the maximum is the last case, where we... So Abhishek from Nizam Institute, he scored the maximum. So all the best and congratulations. And if you have any more questions, we can still take up. We have more time because we kept, still there are 15 more minutes. So that shows we have been precise and concise. So I only have one question for Abhishek, who has got the maximum score. Did the autopsy show any granulomas? I mean, we are just going by this culture report. Did it have any evidence? Did you do brain autopsy?
Yes, ma'am.
So did it show anything to suggest TB meningitis?
Granulomas were not there.
We have to have some pathology attributable to the organism to say that that contributed to disease. Otherwise, how do we say? Cryptococcus, you could show there. You could see cryptococcal abscesses. You could see everything. But where is the mycobacterium causing anything?
Histological response we couldn't find, ma'am, in the bone marrow or in the brain. But
So
this vasculitis part, like those infarcts or this thing.
Those will occur much more in cryptococcus than in TBM.
Yes.
So when autopsy doesn't show that, I will be very, very skeptical of that culture report. What? 80% reduced to 67%. No. I'm just asking, because this point came to my mind after we were discussing autopsy. Rajkiran, yes.
Ma'am, can the defective Th1 response or the defective gamma interferon, these things, can it explain the poor granuloma formation? Because if someone has a poor immune response, initial immune response to TB, because the granuloma formation might not be there, it could be a primary infection and later on dissemination.
So the question in those patients is, they are teeming with AFP. If your body is not responding to mycobacteria like HIV patients with immune deficiencies, they have lots of TB bacteria. This person you are finding not on ultra, you're finding on culture. His cryptococcus is everywhere. He has blood culture positive for cryptococcus. His cryptococcus is there in the autopsy. His cryptococcus is there in the CSF. Why are you not finding mycobacteria? I am absolutely skeptical of that culture report now.
Do you have the histopathology report after the autopsy?
We didn't find anything of TB. Yes, we didn't find granuloma. But both the antemortem and postmortem CSF cultures grew MTB. Like we had discussion with the ID team as well. They said that for not all cases will have a histological response. So that was the thing. And we are
This is my way of thinking. It may be wrong. Absolutely. Yes, Apan.
So I had once a neuropsychiatric lupus case with similar CSF AFP showing positive, and I was very skeptical. And as happens, unfortunately, he was the sister of a very eminent income tax officer. My neurologist friend said the same thing. He said, you forget the AFB. This is neuropsychiatric lupus. I gave cyclophosphamide, the patient actually improved. I followed up with 3, and it was probably never TB. And she's still living and she's fine. He still continues to send me Christmas cakes, So.
Yes, Subramanian. In medicine, there is nothing of legality. What you want to do is in the interest of the patient. What fits in? Like you said, you discard those ANA reports. As Nilesh was saying, anti-SMs, everything. People keep telling us, you negate them, no? Same way, sometimes you negate a mycobacteria report also. We can have people who have to tackle those kind of issues. I have never had those kind of issues to be tackled in my life.
In private, keep yourself safe first. It's okay. 4 AKT drugs will not make any harm for 9 months. But if there is really TB, it will make your life difficult. So in private practice, I think don't try to become a hero. I think it's always good to tell patients what you are thinking. I have had times when 3 prominent ID specialists have said that this is TB, and I've said no, this looks like a macrophage activation. But I'm giving you an option. You want to try AKT first, or you want to try steroid first, and patient has chosen steroid first. But I have taken it in writing that it may still develop TB, but there was no evidence of TB, and then we went ahead. So you have to be clinically very sure, but don't get into battles which you cannot win. And when you are taking decisions, always make sure where the patient is inclined towards, because sometimes in our nephrology department, they just don't want to listen to what we want to give. And it's like they are doing the biopsies, we don't have the wherewithal to do, so we don't really argue much. And when they get complicated, they send to us. We try to help. This is how life operates. Yeah, you don't have to become.
You can't be dogmatic. Absolutely. And patient consent is the most important. You have to tell the patient that we are not treating this for these reasons. If patient wants, you will treat it, definitely. Patient is the king, always.
Ma'am, here. Any one question.
Okay, fast.
Montu or IGRA in this case, if you're really thinking of TB, did you done any Montu or IGRA?
IGRA is not a good test for diagnosis.
No, it just even shows that whether it is latent
WHO has
or
also
active.
said it should never be used for diagnosis of TB.
Despite we have not gone for a histopathology as such to prove it is a TB.
No. You cannot.
So either or, whatever it is, Montu or IGRA, in this case can be helpful because the culture actually shows TB, so we can say that it is because of TB. But that is the supporting evidence, that's what.
No, we didn't do Montu or IGRA. Yeah, probably IGRA may not be helpful for diagnosing TB, but it could be an indirect way of assessing anti-interferon gamma antibodies. Because if you do a quantiferon TB, if there is a neutralizing autoantibody to anti-interferon gamma, you will get an indeterminate result. Even the positive control will not yield a high interferon gamma response. So that is comment number one. Comment number two, I think if you have the DNA, it is worthwhile doing a whole exome sequencing because you can screen other family members and that would have implications for others.
I think now we can close the session. I hope everybody has had their fill. Thank you. Thank you for actively participating.
I call upon the chairpersons to announce the pre-winners.
I think we had an excellent pediatric rheumatology session. All 4 cases were very well presented. All candidates scored above 70%, but the winner is Dr. Vimal Manekshaw from KIMS Hyderabad. I have already announced IBD for heart disease. I have announced the winner. Oh, they want me to announce again Abhishek from Nizam Institute.
For the inflammatory myositis and the inborn errors of immunity session, I think it's Dr. Ranjan Gupta from AIMS.
So I got to tell a small story. Ranjan Gupta, he called me, Sarath, can I present this? I told him, in this platform, resident, consultant, professor, everyone is equal. This is the platform for all of you guys, irrespective of the level. Everyone is equal here. Thank you. We are lucky to have you here. Now the next session is rheumatology quiz for the DNB trainees and fellows. Now I call Dr. Ramya and Dr. Neeladri. Not here. So she's going to.
Dr. Mohit will be assisting.
Okay. And this is you're going to tell the rules? Yeah.
This year we are going exclusively everything to digital. So I will ask you to open your phones and scan the QR code. Zoom, sir. Oh, zoom out. Okay. Can you? If anyone facing difficulty with scanning, just let us.
The top 3 winners will be awarded, and the first one will get the CRC trophy. We'll see who gets this. All the best, guys.
Only the residents will be eligible for the prize, not the consultants.
But
Yeah, young guys are very intelligent. We can't compete with them.
so I will read out the instructions. So after scanning the QR code, you'll be seeing a Google form with you need to fill the details. Please enter your mail ID and the name. Then each participant is allowed only one entry. Multiple entries will be disqualified, and questions will be 30 questions will be displayed on the screen, and you need to enter in the Google form. And all questions should be answered in sequence, and do not submit the Google form until the 30th question is displayed. And early submissions will be disqualified. So I hope you have a great time.
All the best. And the first question is, complement pattern in cryoglobulinemia type 2. A, low C3, normal C4, normal C3, low C4, low C3 and C4, and option D, normal complement. Question number 2. The strongest genetic association for Vexus syndrome. This is an easy one. Somatic mutations in UBA1P MET41. B, germline gain of function mutations in UBA1. Somatic mutations in DNA SC1L3. X-linked germline mutations in UBE2A. Question number 3. Which cytokine is most central to SAVI pathogenesis? Interleukin 6, option B, interferon beta, C, interleukin 1 beta, and option D, TNF alpha. Question number 4. Which 2 collagen genes are specifically hypomethylated in diffuse cutaneous systemic sclerosis? Col1A1 or collagen 12A1, collagen 8A1, collagen 29A1, option C, collagen 4A1 and collagen L15A1, or option D, collagen 12A1 and collagen 14A1. Question number 5. Which trial in 2024 demonstrated that benralizumab is non-inferior to mepolizumab for treating EGPA? Question number 6. Which of the following statements about icotrokinra is true? Icotrokinra is an oral interleukin 17 inhibitor. Option B, it reduces interleukin 23 levels indirectly. Option 3, it reduces interleukin 17 levels directly. Or option D, it's an oral IL-23 inhibitor. Name the test performed in the image. It's Fallon, or Durkin, Tinel, or Allen. Clinical rheumatology. Question 8. What drug was recently FDA approved for use in adult patients with idiopathic pulmonary fibrosis? Rofamilast, ziritaxestat, nerandomilast, piclamilast. Question number 9. Drugs to be avoided in breastfeeding except voclosporin, colchicine, apremilast, avacopan. Number 10. According to EULA 2025 recommendations for management of lupus nephritis, the following combinations can be used for active lupus nephritis except mycophenolate with belimumab, mycophenolate with voclosporin, mycophenolate with obinutuzumab, and D, mycophenolate with rituximab. It's except. Eleven. Which of the following manifestation gets the highest weight in the new EULA disease activity score in antiphospholipid syndrome? Digital gangrene, livedoid vasculopathy, pulmonary hemorrhage, arterial thrombosis in 2 territories. Number 12. In Dahlia's trial, which was evaluated for nipocalimab for the treatment of which condition? Systemic lupus erythematosus with active nephritis, rheumatoid arthritis which was refractory to JAK inhibitors, moderate to severe primary Jogren syndrome, or option D, ANCA-associated vasculitis. So this is a muscle biopsy slide which is consistent with muscular dystrophy, polymyositis, inclusion body myositis, or immune-mediated necrotizing myopathy. Telitacicept's dual inhibition targets which 2 B cell growth factors? BAF and IL-6, BAF and April and IL-17, IL-23 and BAF. Number 15. Which of the following statements is correct? Anti-SP4 antibodies are associated with immune-mediated necrotizing myopathy and severe statin exposure, or anti-CN1A antibodies are highly sensitive and specific for inclusion body myositis and predict good steroid response. Option C, anti-SP4 antibodies have been linked to increasingly malignancy risk and anti-TIF1 gamma positive dermatomyositis, or option D, anti-CN1A antibodies are primarily associated with rapidly progressive ILD in clinically amyopathic dermatomyositis. Question number 16. The census trial established the efficacy of nintedanib in systemic sclerosis associated ILD by demonstrating a significant reduction in which primary outcome? Improvement in FVC percentage, which was predicted at 52 weeks, reduction in annual rate of decline in FVC, option C, improvement in MRSS skin score, or option D, reduction in all-cause mortality. Question number 17. Which metabolic abnormality is classically linked with early onset CPPD disease? Hypercalcemia, hypomagnesemia, hyperuricemia, hypophosphatemia. Question number 18. Which clinical factor is not included in FRAX calculation? Prior fragility fracture, parental hip fracture, dose of glucocorticoids, rheumatoid arthritis. Number 19. Fircicabart, a newer agent investigated in gout, showed superior prophylaxis against acute flares compared with which standard therapy? Allopurinol, colchicine, probenecid, or an NSAID. Number 20. According to KDIGO 2024 guidelines, plasma exchange should be considered in which situation? Anti-PR3 ANCA-associated vasculitis with ENT disease, anti-MPO associated vasculitis with EGFR 55 and subnephrotic proteinuria, ANCA-associated vasculitis plus anti-GBM overlap syndrome, any DAH regardless of oxygenation. Question number 21. Which trial tested type 2 anti-CD20 monoclonal antibodies in active lupus nephritis? BLISS-LN, Aurora 1, Regency, Rituximab. This is an X-ray image of a patient with progressive joint pain and stiffness, which is the most likely diagnosis. JIA, pseudoachondroplasia, Morquio syndrome, or pseudorheumatoid dysplasia. Number 23. Which one of the following is a major concern for using tocilizumab in GCA patients? Severe osteoporosis, diverticulitis, hemolytic anemia, retinal vasculitis. Number 24. Which toll-like receptor is most directly implicated in RNA immune complex recognition within plasma cytoid dendritic cells in lupus? Toll-like receptor 3, 7, 4, or 11? The NLRP3 inflazome promotes inflammation primarily through activation of which cytokines? IL-6 and TNF-alpha, IL-12 and IL-23, IL-1 beta and IL-18, interferon alpha and interferon gamma. Hyperechoic linear deposits within hyaline cartilage on ultrasound most strongly suggest gout, CPPD, RA, septic arthritis. Which among the following is the skin first DM? Anti-NXP2, anti-SAE, anti-MI2, or anti-MDA5? Skin first DM. Number 28. A 19-year-old male with digital clubbing, genetic analysis revealed impaired degradation and transport of prostaglandin E2, leading to its accumulation. Which pair of gene mutations is most strongly associated with pathogenesis of this disorder? MEFP and TNFRSF1A, HPGD and SCLCO2A1, option C, FBN1 and TGFBR2, option D, STAT3 and DOCK8. If you know what is the image, then you will be knowing the genes. Question number 29. Which among the following is not a feature of Erdem-Chester disease? Hairy kidney, MAP2K1 mutation, BRAF V600E mutation, CD68 plus, and CD1A minus. The last question. All of the above are treatment options after discontinuation of denosumab except alendronate, zoledronic acid, ibandronate, teriparatide. As few of them were not available, I'll be repeating the first 5 questions again. Complement pattern in cryoglobulinemia type 2. The strongest genetic association for Vexus syndrome is which cytokine is most central to SAVI pathogenesis? Which 2 collagen genes are specifically hypomethylated in diffuse cutaneous systemic sclerosis? Which trial in 2024 demonstrated that bendalizumab is non-inferior to mepolizumab for treating EGPA? Question number 11. Someone was asking for it. I think I'll end the quiz now. You can all submit your responses. Once we get the final response sheet, I'll display all the answers. Only if you answer all the 30 questions, it will be submitted. The response will be calculated. It is moderate to severe primary Sjögren syndrome. This is very easy, inclusion body myositis. You can see all those inclusion bodies. This teleciacept is B, BAF in April. Question number 15, it is answer C, anti-SP4 antibodies, which have been risk to malignancy and also Tiffin gamma positive dermatomyositis. Yes. Decreases, sorry. That's a wrong question, I'll display. So we'll calculate for 28. Question number 16, it is B. Reduction in annual rate of decline in FVC. Early onset CPPD, it is hypomagnesemia. And this is dose of glucocorticoids. It's colchicine. It is ANCA-associated vasculitis with anti-GBM overlap. Answer? Regency, yes. This? Pseudorheumatoid, yes. This? Diverticulitis. 7. Yes. CPPD. SAE. Anti-SAE skin first DM. This? Yes. It is B. Yes. MAP2K1 is for Rosette Hoffman. Both are together, so I just switched the genes. This teriparatide, yes. So both have, but pulmonary hemorrhage carries a higher weightage, so that's a closer picture. So we have, I didn't. Yeah. Yes. So we have 3 residents who have scored the same score, that is 24 out of 30. One is Baishaka Swaim from Hinduja, Nandita from CMC Vellore, and Lovely Kumari from Jipma. You please, 3 of you, please come to the front row.
Just please wait. A small announcement. We have a dinner in Marigold. Please join us for the gala dinner tonight. So there is a confusion. Someone without knowledge, someone else is hosting dinner. But for all the delegates and all the faculty, we are hosting a dinner, gala dinner in Marigold. Please join us at 7:30 today. Thank you. And please be on time tomorrow morning, 8 o'clock sharp, if you want to catch your flights on time. You have anything to announce, Vinod?
Just a small vote of thanks at the end of the day. And I think, as I have, you also must have enjoyed the academic session on time. And thanks to all the chairs, all the panelists, and the rapporteurs, and all the delegates, because it's the delegate engagement which makes the conference a success. So as Dr. Shara said, be on time tomorrow morning and have a great evening. We look forward to welcoming you at the Marigold. Thank you. And sorry, so we had about 300 in-person attendance today, which I think is very, very encouraging. Thank you.
And please collect the group photo from outside. They're available in the stall. So Ramya, over to you. Ramya, take over. So anyone want to share their first time experience? Anyone first time here? This is mainly for the trainees and the young rheumatologists, this platform. Yeah, you can share while we are waiting for that program.
Thank you for inviting me. Good evening, everyone. My name is Maurya Patel, and I am an intern at NHL Municipal Medical College, Ahmedabad, the same as Dr. Sapan Pandya. And the first conference I attended for rheumatology was IRACON, and I had a lot of fun there, which is where I discovered that CRC was being organized. And I was introduced by Sapan sir that it is a case-focused conference, and it will be very interesting. So that's how I was motivated to submit a case. The cases admittedly are a bit difficult to follow because I don't have the context of the lecture that precedes usually, but it's interesting nonetheless, and I enjoyed the quiz as well. So thank you so much, everyone.
Which of the following is true about Sjogren's syndrome? Stimulated whole salivary flow is recommended as a part of evaluation of oral Sika. Extra questions. Major salivary gland ultrasonography is more sensitive and specific than minor salivary gland biopsy for diagnosis of Sjogren. There are no histopathological differences in minor salivary gland biopsies between seropositive and seronegative patients, and IGRF is a poor prognostic factor for patients with Sjogren's. Next. Bimekimuzumab is a novel monoclonal antibody approved for the treatment of psoriasis and psoriatic arthritis. Which of the following cytokine isoforms are stimulated simultaneously neutralized, contributing to its enhanced clinical efficacy? Anti-IL-17A and IL-17C isoforms, IL-17B and IL-17F isoforms, IL-17A and IL-17F isoforms, anti-IL-17A and IL-17B isoforms. And the last question, all are true about endo-MT except the process can be induced by TGF-beta and endothelin. Epithelial cells lose markers like VE cadherin and express alpha SMA, vimentin and type 1 collagen. It leads to vascular remodeling and fibrosis in scleroderma. The process is stimulated by inflammatory mediators. So the winner is, for the Sjogren's syndrome, it's option D. And for the bimekizumab, it is C. And last question, it is B. So the winner is Dr. Vishaka Swain from Hinduja. So now, there is one more tie between Dr. Nandita and Lovely Kumari. I'll read out the question, okay? Okay. Question number 1. In the oral surveillance trial, JAK inhibitors showed higher risk compared with methotrexate, IL-6 inhibitors, abatacept, or TNF inhibitors. A patient with proximal muscle weakness and spontaneous pneumomediastinum on CT is most classically associated with which autoantibody? Anti-Jo1, anti-TIF1 gamma, anti-MDA5, anti-NXP. Muscle weakness and spontaneous pneumomediastinum. And the question number 3, the strongest predictor of future pulmonary arterial hypertension in systemic sclerosis is reduced DLCO out of proportion of to FVC, anti-SCL70 positivity, interstitial lung disease, Raynaud's duration. Options again. Reduced DLCO out of proportion to FVC, anti-SCL70 positivity, interstitial lung disease, Raynaud's duration. So again, you both answered the last question wrong, that is oral surveillance trial of JAK inhibitors, which showed higher risk in comparison compared to, you answered methotrexate, but the answer is TNF inhibitors. So we will declare again few questions, or should we declare?
Now the toss.
Now the toss, okay, we'll play toss like how we not so such.
Anybody has a coin?
Or any further last question?
Ask one. Fastest fingers first.
Fastest finger. Right, done. Well. I knew everyone would answer. That's why I bought a lot of more questions, more 10 or 20 questions. Done. Which drug was studied in mitigate trial? Inebilizumab, lanalumab, obinutuzumab, or rozanolixizumab? Done? You can tell their answer. It's inebilizumab, option number 1. Wrong, huh? Second. Who answered? One more. One last question. You can tell the answer. No issues. IL-6. Ifgaritigimod is a IL-6 receptor blocker, FcRn blocker, BAFF inhibitor, or anti-CD40 L monoclonal antibody. Ifgaritigimod. Yes, that's the answer. FcRn receptor blocker. She's second and she's third.
So that
First is Baishaka Swain, second is
can you stand up?
Lovely Kumar, Jipmer, and third is S. Nandita.
Can you stand up? Number 1, who's number 1?
Baishaka Swain.
Vaishaka? Vishaka Singh. From one? From where? Hinduja. Congratulations. So you win the first trophy of CRC 2026 Rheumatology quiz. Congratulations once again. And second place, Avali Kumari from JIPMA. Congratulations. And the third winner, Nandita from CMC Vellore. Congratulations, Nandita. So we will give the prizes tomorrow. Now combining all the sessions, we have a prize session tomorrow. Yeah, please be there. Yeah, please join us for the gala dinner. Congratulations, all of you again. I hope you enjoyed the conference today. Thank you. Good night.
Okay.